Yes, sir. Good morning, Anurag.
Good morning, sir.
सुनाई दे रहा है?
Yes, sir. सुनाई दे रहा है.
Very good. अबे Bluetooth रो
Can you hear me, sir, clearly?
Yeah. I can hear you. अच्छा सुनो,
Yes, sir.
अनुराग,
बोलिए sir.
एक काम करेंगे.
Sir.
Okay. One question. Bluetooth off. Forgot to tap to turn 10% of it.
Sir.
Sir, excuse me, sir. Good morning. We are on live.
Okay. Okay. I think you will appear and disappear in this. I'm calling you up.
Sir.
Yep. Asit, can you hear me?
Yes, sir. Yes, sir.
I suggest if someone log in with two devices at a time, so I suggest each mute one device, otherwise it will be echo. Thank you. Good morning. I request to all presenters for session 1, please on your camera. Thank you.
Good morning, everyone. Good morning, everyone. Myself, Dr. Swamprabha Sil, on behalf of Scientific Committee.
Yes, Dr. Swamprabha, we can hear you. We can hear you.
Good morning, everyone. Hello. Myself, Dr. Swamprabha Sil, on behalf of Scientific Committee 19th Fiji Convention 2021, which is being held on this virtual platform. So, hope all you are doing well in this pandemic. So let's begin our first session. The chairpersons are Dr. Anurag Satpathy, Professor from Department of Periodontics, Institute of Dental Science, Bhubaneswar, and Dr. Deptati Mohanty, Reader from Department of Periodontics, ACB Dental College and Hospital, Cuttack. Sir, have, sir, we have to adhere to the strict timing as it is being held on this virtual platform. Sir, after 8 minutes, the presenter video has to be started, followed by 2 minutes of question answer session. So let's begin our presentation. Title of presentation is Root Coverage Procedure for Management of Multiple Gingival Recession, a case series by Dr. Mayuri Raje. So, sir, may I invite our
Greetings, respected judges. Today I am going to present case series on management of multiple gingival recession. Gingival recession is the apical shift of the marginal gingiva from its normal position on the crown of the tooth to the levels of the root surface beyond the cemento-enamel junction. The term marginal tissue recession is considered more accurate than the gingival recession since the marginal tissue may have been alveolar mucosa. The prevalence of gingival recession ranges from 20% to 100% in adults. Moscow and Bressman in 1966 gave variety of etiologic factor, which was again modified by Aldrin in 1968. Consequences include the hypersensitivity, then the plaque retention and the gingival bleeding, caries, and hampered aesthetics. Treatment modalities include the non-surgical and the surgical treatment. Now, the surgical treatment consists of the pedicle soft tissue grafting procedures, pre-soft tissue graft, and the evolution of the surgical technique. The coronally advanced flap is a common approach for the root coverage, which was first introduced by Norberg and has been witnessed various modifications since then. Tunneling technique was introduced by Zebelgue in 1999. The unique characteristic of the tunneling procedure is that the interdental papillae are left intact. Zucchelli introduced modification in the coronally advanced flap for isolated as well as multiple recession defects. Vestibular incision subperiosteal tunnel access VISTA technique was proposed by Zade in 2011, can be utilized in single as well as multiple recession defects. Zure demonstrated that the microsurgical tunneling flap procedures are associated with more favorable clinical and post-operative patient-reported outcomes. Limitations of the tunneling access technique include the technically challenging nature of the intracellular tunneling and the increased risk of traumatizing and perforating the cellular tissues, potentiating the possible unfavorable healing outcome. Some of these limitations encountered in the intracellular tunneling technique can be avoided by VISTA technique. Moving on to case 1, in which Zucchini technique with PRF is utilized. These are the preoperative pictures showing the recession depth and the recession width. Then the measurement of the keratinized gingival width was done. Then the measurement of the biotype, gingival biotype with endodontic file was done. Then highlight of this technique, which is the paramarginal oblique incision, were given. After that, flap reflection, which was full split thickness, was made. Then the stabilization of the PRS taken from the patient was done. After that, the suspensory sutures were placed. The patient was followed at 10 days, and after that, 3 months. Then the second case is the VISTA technique using PRS. So these are the preoperative pictures showing the vestibular, showing the recession depth and the recession width. Then the vestibular incision is given. After that, the vestibular incision is extended in the form of tunnel. After that, the stabilization of the PRS is done in the tunnel. Then the curing of the sutures was done with composite. Again, the highlight of this suturing technique is the coronally anchored sutures. They minimize the micromotion, thus helps in improving the healing outcomes. Then the patient was seen after 1 month for follow-up. Now, the next technique is the VISTA technique with CTG. So these are the preoperative pictures showing the recession depth and the recession width. Then the vestibular incision was placed. After that, the tunnel was extended. Then we have harvested the CTG from the palatal donor side. Then we have stabilized the CTG in the pipette tunnel. After that, the coronally anchored sutures were placed, and this picture shows the post-operative 3 months follow-up. So all these 3 cases shows predictable outcome for the treatment of the gingival recession. Moving on to discussion. So the first case which we have seen was the Zucchilis technique. So this technique utilizes full split approach, which permits to maintain the maximum soft tissue thickness above the root exposure. This technique guarantees adequate coronal advancement, good anchorage, ample blood supply to the surgical interdental papillae, maximum soft tissue thickness in the central portion of the flap covering the avascular root surface. The next 2 cases which we had seen were the VISTA approach. So this is in this case, in this technique, the access is broader and it's made in the vestibule, where the single incision can provide access to the entire region. One of the major obstacles to the regenerative healing is the micromotion, which promotes the formation of the scar tissue. This is also minimized in the VISTA technique by using the coronally anchored sutures, which has proven to be the major advantage of the present technique over the conventional methods. Next, we have used this gold standard, which is the CTG, which has predictable outcomes, and this is proven by the various systematic reviews. Major advantage of CTG are that it is inexpensive, versatile, and easily available. It provides successful outcome in it is less invasive, and than the other autologous harvesting techniques. Graft has dual blood supply. It has shorter healing period, but we have noticed that we have noticed through the literature that it has potential patient-related morbidities. So the other innovation which can be used is the PRF, which is the concentrated suspension of the growth factors found in the platelets. The clinical and the histological data reveals that the PRF is a therapeutic approach would be an encouraging medium for the improvement of the soft tissue healing and regeneration, and it is therefore incorporated in the treatment of the multiple gingival recession. So we can conclude that the management of gingival recession and sequelae is based on a thorough assessment of the etiological factors and the degree of the involvement of the tissues. The multiple adjacent recession type of defects present a challenge because most of the limited, mostly it has limited tissue availability and post-harvesting morbidity is magnified. Also, several recessions must be treated at single surgical session to minimize the patient discomfort. This challenge can be excelled using recent modifications for the treatment of the multiple gingival recessions like the Gillis technique and the Vista approach. This predictability of the technique can be enhanced by combining them with additives like PRS and CTG. That's all for today. Thank you.
Yeah,
Thank you, sir. Thank you, Anurag sir. Thank you, Devpratin sir. Sir, our next presentation will be by Dr. Rasmi Bhamare, and it will be if you
Dr. Swayam Pragya, just
okay, sir.
one.
Sir, now it is question and answer session. Sorry,
Yeah.
sir. Sorry, sir.
Dr. Devpatum sir, yes. Your speaker is muted, sir.
Yeah, you go ahead. You ask.
Yes, sir. Good morning, Dr. Mayur Rajan. Good presentation.
Good morning, sir. Thank you,
Good
sir.
morning. Okay, so you have wonderfully compared the techniques. So can you highlight what is the one major disadvantage of Vista technique over Zucchini?
Sir, actually, it is very much technique sensitive as the interdental papilla, we have to go through the tunnel. So it might be exposed, like it might get exposed due to technicality, and also the frenal, also the vestibular pull, when the patient masticates or when the patient do movement, it might affect the coronally anchored suturing. So it might overall affect the predictability of the technique.
Okay. Given maxillary and mandibular, which one do you think is more preferable to go for a Vista, or both are equal?
Sir, according to me, I think maxillary region is better, since
Why?
the frenal pull is more in mandibular region most of the time.
Okay. Sir? Yeah. Depatim, sir? Okay.
No, nothing.
Okay. Thank you. Thank you, Dr. Rajan.
Thank you, sir.
Thank you. Good luck.
So when start next.
Thank you, Anurag sir. Thank you, sir. Sir, our next presentation by Dr. Rasmi Bhamare, and the topic is effective diode laser assisted flap surgery on post-operative healing and clinical parameters.
Good morning. My case series is to assess the effect of diode laser assisted flap surgery on post-operative healing and clinical parameters. Currently, chronic periodontitis is the most prevalent oral conditions worldwide. It is basically an inflammatory process that affects the protective and supportive tissues around the teeth. The major etiology responsible for periodontitis is of microbial components, post-inflammatory responses, and environmental factors. The basic goal of periodontal therapy is for disease prevention, slowing or arresting disease progression, regeneration of lost periodontia. The presence of root concavity, furcations, and developmental grooves exhibits incomplete removal of bacterial deposits and toxins by using conventional non-surgical method, hence necessitating these surgical interventions, that is by utilizing flap surgery. Flap surgery is indicated for deeper pockets, which results in the reduction of probing depth and clinical attachment loss. Various treatment modalities have been discovered for periodontal therapy. One such novel technique is use of diode laser for periodontal therapy. and reduction of periodontal pockets. The first use was given by Mainman, and the periodontal use was founded in 1997 by Morris. Basically, diode laser is a soft tissue laser which lies in the wavelength of 810 nanometers to 910 nanometers. Now, diode laser assisted periodontal therapy helps in achieving excellent hemostasis, sterilization of the incision, lesser post-operative edema and swelling, and it targets the surface area. So the aim of this presentation attempts to highlight management of periodontitis by showcasing cases depicting the noteworthy results achieved by utilizing diode laser as an adjunct to mechanical debridement in the flap surgery. Coming on to the case one, a 33-year-old female with a chief complaint of bleeding of gums reported to the Department of Periodontology. Diagnosis of generalized periodontitis stage 2 grade B, currently unstable with no risk factor, was made according to the new classification system. After 4 weeks of phase 1 therapy, subsequent local anesthesia was administered. And in this case, modified Widman and modified papilla preservation flap was planned. After which flap was reflected and thorough mechanical debridement was done. Post that, epithelial tissue and granulation tissue was curated and sutures were placed. A 3-month follow-up was taken and recordings were made. And it was compared with the baseline. Similarly, in the test group, probing depth was measured and a Kirkland flap was planned. The flap was, the full thickness mucoperiosteal flap was reflected and thorough mechanical debridement was done, followed by which the laser was held at 45 degrees to the inner aspect of the epithelium and was moved in the horizontal direction in the parallel to the flap reflected. Each tooth was laced for 10 seconds. And the total treatment was 1 session and it lasted for 60 seconds. Sutures were placed and the clinical parameters were recorded at 3 months. A second case report consisted of a 45-year-old male with a chief complaint of bleeding from gums. Diagnosis of generalized periodontitis was made. Similar technique was followed as before. Probing depth was measured and Kirkland flap was planned. Flap was reflected and the granulation tissue was removed. Sutures were placed and a wound healing index was assessed at 7 days. A 3-month follow-up was done and was compared with the baseline values. Similarly, test group also consisted of raising the Kirkland flap and lacing of each tooth for 10 seconds. Sutures were placed and a 3-month follow-up was taken. Case 3 was of a 42-year-old female whose chief complaint was of food lodgement and bleeding from gums. A diagnosis of generalized periodontitis was made. In this patient, also probing depth was recorded and conventional Kirkland flap surgery was done. Flap was reflected, sutures were placed, and 3-month follow-up was taken. Post-operative instructions were given to each patient, and suitable antibiotics and analgesics were given for 3 days. Analgesics were advised to take as and when needed. Patients were advised and patients were advised for using 0.2% chlorhexidine gluconate mouth rinses, and oral hygiene measures were enforced. Even in test group, where laser was used for assisting the laser was used for flap surgery. Again, 10 seconds for tooth lacing was done, and sutures were placed and 3-month follow-up was taken. Coming on to the discussion, the parameters assessed were at baseline and 3 months. Probing depth, CAL, PI, GI, and wound healing index were assessed. Both the treatments enhanced clinical outcomes. The primary treatment outcome assessing CAL was reduced in both the groups when compared with the baseline. The secondary treatment outcome assessing the probing depth, healing index, plaque index, gingival index yielded significantly improved results in both the groups, though improved wound healing score was found in test group. Very few randomized controlled clinical trials are documented using this technique. One of the study conducted by Janani et al. Found a reduction in clinical and microbiological parameters when diode laser was used. Lobo and Paul found similar results and a reduction in gingival inflammation. Sands and Moliner found that there was reduced edema and postoperative pain. And Gokhale in their microbiological study found a reduction in colony forming units, thus exhibiting bactericidal effect. Though there was a negative result in which diode lasers did not show any significant benefits over conventional access flap by a study given by Jonal Gard. Lasers have been documented for having benefits in pocket reduction using non-surgical aspects. Like studies conducted by Sakuri found that lasers has an anti-inflammatory role. Yilmaz found that there was a reduction in obligate anaerobes, whereas Deshmukh found in his clinical microbiological study reduction in clinical parameters and colony-forming units. A recent study by Jain et al. Found improved probing depth and reduction in clinical attachment level. So laser advantages are like lasers in the wavelength of 800 to 900 nanometer absorb hemoglobin. Thus it was useful for reduction in pigmented bacteria and granulation tissue. Also, laser helps in soft tissue curettage, cellular debridement. It possesses a bactericidal effect and imposes no interaction on dental hard tissue. Lasers also has an hemostatic effect as it helps in thermocoagulation of the blood vessels. Besides this, laser beam transmission through flexible fiber optical fibers in oral cavity provides ease of maneuverability and adaptation to the tooth anatomy, thereby targeting and disrupting the subgingival microbiome. Laser irradiation also helps in increase of growth factor, that is basic fibroblast growth factor, which helps in wound contraction and reduce inflammatory mediator. So, in conclusion, it can be stated that the present the present case series depicted a reduction in clinical parameters with both the groups, and a significant wound healing result was obtained in the test group. But diode laser as an adjunct to flap surgery exhibits a promising new modality along with surgical periodontal therapy. Thank you.
So, any question time?
Sir, it's a
Where is the
question
mod?
answer session.
Yeah, okay. Good effort, Dr. Rashmi. Why do you call it a case series when you have got a case under control? Two groups. Why do you call it a case series?
I was just about to depict the modality in both the groups. That's why I named it as a case series, though it should have been named as control.
And the second thing is that you have not standardized the oral hygiene procedure post surgery, which I believe had to be done to compare the outcomes. Okay, and also the medications, it had to be standardized. Because if I put a person on steroid and the other person on an NSAID and allow them to heal, the one under the steroid will show much lesser inflammation. Okay, rather than the NSAID. So that has to be mentioned first.
Actually, both the patients were given the similar antibiotic dosage and analgesic.
Yeah, but it has to be in this. It has to be line has to be put about that. Okay. You are new to research probably. Yeah, you're a PG student. So and the other thing is that most of the benefits you cited have relevance when you are doing a non-surgical procedure, because those are exactly the objectives we try to achieve by surgery. Control microbes, degranulate. So once you have already done all that, either your surgery is incomplete or your laser therapy is a redundance. What do you have? What do you have to say about this?
Sir, what I feel is that laser will be having added benefits over the mechanical debridement because of the thermal effects which it includes in it. So the remaining granulation tissue, it can be removed out because of the thermal effect. As it causes a charred layer, a charred effect is created. So enables the improvement of epithelial growth.
Okay, thank you. Thank you. All the best.
Thank you, Dr. Rasmi Bhamare. Sir, our next presenter is Dr. Shashank Deshpande, and the topic is osteodensification, a novel approach for indirect sinus lift procedure.
Good morning, everyone. Myself, Dr. Shashank Deshpande. My topic for today is osteodensification, a novel approach for indirect sinus lift procedure. Introduction. Osteodensification, a bone non-extraction technique, was developed by Huves in 2013 and made possible with specially designed burrs, the tensor burrs, to increase bone density as they expand in osteotomy. When the densifying burr is rotated at high speed in a reversed non-cutting direction with steady external irrigation, the densifying mode, a dense compacted layer of bone tissue is formed along the walls and base of the osteotomy, as it can be appreciated in the diagram. The rotating counterclockwise, the flute back rake angle creates osteodensification, while the rotating clockwise, the flute edges precisely cut the bone. The bouncing motion, in and out movement, is helpful to create a rate-dependent stress to produce a rate-dependent strain and allows saline solution pumping to gently pressurize the bone walls. The rehabilitation of the edentulous posterior maxilla using osseointegrated implants is often challenging due to alveolar bone resorption, low bone density, and maxillary sinus pneumatization. Maxillary sinus lift is one of the most common surgical techniques used for increasing the available bone volume to place implants and restore function and aesthetics. The advantages of osteodensification: it increases the bone mineral density. During osteotomy preparation, it condenses and preserves bone through autografting compaction, autografts bony particles, creating a smoother osteodensification site. Primary stability, bone density, and bone implant contact are increased. Preserves bone bulk, allows for predictable ridge expansion at coronal level. It increases residual strain and creates a higher insertion torque, resulting in good prognosis. The limitations: osteodensification, it does not work with cortical bone as cortical bone lacks plasticity. It prevents the densification of xenografts as well. Healing of the osteotomy by osteodensification technique. The most specific feature of the healing pattern is observed at the level of the coronal area where the bone presents a granular aspect. In these zones, the bone trabeculae shows outer side lamellar bone layers and the specific granular layer in the inner side. The percentage of the bone surface lined by osteoid bands in the coronal area is much higher than that found in the other areas of the implants. The increase of bone density is particularly evident in the most coronal implant region. Active bone remodeling is found to be directed more towards the bone apposition and bone density increase than towards the bone resorption. This suggests that in the long run, the bone could still increase its density. This is a case report. A 40-year-old female patient reported to the clinic with missing maxillary posteriors in the first quadrant with 1/6 and 1/7 missing, as it can be appreciated in the radiograph. This area posterior maxilla in first quadrant shows 1/6 and 1/7 missing. The radiographic examination revealed that the available bone to be 7.1 millimeters, as it can be appreciated in the CBCT report. 7.1 millimeters from the crest to the sinus floor, necessitating an indirect sinus lift. After a thorough history was recorded and necessary investigations were done, the patient was scheduled for surgery. The patient was put on prophylactic antibiotic coverage of amoxicillin 1 hour prior to the surgery. After administration of local anesthetic, a crestal incision was placed and a full thickness flap was reflected. Osteotomy was initiated with a pilot drill of 1.5 millimeter diameter in a clockwise direction and was drilled to 1 millimeter short of the sinus floor. Position confirmed by taking a radiograph. This radiographic representation of the intermediate procedure of drilling was the initial osteotomy was determined. It was then sequentially expanded using the denser drills in the densification mode, using the drills in a pumping motion with copious saline irrigation in counterclockwise direction. This is the CBCT report of the patient. The region 1/6, the section number denoted by section number 35, the height to be 7.1 millimeters and width to be 5.7 millimeters. This is a complete CBCT report. The section number area of interest, the section number 35, it denotes the height to be 7.1 millimeters, while the width to be 5.7 millimeters. The sinus membrane was simultaneously lifted along with bone densification and compaction autografting of the sinus floor, followed with the direct placement of the Novabone putty into the socket. So Novabone putty that was used. The implant, spiral alpha biotech of 4.2 millimeter diameter and 10 millimeter length, was placed into the prepared osteotomy and cover screws were placed with closure achieved using silk sutures. This is the final post-operative final position of the implant. And the sinus membrane, it can be seen as the sinus membrane is lifted. This is the placement of the Novabone putty. Post-operative X-rays were recorded to assess the final position of the implants. Following 3 months, the second stage was initiated and healing abutments were placed. The placement of the healing abutment, and this is the placement, the area of the implant. Further treatment will be carried out soon in subsequent appointments, undertaking all precautionary measures. Discussion. Lehenby et al. Conducted a study to examine the effect of osseodensification on the primary stability and early osseointegration of implants. They concluded that, regardless of the design of implant, the osseodensification drilling technique enhanced the primary stability and bone-to-implant contact. Trisipi et al. Conducted a biomechanical and histological analysis after inserting 20 implants in the iliac crest of 2 sheep and using conventional drill for implants on one side as control and osseodensification for implants on the other side as test group. They reported a significant increase in ridge width and bone volume in the test group. Uves and Mayer were reported that osseous densification increased the insertion torque compared to standard drilling. High insertion torque significantly increased the initial bone-to-implant contact and was found to be directly related to implant primary stability and host bone density. Algamdi H. et al. Conducted a study where osseodensification technique increased the insertion torque of implants to 49 Newton centimeter, approximately low density bone, when compared to 25 Newton centimeters in the standard conventional drilling technique. They concluded that osseodensified osteotomy diameter was reduced to viscoelastic deformation nature. This springback effect of bone is due to viscoelasticity in osseodensification, thereby enhancing the bone to implant contact and primary stability. Lopez CD et al. Conducted a study to assess the biomechanical and histological effects of osseodensification surgical instrumentation in a spine model animal study. They concluded that this technique can potentially improve the safety and success rates of bony drilling at all sites of low bone density and limited bone volume. Conclusion. Osseodensification is a novel osteotomy preparation method that is inherently bone preserving. Unlike conventional osteotomy, osseodensification utilizes proprietary high-speed densifying burrs to compact an autograft bone in its plastic deformation phase. The result is an expanded osteotomy with preserved and condensed bone tissue that maintains alveolar ridge integrity and allows for implant placement with enhanced stability along with no violation of the sinus membrane. This is a small tidbit. Thank you.
So now it is question and answer session.
Sir.
Anurag, go ahead.
Good morning, Dr. Deshpande. Nice presentation. Dr. Shashank, I just wanted to ask you that in osseodensification, primarily there is a compaction of the bone on the walls of the osteotomy, right? Now, when you are attempting a sinus lift procedure, how is it advantageous over a usual or standard corticotomy procedure?
So, when we perform the osseodensification, the pumping action of the osseodensification bar, what it does is the surrounding the bone layer, the surrounding chips that are compacted in an aspect of the osteotomy site. So that is why we get an indirect sinus lifting that is achieved, and a proper integration, the proper insertion torque that can be achieved.
Do you think only osseodensification would be advantageous in comparison to a standard corticotomy for sinus lift?
Yes, sir. Yes, sir. I would justify my answer as by that during a normal osteotomy procedure, we are sacrificing a lot more bone as compared to osseodensification, where we are preserving the bone in the complete periphery and compacting it like a normal autograft. Hence, we are saving a lot of bone and preventing the patient by sacrificing the normal.
Okay. Use of yes. Sir, yes. Would like to...
Yeah. What do you think is the limitation of this technique?
So, in this technique, sir, the main disadvantage will be that the patient should be economically capable, because this technique utilizes a lot of more equipment, and the procedure is a little bit on the economically higher side. That should be.
No, why? Why should it be? Anyhow, thank you.
So,
Thank you, Dr. Sansak Deshpande. Next, it is free gingival graft with diode laser in Miller Class 1 recession by Dr. Bhagyasri Patil.
Today I'm going to present a case report of pre-gingival graft procedure with using diode laser, which we did photobiomodulation in Miller class 1 recession. So gingival recession, it is mainly characterized as a partial denudation of the root surface because of the apical movement of the gingival margin. So gingival recession is associated with the accumulation of biofilm, dental plaque, tissue inflammation, improper restoration, high frenum attachment, and it could be due to age. So to restore this mucogingival deformity, a variety of surgical techniques have been introduced, including pre-gingival graft technique. So this pre-gingival graft technique is one of the most classical approach which was developed a half century ago, and it still remains the most successful one. In spite of remaining most successful and predictable technique, it has a major complication, that is the post-operative morbidity associated with the open palatal wound, acute pain and excessive hemorrhage and bone exposure. So these complications you will usually take around 2 to 4 weeks to resolve, until the wound epithelialization completely takes place. So to accelerate this process, many of the agents were being introduced, such as chemotherapeutic agents, antibiotics, hemostatic agents, and the low-level laser therapy. So here the low-level laser therapy is used in this case, and it has used to accelerate the wound healing process. The low-level laser therapy is defined as the light source with an energy density which is less than 100 joules per square centimeter. So therefore, the temperature change can be neglected to minimize the tissue change. So the objective of this case was to evaluate the efficacy of the diode laser, which is used as a photobiomodulator in pre-gingival graft procedure in localized Miller's class 1 recession, mainly in terms of wound healing and post-operative phase. So here is a female patient of 20 years old, who came to our department with a complaint of bleeding gums and sensitivity in the lower front region of the mouth since 1 year. She has a difficulty in having cold water and food. Her past dental, medical, and drug history were not significant. Upon extraoral examination, the face appeared bilateral symmetrical with a competent lips, and lymph nodes were completely not palpable. On clinical examination, it revealed class 1 gingival recession and grade 1 mobility in relation to 4-1. Upon routine blood hematological and investigation, hemoglobin, clotting time, bleeding time were found to be normal within the physiological limits. So the patient was informed verbally about the surgical procedure, and written consent were also obtained by the patient. So before going towards the surgery, the patient was put on onto the non-surgical periodontal therapy, that is phase 1 therapy, to establish the adequate supragingival plaque control and to maintain the gingival health conditions. And the procedure was done after the um, recession defect was completely free of both plaque deposits and bleeding on throat. So these were the clinical measurements. We have recorded the height of the recession defect. We have recorded the probing depth and the clinical level attachment. The parameters were recorded on 7th, 14th, and 21 day after the surgery. The following clinical parameters were recorded. We recorded the wound healing index. We recorded visual analog scale to record the pain level. And we also checked for the width of the attached gingiva using the UNC 15 probe, which we did pre-surgically and after 3 and 6 months post-operatively. This was the armamentarium which was used, and procedure, both the recipient and the donor site were anesthetized. We have used topical anesthesia here since we are using the laser. So the recipient site was prepared and deepithelialization was done with the laser itself, and the muzzle insertion of the and the frenum were completely relieved. So the recipient site was rinsed with a sterile saline, and a moistened gauze was placed over the area until the graft placement. So after the local anesthetic injection was injected onto the donor site, the FVG graft was harvested from the palatal site, which was located between the distal aspect of the canine to the medial aspect of the first molar. And this we did by tracing along a tin foil paper. So the partial thickness graft consisting of the epithelium and the thin layer of the underlying connective tissue was dissected using the scalpel. So as you can see in the picture, we have harvested the graft from the donor site. The graft thickness was approximately 1.5 to 2 mm, and the prefabricated acrylic stent was then placed onto the maxilla to protect the palatal wound.
वो पहलवान आज भी नहीं आया
Then this graft was sutured using a
पहलवान आज भी नहीं
steel
आया
suture and the suspensory recipient was
बताओ
attached
जो
to it
पैसे
to
बुरे लगे आते हो
stabilize
लोगों
the
को
graft. Here, the stabilization of the graft is the main key for the success of the procedure. So the graft was held firmly into the place by using the digital pressure for 5 minutes with moistened gauze and the saline. And now the patient received the low level laser therapy as a biostimulation at donor and the recipient site with a total radiation time of 32 seconds. And the laser were irradiated directing perpendicular to the site with a slight contact with the tissue. And the laser was irradiated immediately after the surgery and first to fourth and seventh day later the donor and the recipient side. So both the operator and the patient were wearing safety glasses in the session. So later on, after the biomodulation, we have placed the periodontal dressing, and this is the post-operative pictures after 10 days and the 6 months. The patient was instructed not to brush, and he was put on onto the chlorhexidine mouth rinse 3 times daily for 21 days, and he was also put on antibiotics, that is amoxicillin and chlorogenic acid, twice a day for 7 days after the surgery. And the patient was also asked to record the pain in a visual analog scale, and the patient resumed his toothbrushing after 3 weeks after the surgery with a ultrasoft toothbrush. So the result what we got here is the patient represented significantly better healing at the palatal donor site on 7th, 14th, and 21st days. And there was a reduction in the post-operative pain after the 24 hours after the surgery. So discussion in a study which was done by Diaz et al., he reported positive effects of the laser radiation on the palatal donor site, which was similar as that of our study. And in the present case showed that photobiomodulation had promoted early epithelialization of the donor as well as the recipient site. And Almeida et al. In his study in assessing the effect of two different wavelengths of the diode laser on healing process and analgesics, he reported that the application of the lower level laser therapy immediately after the surgery and 48 hours had no influence on pain level and improvement of the healing, which was in contrast with our results what we got here. On the other hand, Vieira et al. He also investigated the biomodulation effect of the laser on pre-gingival graft, and he got a positive effect on the pain reduction and wound healing, which is in same with as of our results. So with this, we can conclude that biostimulation using the low-level laser therapy can benefit wound healing at the pre-gingival graft donor area by accelerating wound healing, and it also helps to reduce the post-operative pain and self-reported bleeding in the patient. These were my references. Thank you.
Sir, it's time for question and answer session, sir.
Dr. Bhagyashree, I have a question for you. Have you listened to your own audio before you posted it for the ISP convention, PG convention? Have you listened to your own audio beforehand? Unmute your mic. Unmute your mic.
Yes, sir.
Yeah.
Sorry. Yes, sir. I
Yeah.
did
Have you?
check. Yes, sir. Yes, sir. I did check.
But still,
But
you posted it.
in between when I checked it, I couldn't hear any of the noise as such from my laptop, sir. I don't know how come it got in between inserted into the recording, and
This profanity cannot be posted. I'm sorry. I apologize to all the participants who are listening to this audio. We are extremely sorry for the slangs being thrown in between the presentation. What it has done is that it has taken up attention of your presentation.
yes, sir. Yes, I'm so sorry about it. I did really check it, but I don't know how come
Do
it
you realize
went
senior doctors, professors, HODs, office bearers might be listening to this proceedings? Because
Yes,
this is the
sir.
first one of the day of the convention.
Yes, sir. I'm so sorry about that. I do really
Okay,
apologize for that.
okay. Coming back to the topic, I'll just ask you one question. Why class one
Yes,
recession? Why not something else? Because class one, as it is, has a very good prognosis.
yes, sir. Yes. The thing was, when the patient came to the department, since it was a class one recession, we put her onto the non-surgical therapy almost 1 month before conducting the surgery. And even after the non-surgical therapy, we couldn't get the proper results. And since even the patient also had the muscle pull, so we went ahead with the deepening of the vestibule as well as for the coverage of the root surfaces. We went ahead with the pre-gingival graft procedures.
So there was no practical selection procedure, just that one patient came and you had to do it and you have to send it.
So,
No, yeah, there has to be logic for a class 1 decision, right? Why you do it?
yes.
Anyhow, thank you. So we'll go for the next
Thank you
presentation.
so much, sir. Thank you, sir.
Thank you, Dr. Bhagyasri Patel. Next is socket seal technique, a solution to thin vocal cortical plate by Dr. Sikha Pariyar and Dr. Jasprit Kaur.
Good morning, everyone. This is Dr. Shikha Parihar and my co-presenter is Dr. Jasprit Kaur. Today, I'm going to present my case report on socket shield technique, that is a solution to thin buccal cortical plate. Now, let's start with the introduction. It is well established that when a tooth is lost due to extraction or trauma, it results in the loss of periodontal ligament as well. Following extraction, the blood vessels to the thin bony walls from periodontal membrane that primarily vascularize the bundle bone are severed, causing facial bone plate resorption. The buccal area of an extraction socket is subjected to the maximum bone loss, that is up to 4 mm. To prevent the inevitable remodeling process after tooth extraction and implant placement, several rich preservation techniques have been described. In 2014, Ling et al. Compared 6 major techniques to prevent buccal bone resorption in immediate implants, that is palatal lingual implant position, platform stitched abutments, bone graft between implant and buccal bone, flap-based approach, connective tissue, and immediate provisionalization. Only the palatal lingual placement of the implant was able to reduce the mucosal recession with a high level of liability in immediate placed implant. So, a new method called a socket shield technique was introduced by Heisler in 2010, in which partial root fragment was retained around an immediately placed implant with the aim of avoiding tissue alteration after tooth extraction. Buccal root retention in conjunction with immediate implant placement is able to achieve osseointegration without causing inflammation and resorption. Our objective is to preserve buccal cortical bone by retaining partial buccal root fragment for immediate implant placement. Methodology: a 37-year-old male patient visited the Department of Periodontology and Oral Implantology with a chief complaint of missing teeth in the front region of upper jaw. Patient had a history of trauma 2 years back. This is the preoperative picture of a patient with the upper front missing teeth. Technique: under local anesthesia, following procedure was carried out. Preoperative radiograph was taken with paralleling cone technique and grid depicting restored root fragment in upper front tooth region. Mid-crestal incision was given and flap was raised as seen in the picture. In the first picture, mid-crestal incision is given in the upper front tooth region, and in the next picture flap was raised with the help of periosteal elevators. Decoronary tooth was sectioned vertically using long tapered fissure diameter as seen in the first picture, and in the next picture, conservative extraction of palatal half of a roof along with its apex was done with periotome and forceps without putting stress on buccal tissues as seen in the next picture. The length of the shield was kept at 2/3 of the root length. The buccal part of the root was then reshaped so that the shield width was about 1.5 to 2 mm. The shield was trimmed to the bone level as seen in first picture where bevel preparation is being done, following which thin level root segment is restored as seen here. After that, osteotomy was done sequentially and immediate implant was placed palatal to the root fragment as seen in the pictures. In the first picture, osteotomy being done, and in the next picture, immediate implant is placed with respect to 2-1 tooth region. The jumping gap between the shield and the implant was approximately 1.5 mm, so a bone graft was placed in the gap between the implant and the root as seen here in the picture. Sutures were given to close the socket and immediate post-operative radiograph was taken with respect to 2-1 tooth region. After that, patient was recalled after 6 months, during which time on that day, healing abutment and angulating abutment was secured with respect to 2-1 tooth region. Impression were made using the closed tray technique on the same day. And here in the next picture, it is a picture of restoration before placement in the mouth. This is the final placement of restoration in patient's mouth. Results: successful immediate implant supported restoration could be achieved without extensive resorption of the buccal cortical plate. Conclusion: the socket shield technique is indicated in the aesthetic areas, mainly in the maxillary and anterior region. It can also be performed in the posterior region along with immediate implant placement. The preserved buccal root segment functions like a shield and prevents the resorption of buccal bone, thus enhancing the contour and aesthetic of the tissue. This tissue is very promising for the preservation of hard and soft tissue in case of immediate implant restoration. The socket shield technique to a large extent prevents resorption of bundle bone by maintaining its viscolarity. Thank you.
Sir, now question answer session.
Yeah, good morning, Dr. Shikha.
Good morning, sir.
How come there are two presenters in this case? Both of you have done the case together?
Yes, sir. We assist. She was my co-presenter as mentioned in the protocols.
Okay.
She was
Okay.
assisting. She was also assisting the case.
Okay, Dr. Shikha, can you tell us what are the few contraindications in which we cannot go for socket shield technique?
So, in case of vertical root fracture involving the buccal segment, in case where pulpal pathology is present, in case of long term, in case of pus, in case of root caries, in case of loss of buccal bone beyond the apex, and in case of if there is periodontally or endodontally the tooth is involved, in that case also we cannot perform the surgery if it is progressive, if it is in progressive stage.
There is a very strict case selection criteria, right?
Yes, sir.
Okay, while performing this highly technique sensitive procedure, if the socket shield that you're trying to preserve, there is mobility, then what will you do?
Sorry, sir.
Okay, while doing the procedure, the buccal fragment that you're trying to preserve.
While performing, sir, are you asking if there was any complication performing surgery?
No, if there is mobility in the buccal shield that you have preserved, while sectioning the tooth, if you find that there is mobility in the buccal fragment that you're trying to preserve, what would be your next course of action?
So in that case, we can't perform the buccal socket shield technique.
Why we cannot perform?
Sir, as it will not lead to osseointegration, and failure of implant will ultimately occur.
Why? Can you tell us why will it lead to failure?
So because it will not properly the bundle bone and the vascularity, it will not properly the bundle bone will not properly I'm sorry, sir, actually it will properly osseointegration will not occur because this blood supply will not properly happen in that case.
Thank you.
Okay, thank you, sir.
Thank you, Dr. Sikha Pariyar. The next presentation will be by Dr. Justina David Joy, and the topic is the symbiotic approach for impermanent defect.
Good morning, respected jury members. I'm here to present a case report titled The Symbiotic Approach for Intrabony Defects. Currently, clinical treatments for periodontitis focus on plaque removal and local inflammation control, such as scaling and groove training and surgical treatments. Those therapies attempt to minimize symptoms and prevent disease progression, but cannot restore the attachment of periodontal tissues to teeth and the original periodontal tissues. Therefore, it is imperative to develop alternative regenerative strategies to restore the structures and functions of periodontal tissues for periodontitis patients. Periodontal surgery as part of the treatment of periodontal disease is mainly performed to gain access to diseased areas for adequate cleaning, to achieve pocket reduction or elimination, and to restore the periodontal tissues lost due to disease. To accomplish the latter, open flap procedures are usually performed, which is combined with bone grafts or various bone substitutes and guided tissue regeneration. Bone grafts such as autografts, allografts, xenografts, and synthetic materials, along with GTR, are most widely used therapeutic strategies for the correction of osseous defects related to periodontal or periradicular lesions. Case presentation. A 40-year-old patient reported to the Department of Periodontology with a chief complaint of pain on lower left front tooth since 6 months. Mild pain, which was aggravated on chewing and relieved at rest, was present. Generalized sensitivity on consuming cold and hot fluids since 1 year was present. Medical history stated that the patient was systemically healthy and no tobacco use or alcohol consumption was present. On clinical examination, both intraoral and extraoral examination detected no abnormalities. Gingival status, the color was pink with physiologic pigmentation, consistency firm and resilient, contour accentuated scalloping with respect to 3.2, 3.3, and 4.2. The size was not enlarged. Position was apical to CEJ with respect to 3.2, 3.3, and 4.2. The surface texture was showed stippling appearance, and there was bleeding on probing, which was grade 2, and the oral hygiene status of the patient was good. Periodontal examination. Miller's class 2 recession with respect to 3.2 and 3.3 was present, and probing pocket depth with respect to 3.2 distally was 5 mm, and with respect to 3.3 nasally was 9 mm. Grade 1 mobility with respect to 3.2 and grade 2 mobility with respect to 3.3 was present. Occlusal evaluation detected high points and it was corrected, and vitality test showed delayed response with respect to 3.2 and 3.3. On radiograph, angular bone loss was present up to the apex of 3.3 and apical third of 3.2. Diagnosis, it was localized periodontitis, stage 2, grade A. And the prognosis with respect to 3.2 and 3.3 was fair. Treatment plan. In phase 1 therapy, thorough scaling and root painting was done using ultrasonic scalers and the respective Gracie curates, and a removable partial denture was placed with respect to the missing lower anteriors. In phase 2 therapy, the patient was referred to the Department of Endodontology in opinion with respect to 3.2 and 3.3. Then the patient underwent root canal treatment with respect to the same. After 2 weeks following the root canal treatment, the patient was recalled for periodontal surgery. Local anesthesia was given, and since there was recession, circular incision was placed using a 15C BP blade. As we can see, then full thickness mucoperiosteal flap was reflected using an elevator, followed by which thorough degranulation was performed with respect to the same quadrant, ensuring smooth root surfaces. This gave improved visibility and accessibility of the angular defect, which was a 3-wall defect. As we can appreciate from the photographs, it was a typical angular defect extending up to the apex of 3.3. And so, regeneration approach was carried out with xenograft as it has osteoconductive property and collagen membrane, which being a gold standard method. After continuous irrigation with saline at the surgical site by a pen of size 0.25 mm to 1 mm was used to pack the defect to the fullest depth, and membrane was cut according to the length and width of the defect, and it was inserted into the buccal and lingual flap. Care was taken to stabilize the membrane. The mucoperiosteal flaps were then secured coronally by placing simple interrupted sutures using Mersilk 440 sutures. Then, periodontal dressing was placed for better protection and close adaptation of the surgical site tissues. Post-operative instructions were given and prescribed with the course of antibiotics such as amoxicillin 500 mg thrice daily for 5 days and analgesics such as diclofenac 50 mg. Followed by which the patient was recalled after 10 days for suture removal, and during which the healing was found to be satisfactory and no other complications were present. In phase 3 therapy, the patient underwent implant placement with respect to the lower anterior region and for future prosthetic rehabilitation. Patient was recalled after 3 months and 6 months for review, and substantial bone fill was found when compared to the pre-op, and the results were stable between the 3rd and the 6th month, and the clinical parameters was found to be improved from baseline to the 6th month. Discussion. Intrabony defects have been associated with risk of periodontal progression in the absence of appropriate therapy, but not if included in regular maintenance care programs. With the currently available regeneration procedures, materials, and technologies, intrabony defects can be successfully regenerated subject to patient factors such as plaque control, smoking, medical history, as well as tooth mobility, restorative, and endodontic condition. Several publications reported on the superiority of periodontal regeneration therapy in the treatment of intrabony defects over the conventional surgeries, such as periodontal access flap, known as open flap debridement surgery, in terms of probing pocket depth and clinical attachment loss reductions. In the present case, by OS, the bovine porous bone mineral resulted in significant improvement of all clinical parameters and also with an increase in the bone fill. As shown in earlier studies by Camillo et al. In 1998, BioOz exhibited favorable handling properties such as ease of delivery to the site, ease of packing the material into the defect, ability of the material to demonstrate an adhesion once placed in the defect, even with significant hemorrhage of the wound site, providing a stable graft. The collagen type 1 selected as a GTR membrane in the present study was based on the following facts. It is the main constituent of periodontal connective tissue. It is bioabsorbable, so it can act as a barrier analogous to a non-resorbable membrane. It's chemotactic for periodontal ligament fibroblast and improves fibroblast migration and attachment through its scaffold-like fibrillar structure. It also creates a thrombogenic surface. It stimulates platelet attachment, which may accelerate fibrin and clot attachment. Collagen is a hemostatic, a property that enhances wound healing. This case report indicated that the use of GTR technique in combination with xenogenic bone graft material was beneficial for the treatment of periodontal intrabony defects. Conclusion: this combination technique provided improved outcomes in terms of clinical and radiographic parameters. Regenerative periodontal procedures seems to be predictable in the long term when proper biomaterial is used, when good oral hygiene and rigorous recall program are implemented, and therefore the use of bone graft associated with membrane has shown promising results in the treatment of infrabony defects. Thank you.
Sir, it's time for question answer session.
Yeah. Good presentation, Dr. Justina.
Thank you,
I
sir.
have a couple of questions for you.
Yes,
First
sir.
thing is that where the mobility of those two checked 3.1 and 3.2 and 3.3, were they mobile?
Yes, sir. Grade 2 mobility was there, sir, for both of them.
Grade 2 mobility. Intentional RCT was there also, was done
Yes,
also.
yes, sir.
Okay. After that, you have put bone graft and you have put a GTM membrane.
Yes, sir.
You feel that this two approach leads to further bone, to greater bone formation.
Yes, sir.
There are very specific questions I'll ask you. What was the mobility post your surgical procedure?
So the mobility was from grade 2, it has just reduced to grade 1, sir.
Okay, in both the teeth.
Yes, sir.
And what you called as bone formation, I only see radio opacity on the radiograph.
Okay, sir.
Right.
Yes, sir.
How do you claim it was a bone formation? It was bone formation.
So because there was reduction of probing pocket depth. Initially, it was 9 millimeter, and then after 6 months, it shows 6 millimeters, sir.
You don't need the graft must be entrapped. It's like a defect fill that is giving you a reduction. And the third thing is that how prudent it is if you are planning for an implant anyhow for one tooth and you have got another tooth with slightly better bone, but still in grade 2 mobility with grade 2, how prudent it is to save it. Because you say in long term, a slight deterioration of the treated tooth will lead to a condition where you have an implant with two mobile tooth next to it. And it can lead to overloading of this implant.
Yes,
And
sir.
now it's a situation where you have got D2 bone, the cancellous bone, because in anterior mandible, you have D1 bone orals. Okay. So you could have just extracted those two and put 3 implants together. How to justify this? That is only I want to know.
So initially, we had told the patient regarding the treatment protocol, but then he insisted on saving the tooth, sir. And then later on, for regarding the 3.1 and 4.1, which was missing, he said he will go for implant as a cantilever, sir.
Okay. And last but not the least, why didn't you splint those the mobile tooth while you're doing the bone grafting? Do you think splinting would have helped in stabilizing the tooth at least during the time when you're grafting, because it was grade 2 mobile, and we all know that once you raise the flap, there's an increased mobility in the post-healing period.
Yes, sir.
So that would have given sleepless nights to the patient, thinking that it has become more mobile. Because you see, if the causes of mobility, post-operative, post-surgery mobility is there, increased mobility is there, and we have to reassure the patient. Now, in this case, it's grade 2 mobile to start with.
Yes, sir.
So grade 2 plus a bit more post-operative. Don't you think splinting could have helped in at least
Yes,
for
sir.
some time being? There are many types of splints available, not the rigid ones, the fiber splint that allows some degree
Yes.
of mobility.
Yes, sir.
Okay, but anyhow, it's a very honest and good presentation. Thank you so much.
Thank you. Thank you, sir.
Thank you, Dr. Justina Joy. Sir, with this, we end our first session. And thank you, Dr. Anurag, sir, and Dr. Depratim, sir, for taking out your valuable time and being a part of this first virtual PG convention. Thank you, sir. Thank you very much. So let's start our second session. This will be coordinated by Dr. Asit Misra.
Thank you, Swaying Pravar. And thank you for this opportunity, organizers.
Thank you. Can we leave and this and
Sir,
Can we
are we
leave the
allowed to
meeting?
leave the panel meeting?
sir, sir, you can leave. Sir.
Yes. Thank you. Thank you.
Thank you.
Thank you very much. Thank you, ISP. Yeah. Hi, Dr.
Good morning,
Dinesh.
everyone. Hello.
Yes, good morning.
Sir. Good morning, everyone. So now we begin with our second session. The chairperson for the second session are Dr. Nilesh P. Joshi, is professor from Bharati Vidyapit Dental College, Navi, Mumbai. Along with him is Dr. Suryakant Malgikar. He is reader from Department of Periodontics, Kamineni Institute of Dental Science, Telangana. One thing I want to add here, we have to strictly adhere to the time limit, sir. The timing of paper presentation is 8 minutes and for question answer is 2 minutes. We can begin the session now. The first presenter is Dr. Safia Hassan. Her topic is physiosurgery assisted periodontally accelerated osteogenic orthodontics, a case report.
Respected dignitaries, today I'll be presenting my paper on piezo-surgery assisted periodontally accelerated osteogenic orthodontics, a case report. My contents are introduction, various methods for accelerated orthodontics, case presentation, orthodontic considerations, radiographic evaluation, periodontal surgical phase, discussion, take-home message. Adults have specific treatment needs with the demand of better aesthetics, appliances, and results in quick time. The demand for aesthetic appliances were met with ceramic brackets, Invisalign, and lingual brackets, but the demand of achieving results in quick time could not be met with these appliances as you cannot exceed the biologic limit of the tooth movement. Hence, the demand of achieving faster tooth movement, excellent results with time-saving techniques lead to the discovery of the accelerated orthodontics, which open doors and offer solution to many limitations in ortho treatment in adults. Various methods for accelerating tooth orthodontic movement are drugs, surgical, and physical. Drugs are vitamin D, prostaglandins, thyroid hormone, interleukin, parathyroid hormone, misoprostol. Surgical is corticotomy, piezocision, microosteoperforation. Physical is accelerant laser. In 1959, Cole used a combination of interradicular corticotomies and supraapical osteotomies to speed up the tooth movement. He theorized that by disrupting the continuity of the cortical layer of bone, he was actually creating a moving blocks of bone in which teeth were embedded. He postulated this theory as bony block movement. This treatment approach never gained widespread acceptance, probably due to the association of horizontal subapical osteotomies, which pose considerable risk to the periodontium and tooth pulp vitality. Also, these bony block movements were later recognized by Frost as regional acceleratory phenomena. This procedure was developed by Dr. Thomas and William Wilco in 1995. Wilco brothers reported 1/3 reduction in traditional orthodontic treatment time. Cuts are given into buccal and lingual side. The most commonly used material are deproteinized bovine bone, autogenous bone, decalcified freeze-dried bone, allograft, or a combination. Advantages are reduced chances of root resorption, addition of bone graft induces enhanced support for naive bone, chances of relapse are very low. Alveolar grafting also benefits the patient by repairing bony dehiscences and fenestrations, improve periodontal support. Less need for extraoral appliances like headgear. It can be used to expedite the rate of movement of individual teeth or dental segments, that is canine and incisor retraction. Reduces 35 to 40% of treatment time as compared to conventional orthodontics. Disadvantages are extra surgical cost. Proper case selection is necessary to attain a good result. Post-surgical crestal bone loss and recession may occur. Some pain and swelling is expected in invasive surgical procedure. Instruments used for corticotomy are manual instrument, chisel and mallet, blade and mallet. Motor-driven instruments are surgical burr, surgical microsaw. Case report. A female aged 28 years complains of spacing between teeth of upper and lower front region of jaw leading to compromised aesthetics. Extra-oral examination contains feature given below. Pre-treatment extraoral photographs are intraoral photographs, radiographic examination, lateral cephalogram of case, diagnosis, skeletal class 1 and dentoalveolar angles class 1 malocclusion with Dewey's type 2 modification. Treatment objectives are correction of proclination of upper and lower anteriors, correction of spacing with upper and lower anteriors. Treatment phase. Phase 1 include patient counseling and informed consent, scaling and polishing. Phase 2 is pre-surgical orthodontic correction, initial leveling and alignment of arches. Phase 3 is surgical phase, corticotomy. Phase 4, post-surgical orthodontic corrections, closure of spaces. Phase 5, retention phase, fixed lingual retainer. Completion of pre-surgical orthodontic phase, leveling and alignment done by 17 into 25 stainless steel wire in 63 days. After completion of pre-surgical phase, patient was referred to Department of Periodontics for the periodontal phase. Surgical phase, surgical procedure, clavicular incision placed both labially and palatally. Reflection of full thickness flap, vertical corticotomy labially and palatally up to 1.5 to 2 mm depth. Horizontal cuts were made 2 to 3 mm apical to root apex joining the vertical cuts. Flaps were sutured. Patients was referred back to Department of Orthodontics for beginning space closure. 7-week recovery period was given for recovery of gingival health before application of orthodontic force. Space closure was completed with sliding mechanics. Pre-op photographs and post-op photographs. Pre-operative radiographic view, post-operative radiographic view months after orthodontic treatment. Pre-surgical orthodontic phase is done. Pre-surgical orthodontic phase and post-surgical orthodontic phase is done in 63 days. 55 days plus 7 weeks of healing. Total treatment time is 168 days, 5 months and 15 days. Routine orthodontic treatment is usually done in 365 to 500 days. Corticotomy can be done on people of any age as long as they have good amount of support and healthy periodontium. According to Wilco, this technique can be done in age as young as 11 years and on senior citizen as old as 77 years. Studies. Authors concluded that corticotomy facilitated tooth movement could be used to treat moderate to severe malocclusions in adolescents and adults. When compared with conventional treatment, it was believed that a reduction in the need for extraction and orthodontic side effects. In this systematic review, authors suggested that corticotomy facilitated orthodontic tooth movement significantly reduces the total time of treatment. This technique is considered as safe and reduced root resorption is seen. Take-home message: by combining the expert advice of radiologist and clinical skills of periodontist and the orthodontist, it is now easier to achieve a viable and patient-centered outcomes through periodontally assisted osteogenic orthodontics. The time required is almost 1/3 than that of conventional orthodontics. My references are, thank you.
Thank you, Dr. Safia. I may now invite Dr. Nilesh sir and Dr. Suryakant sir for the question answer session.
Yes, Dr. Safia, good morning. It was a good presentation. Though I have got some
Thank you, sir.
for you.
Yes,
Now,
sir.
we know that there are less invasive procedures available like micro perforations, assisted movement, right?
Yes, sir.
So why did you choose for
Yes, sir.
why did you choose for a more invasive procedures wherein you will have to reflect a flap when we have got a little more better conservative procedure which is available with equal results?
Sir, the heat generation is very low in piezo surgery, and which does not hinder with the healing process, and it's safe, more safer than other
Okay. Nevertheless, it is more invasive as compared to the microperforations, isn't it? Microperforations would give the same amount of results with little less exposure of the bone.
Yes.
Okay. There's one more question. Um, what is the healing time that is expected after the piezo surgery is performed? When do you expect the healing to be complete?
Sir, it reduced to 1/4.
I'm not talking about the orthodontic time. I'm
Sir,
talking
there
about
is
the
reduction
heal.
of, sir, yeah, it reduced to, sir, it is accelerated healing. Sir, accelerated
Okay,
healing
but
is safe.
any reference you know for that, wherein you can quote some duration for it? Any particular scientific article you know or reference you know for that?
Sir, it's given in my, sir, by Frost. Sir, Frost in 1969.
Okay, okay. Suryakant sir, you have any queries?
Yeah, just I wanted to ask one question. How much residual space was left after pre-surgical orthodontic phase was done? Did you evaluate before and after? In what way the surgery helped?
Sorry, sir.
How much residual space was left after pre-surgical orthodontic phase?
Sorry, sir, you're not audible.
How much residual space was left after pre-surgical orthodontic phase?
Sir, it wasn't left. There was no space left.
Okay. Then what were the advantages of physiosurgery?
Sir, it is a sir, less heat is generated with piezo surgery, so it doesn't hinder with the healing. It is more safe procedure.
You have done follow-up was done for the patient? Follow-up was done for the patient? Follow-up?
Yes, the follow-up was done. 6-month follow-up was done with the patient.
Okay, fine.
Sir,
Alright, so
time is over.
yes.
Hello.
So we can now move to the next presentation.
Yes, sir. Yes, sir.
Dr. Suryakant, is it okay? We can move to the next
Yes, sir.
presentation.
We can move to next presentation, sir.
Next presentation is by Dr. Jamini Taylor. Evaluation of volumetric bone regeneration efficacy of composite graft in periodontal osseous defect using CBCT. A case report.
The plausible aim of this case was to evaluate the volumetric bone field, an intrabony defect in chronic periodontitis patient using demineralized freeze-dried bone allograft as a bone graft material and concentrated growth factor as a carrier material, thereby observe the changes in the soft and hard tissue parameters like probing depth, clinical attachment level, defect depth, and defect field. A 46-year-old male patient reported to the Department of Periodontics with a chief complaint of mild pain in relation to the lower left back tooth region for the past 1 week with a recent episode of swelling and pus discharge that subsided after medication. He gave a history of food being stuck inside his gums while chewing 10 days back. Pain was gradually increased in onset with the aggravation on chewing food and relieved on rest. He did not give any relevant medical history and was reported to be in a systemically healthy condition. In intraoral examination, the buccal aspect of left mandibular molar distal to the 3.6 and mesial to the 3.7 revealed a probing pocket depth of 10 mm, with a clinical attachment level of 11 millimeter. No mobility was detected. Endodontic evaluation was done to test the vitality of 3637 and dental caries was detected in relation to the 3637 and were non-responsive to the vitality test. An intraoral periapical radiograph revealed periapical radiolucency, widening of PDL space, and osseous defect in relation to the distal to the 36 and mesial to the 370. Hence, a diagnosis of primary endodontic lesion with secondary periodontal involvement in relation to the 3637 was made. The treatment plan included was oral hygiene instructions and motivation of the patient in performing effective oral hygiene measures. Routine blood investigations were found to be in the normal range. Non-surgical periodontal therapy by means of conventional scaling and root planing using ultrasonic instrument and curettes. Root canal therapy was done in relation to the 3637,
I'm not
moving to
able
the
to see it.
non-vital response explicated. The patient was recalled after every week for 4 weeks. Re-examination after 4 weeks revealed no changes in the pocket probing depth and clinical attachment level. Cone beam computed tomography and intraoral periapical radiograph were taken for the defect site using intraoral millimeter grid by long cone paralleling technique to standardize the projection geometry revealed loss of buccal cortical plate up to apical third of distal to the 36 and mesial to the 370. Hence, periodontal surgical therapy was planned, followed by supportive periodontal maintenance therapy. A customized acrylic stand with guiding groove was prepared and confirmed for its stability to maintain certain standardization in the angulation and location of the instrument for measurement of periodontal pocket depth at baseline, 6 months and 9 months time after surgery. Concentrated growth factor preparation, 9 ml of venous blood was withdrawn in a sterile vacuum tube without any anticoagulant solutions. The venous blood was immediately centrifuged for 2 minutes at 2700 rpm, 4 minutes at 2400 rpm, 4 minutes at 2700 rpm, followed by 3 minutes at 3000 rpm. At the end of the centrifugation, 3 blood layers were created in the test tube. The middle layer consisting of huge and dense polymerized fibrin block containing the concentrated growth factors were used in the surgery. At the time of surgery, the patient's mouth was disinfected using 0.2% weight by volume chlorhexidine mouthwash for 60 seconds, and the area to undergo surgery was anesthetized with 2% lignocaine hydrochloride 1:80,000 solution. Intraclavicular incision was placed using a bar Parker handle number 3 and the blade number 15. Full thickness mucoperiosteal flap was reflected on buccal and lingual side in relation to the 3637. The granulation tissue was removed using Gracie curettes and the roots were thoroughly scaled and planed using the hand and ultrasonic instruments. Once the debridement of the defect was done, direct measurement of the osseous defect was done with the help of the University of North Carolina 15 probe. The vertical bone depth, bone defect width, and the number of bony walls present were noted. The root surfaces adjacent to the defect were conditioned with the help of 24% of ethylene diamine tetraacetic acid gel. Pre-suturing was done using 3-0 silk suture, followed by bony defect filling with demineralized freeze-dried bone allograft, which was hydrated with saline in a combination with concentrated growth factor. The reflected flap was repositioned and secured with 3-0 silk suture using the interrupted suturing technique. Periodontal dressing was placed. The patient was prescribed a non-steroidal anti-inflammatory medication, ibugesic plus ibuprofen plus paracetamol 3 times daily for 5 days and systemic antibiotic amoxicillin 500 milligram 3 times daily for 5 days. Patient was instructed to rinse with 0.2% weight by volume chlorhexidine gluconate twice daily for 4 to 6 weeks. and avoid undue trauma to the treated site. All the post-operative instructions were given. In the post-surgical evaluation, patient was recalled after 1 week for removal of the sutures. Patient was evaluated clinically for pocket probing depth, clinical attachment level, recession, and radiographic assessment of the defect field at 6 months and 9 months respectively. And overall, favorable response was observed as no post-operative complication, no antigenic reactions were observed, indicating the safety of the material used. All the clinical parameters showed reduction in the pocket depth and gain in the clinical attachment level, better periodontal regeneration, and wound healing was observed with the use of demineralized freeze-dried bone allograft and concentrated growth factor. And the radiographic parameters show improvement in the linear bone growth, and the bone field was calculated via a formula-based approach. By comparing the radiographic and
We are not able to hear.
clinical outcome of the regenerative therapy, significant improvement in clinical as well as in radiographic parameters. Thank you everyone for patient listening.
Yes, sir. Sir, you can start with the question answer session.
Yes. Dr. Gemini, I want to make two observations regarding your presentation. First and foremost, I think you were not supposed to reveal the identity of the college, if I'm not wrong. In the first presentation, you had put on in the slide itself, and in the last presentation. So that goes against the regulation, the criteria that they have put in for the presentations. Okay, that's very important. You are not supposed to uh, give your or expose your identity, which college you belong to.
Yes, sir.
Now coming to the core subject questions as such, I feel the quality of photographs were pretty poor. It could have been better quality photographs.
Yes.
And you did not use any membrane, isn't it?
Yes, sir.
So how are you going to achieve regeneration or bone fill? It is not going to work unless and until there is a membrane covered over it. Whatever pocket depth reduction you have achieved, that is purely because of the shrinkage of the tissue,
Yes, sir.
and it's not going to be a true regeneration. So what is the use of using a graft without a membrane? Can you justify that?
Sir, the main aim of the membrane is act as a carrier, so that the time for healing of the alveolar bone, the epithelium will not interfere while the formation of the bone. That is the main aim of using the membrane.
So how do you actually do you know that this graft could be just a fibrous capsule being present over there without actually true regeneration? It could be just bone fill, and whatever gain in attachment you have achieved, or or reduction in pocket depth, it is because only of the shrinkage of the tissue. There's no, I don't think there's any true regeneration over there. So the entire concept of using such a complicated procedure of centrifuge and using a bone graft is becomes invalid or of no use if you are not using a membrane. Okay, so that's a very important factor.
Yes, sir.
Suryakant sir.
Yeah, yes, sir. Yeah, definitely, sir. It's a case of just bone fill without using the membrane. I want to know why CBCT only was used for assessing the bone regeneration.
Sir, I have used the IOPA with GREED also. IOPA with GREED and CBCT also.
Okay. The formula which you have used for any different, you have presented a case report, right?
Yes,
so
sir.
are other cases are being done to do the study using CBCT? I don't think for a single case you would use CBCT for doing such simple procedure.
Sir, in the same patient, there was a
implant surgery was also held on. So that's why this quadrant specific CBCT was taken.
Okay. What are the other methods of assessing volumetric bone evaluation?
Using the radiovisiography, RVG.
Okay.
Then by the clinically we can check after the 6 or 9 months with the probing depth.
I'm sorry. Okay, anyhow, good presentation. Thank you.
Thank you, sir.
Shall we proceed to next presentation, sir?
Yes.
Okay.
Next presentation by Dr. Shruti KB, Jucheli's technique for management of multiple root recession, a case report.
Greetings to one and all. Today, I'll be presenting a case series on Zucchelli's technique for management of multiple root recession. Gingival recession is an apical shift of gingival margin with the exposure of root surface to the oral cavity. Recession is often seen in populations with good oral hygiene. Commonly, it's located on buccal surfaces. Major causes of recession are found to be improper toothbrushing, trauma associated with malocclusion, etc. Several surgical approaches are proposed for treating gingival recession. Ideal technique selection depends upon the defect size, presence or absence of keratinized tissue adjacent to the defect, width and height of interdental soft tissues, depth of the vestibule, or presence of frenuli and other patient-related factors. Zucchelli's technique is a reliable plastic surgical approach for root coverage of multiple adjacent recessions in the aesthetic zone. It is a modification of coronally advanced flap technique, which eliminates the use of vertical releasing incisions by use of envelope flap design. Multiple root recession coverage is achieved with satisfactory aesthetics and minimal post-operative discomfort using this technique. After phase 1 therapy, surgical technique starts with an oblique submarginal incision placed in the interdental area. Surgical papillae and the gingival tissue apical to the root and the most apical portion of the flap will be elevated in a split thickness, full thickness, and split thickness manner. Remaining anatomic interdental papilla will be de-epithelialized to create connective tissue beds to which surgical papillae would be sutured. After the coronal displacement of the flap, each surgical papilla will be rotated towards the end of the flap to finally reside at the center of interproximal area passively and will be secured using sling sutures, followed by periodontal dressing and antibiotics and post-operative analgesics will be prescribed. After 2 weeks, suture removal will be done. 5 cases diagnosed with Miller's class 1 and class 2 recession and treated with Zucchelli's coronally advanced root coverage procedure in the Department of Periodontology, GDCRI Bangalore are presented in this case series. Case 1 is a 35-year-old female patient reported to Department of Periodontology, GDCRI Bangalore with a chief complaint of unpleasant smile due to elongated and discolored teeth in the upper arch. Clinical examination revealed Miller's class 1 recession with respect to 2.2, 2.3, 2.4 with recession depth of 3 mm at the mid-buccal aspect of 2.3 and 1 mm with respect to 2.2 and 2.4. Preoperative pictures with measurements, initial incision and flap elevation is carried out and the flap is coronally advanced and sutured using sling sutures. Post-operative results show complete root coverage in 2.2 and 2.3 region, but there is partial root coverage achieved in the 2.4. Case 2 is a 53-year-old male patient reported to the Department of Periodontology with a chief complaint of sensitivity in his upper left front tooth region since 3 months. Patient gives history of vigorous horizontal tooth brushing practice. On clinical examination, Miller's class 1 recession was diagnosed in relation to 21, 22, 23, 24, 25, which was measuring 1 mm on each tooth. Preoperative pictures. Intraoperatively, there was incision, flap elevation, and coronal advancement of flap and suturing done. Postoperative picture reveals complete root coverage achieved in all the treated teeth. Case 3 is a 43-year-old male patient reported to department with a chief complaint of sensitivity in his upper left tooth area since 4 months. On clinical examination, Miller's class 1 recession was diagnosed in relation to 12, 13, 14, which was measuring 1 mm, 2 mm, and 1 mm respectively. Incision, flap elevation, and coronal advancement of flap and suturing was done. Post-operatively, there is complete root coverage achieved. Case 4 is a 52-year-old male patient reported to the department with chief complaint of severe sensitivity in his upper left teeth region since 2 months. On clinical examination, Miller's class 1 and class 2 recessions were diagnosed in relation to teeth 2-1 through 2-5, with greatest measuring 3 mm in relation to 2-3. These are preoperative measurements. Intraoperatively, incision, flap reflection, and flap advancement and suturing were done. Postoperatively, all the teeth except 2-3 shows complete root coverage. Case 5 is 38-year-old female patient reported to the department with chief complaint of receding gums and sensitivity in relation to upper right front teeth region since 3 months. Clinical examination showed Miller's class 1 recession in relation to 2-1, 2-2, 2-3, measuring 2 mm at 2-2, 3 mm at 2-3, and 1 mm at 2-1. So the preoperative measurements. Intraoperatively, incision was given, flap was reflected, and flap was coronally advanced and sutured. Post-operative results reveal 100% of root coverage in relation to the treated teeth. When the post-operative results from the case series are evaluated, it is noted that Zucchelli's technique resulted in near complete soft tissue coverage for multiple root recessions. Out of 19 tooth surfaces from 5 cases treated, we found complete root coverage achieved on 17 surfaces. 2 surfaces from 2 cases failed to achieve complete root coverage with 1 mm recession depth remaining after the treatment. Overall, 89% of surfaces treated showed 100% of root coverage. In the 2 surfaces that showed incomplete coverage, probably it was attributed to inadequate attached gingiva, which was present apical to the site of recession preoperatively. This is in contrast to the results seen in study by Zucchelli and De Sanctis in 2000. There was a post-operative increase in width of attached gingiva in the areas of successful root coverage. The treatment of gingival recession is an important therapeutic issue due to an increasing aesthetic demand from the patients. Sensitivity is a major problem that will drive patients to seek treatment in cases of recession. Zucchelli's technique is effective in achieving near complete root coverage of multiple teeth in anterior aesthetic zones. This is advantageous in minimizing the number of surgical sites which are required in achieving root coverage in multiple teeth. Calculated oblique incisions allow for preservation of existing tissues, and they maintain marginal keratinized tissue, thereby achieving good color blending and thickness matching to that of adjacent tissues. Avoiding vertical releasing incisions, it prevents limitation of blood supply to the flap and results in better surgical site healing. Also, no anesthetic scar formation will be seen as in case of vertical releasing incisions. The full split flap approach, it helps to achieve better root coverage owing to more thickness provided for that region of flap which resides over the expected exposed root regions. It also facilitates better coronal displacement of the flap and guarantees anchorage and blood supply to the surgical papilla in the interproximal areas. This case series provides evidence for Zucchelli's coronally advanced flap technique as a successful and highly predictable alternative for the management of multiple root resection. This technique can be used for multiple root recessions in the anterior aesthetic zone, and it is predictable, more predictable due to there is no risk of flap dehiscence, as well as increased post-operative morbidity is not seen as in case of such as graft techniques. The technique has an advantage of less post-operative morbidity due to limited surgical sites involved. Excellent color and texture matching makes it ideal for aesthetic zone, and this is achieved because the tissue adjacent to the defect is only utilized for root coverage. Envelope type of flap and absence of vertical releasing incisions give excellent healing and post-operative marginal stability for this technique. Increasing the width of atagingiva can also be accomplished along with the soft tissue coverage, and that can help in long-term maintenance of the treatment results achieved. High predictability of this technique makes it ideal for clinical applications. Thank you.
Sir, you may proceed with the question answer session now. A gentle reminder to stick to the time frame, sir.
Okay, fine, sir. Shruti, it's a nice presentation. You have done 4 or 5 cases. You have also revealed the identity of your college while presentation. That should not be revealed. But anyhow, how can you say there is complete root coverage in your cases?
Sir, actually, we have analyzed only the immediate post-operative results. The follow-up results are required for telling it as a 100% root coverage, sir. But evaluating the post-op pre and immediate post-operative results, we have put it like that, sir.
What are the parameters used for assessing the root coverage aesthetic scores?
Sir, the CEJ, if it is visible, then that is taken as the landmark from which we'll measure the root coverage, sir.
No, there are different parameters used for assessing the complete root coverage and to give a root coverage aesthetic score. Sir, you can ask any questions.
Yes, Dr. Shruti, I have got a couple of questions. What was the follow-up period?
Sir, only immediate post-operative results have been followed up, sir. Due to COVID pandemic, we could not follow it up.
What could be What could be the possible reasons for not achieving complete root coverage in certain teeth, in certain cases? What could be possible reasons?
Sir, one reason can be attributed to the lesser amount of keratinized gingiva that is present in the immediate periapical area next to the recession. That can be one reason, sir.
Yes, that you have already mentioned, but what I think is important is a case selection. Now, I feel you have not followed, if you have noticed very well, the gingival phenotype in those cases was where you have not achieved root coverage was very thin. Okay, so in those cases, the case selection was not correct. It could have been a connective tissue graft better than the Zucchelli's technique. And secondly, you have missed out on one important anatomical landmark in the case number 3 and 4. I suppose I'm not exactly able to, and that was a buccal frenum. Okay, so you did not take care of the buccal frenum, which has not resulted in root coverage. So these are the important things that you should notice before doing the surgery, especially for root coverage, is gingival phenotype and frenum attachment. So that could have improved your results greatly.
Yes.
Otherwise, it was a good presentation. No problem.
Thank you, sir.
Okay, thank you, Dr. Shruti. We can now proceed to the next presentation. Dr. Ashwati S. Nayak, plasma cell granuloma of gingiva, a case report of an enigmatic lesion.
Myself, Dr. Ashwati S. Nayak, first year MBS, Department of Periodontology, Government Dental College and Research Institute, Bangalore. My title is Plasma Cell Granuloma of Gingiva, a case report of an enigmatic lesion. These are my contents. Introduction. Plasma cell infiltration may occur in many tissues and was first described by Soong in 1952 as Balanitis plasma cellularis. Plasma cell granuloma was first described in 1973 by Bahadori and Lipo. It is a rare non-neoplastic reactive lesion consisting of the proliferation of inflammatory cells with the predominance of plasma cells. It has been classified as an inflammatory pseudotumor that can affect any organ or soft tissue, being common in lungs, vagina, and larynx. In 1968, Bhaskar et al. were the first to report such a case in gingival tissue. The exact etiology is still unknown, but hypothesis suggests that it might be seen due to a focus of irritation or an impacted foreign body or an idiopathic antigenic stimulation. The common microorganisms associated with the lesion include Mycobacteria, Epstein-Barr virus, Actinomycetes, Nocardia, and Mycoplasma. Case presentation. A 32-year-old female patient reported to the Department of Periodontology, Government Dental College and Research Institute, Bangalore, with a chief complaint of swelling in the lower front tooth region since 4 years. The history of preceding illness revealed that growth was initially small and was slowly increasing in size. The patient complained of the swelling interfering with the oral hygiene procedures and was bleeding on brushing. There was no history of trauma and/or surgery to the concerned region. The patient's medical and social history was non-contributory and she did not take any medications. No history of pus discharge or sinus drainage. Radiographic examination was unremarkable. This is a gross picture of the lesion. Preoperative view, gingival swelling in the lower front tooth region on the inner side, occlusal view and lateral view. Clinical features. On intraoral examination, a well-defined solitary growth measuring around 1.5 cm into 1.5 cm in dimension was present in relation to the lingual aspect of 3.1, 3.2, and 4.1. The growth appeared to be arising from interdental papilla region with evidence of mild tooth mobility. The growth was oval in shape, exophytic, pedunculated with regular and non-indurated borders. Mucosa over the growth appeared erythematous without any secondary changes. Surface texture was smooth. Extends anterior-posteriorly from mesial aspect of 4.2 to middle 1/3 of 3.3 and inferiorly extending from mesial surface of 3.1, 3.2, 4.1 to 1 cm from floor of the mouth. On palpation, the inspectory findings were confirmed. It was firm in consistency and non-tender. Bleeding on touching was present. Clinical picture, gingival swelling in relation to 3.1, 3.2, and 4.1 on the lingual aspect. The growth is oval in shape, exophytic, and pedunculated. It is firm and non-tender on palpation. Routine laboratory investigations were found to be normal. The radiological examination of the region showed no bony involvement. Based on the medical history and clinical features, provisional diagnosis was irritational fibroma. The clinical differential diagnosis included peripheral giant cell lesion, peripheral ossifying fibroma, pyogenic granuloma, plasmacytoma, and plasma cell gingivitis. Surgical procedures. Surgical excision was done under local anesthesia and was sent for histopathological analysis. The healing was uneventful. This is an image depicting surgically excised lesion. Surgical site after removal of the swelling, postoperative view, laboratory investigations, gross appearance of the specimen. Received specimen consists of two gray white bits of the tissue. Larger one is shiny, measuring 0.8 into 0.5 into 0.5 centimeter. Smaller one is measuring 0.3 into 0.2 into 0.1 centimeter. Entire tissue was processed. Histopathological examination. The histopathological examination with hematoxin and eosin stain revealed a stratified squamous parakeratinized hyperplastic epithelium with subepithelium showing dense sheets of plasma cells with evidence of ulceration, granulation tissue with proliferating fibroblasts. Numerous histiocytes are also seen with underlying bony trabeculae. However, a typical eccentrically placed hyperchromatic cartwheel-shaped nucleus of plasma cell was also evident. The histopathological appearance, when correlated with the clinical features, was suggestive of plasma cell granuloma of the gingiva. The first image is a micrograph at low magnification showing hyperplastic surface epithelium and subepithelium showing dense strands of plasma cell infiltrates. Whereas the second image is a low-power microscopy showing abundant plasma cells in the connective tissue. The first image is a low-power microscopy showing abundant plasma cells in the connective tissue with elongated rete ridges, and the second image is a high-power microscopy showing plasma cells with eccentrically placed nucleus. Follow-up. The patient was recalled after every 2 months for 6 months for follow-up. Follow-up examination revealed no clinical evidence of any possible recurrence. Discussion. It is rare, reactive, benign tumor-like lesion. Etiology of this lesion is unclear, but according to some authors, it may be due to parasitic infection or antigen-antibody reaction. PCGs of the oral cavity are primarily rare, solitary lesions seen on the periodontal tissue. Maxillary and mandibular gingivas are equally involved with severe bone loss. These lesions have no gender predilection and may occur at any age. These are some of the case reports on plasma cell granulomas. Based on the review of the literature, most of the cases of PCGs are reported in the age group of 17 to 78 years. No sex predilection is seen. Prevalence not known currently. Less than 85 cases of PCG on gingiva reported worldwide. Majority of the cases that have been reported are from Indian subcontinent, suggesting common unknown stimuli or genetic predisposition. Clinically, PCG takes at least two morphological types in the oral mucosa, exophytic or tumor or unilateral ulcerative. Plasma cell granuloma have been now described as inflammatory myofibroblastic tumor and classified by the WHO in the year 2002 under intermediate, rarely metastasizing fibroblastic or myofibroblastic tumors. ICD-IIO code 8825-1. PCGs must be distinguished from plasma cell-rich lesions such as plasma cell mucositis, plasma cell gingivitis, extramedullary plasmacytoma, and multiple myeloma. Histopathological examination of plasmacytoma consists of a pure infiltrate of plasma cells arranged in relatively large sheets with a fine reticulous stromal pattern, while PCG shows a capillary network as its main feature. PCGs must be also differentially diagnosed from other non-neoplastic proliferative oral cavity lesions such as pyogenic granuloma, fibroma, and peripheral giant cell granuloma. Radiographically, PCG may or may not be associated with alveolar bone destruction. A case report by Thielen et al. Has radiographically shown advanced crystal bone loss with ill-defined radiolucency surrounding the apices of the teeth. The most common treatment accepted for PCGs is surgical excision and or complete resection. Other treatment modalities included radiotherapy and steroids, which have also been successfully used to treat larger, non-resectable lesions in case they assume greater dimensions or are in close proximity to vital structures in the area or are deeply seated or infiltrating to the adjacent and subadjacent tissues. Prognosis of PCG is good as there is no evidence of recurrence in any of the reported cases. In our case, simple excision was found to be curative, followed by an uneventful healing period with no sign of recurrence. Conclusion: after the excision and regular follow-up, complete cessation of lesion was seen and no recurrence observed after 6 months follow-up. Plasma cell granuloma is a lesion that is diagnosed primarily based on histological findings. Etiology remains unclear, but it is thought to arise due to non-specific inflammatory response to an unknown exogenous agent. This case emphasizes the need to submit any and all excised tissue for microscopic examination, regardless of clinical impression or perceived surgical success. These are my references. Thank you.
Sir, you may start the question answer session.
What other differential diagnosis can you give?
Dr. Ashwati, you can.
Other differential diagnoses are plasmacytoma, multiple myeloma, pyogenic granuloma, or irritational fibroma, etc.
Why did you give peripheral ossifying fibroma as a differential diagnosis?
Peripheral ossifying fibroma also includes the presence of plasma cells based on histological evidences. Also, they are also hello, sir.
Yeah. Continue.
Also, they are also present as solitary lesions attached to the gingiva, based on clinical examination.
But it particularly occurs in the premolar region, no, not in the central incision. In your case, it was in central incision.
Anterior region.
What was the etiology? How did the patient describe the lesion before?
Patient described as a single swelling present in the lingual side of the mandibular of the lower teeth, which was painless. It was firm in consistency. It was painless, oval in shape. It was also non-compressible.
Patient didn't give any history of recurrence, no?
No recurrence.
Okay, fine. Sir, you can ask questions, sir.
Yes. Dr. Ashwati, I've got two questions. One is that how is it different from plasma cell gingivitis?
Plasma cell gingivitis is a generalized edematous erythematous swelling where this one is swelling and it is localized. Plasma cell gingivitis may be due to use of dendrophysis or other allergic reactions. This may be due to antigen antibody reactions or some other causes. This etiology is unknown.
All right. My second question is. This is a good presentation from the oral pathology point of view. We have included the gross and microscopic anatomy very well, also the differential diagnosis. But as a periodontist, when you are treating such conditions, what precautions you will take or what care you will take as a periodontist, I'm asking, during handling of such cases?
For such case, proper scaling and root cleaning should be done prior, sir, due to prevent any further infections. Also, we had to send this samples for histopathological examination, which because this case may be misdiagnosed for other lesions such as other malignant conditions, which requires disruptive procedures like a multiple myeloma. So, from our point of view, we should send this lesion for histopathological analysis.
All right, that is okay. But would you not take care about the post-operative recession and bone loss?
Yes, sir.
So that
Yes.
is what is expected from a periodontist. Okay. So excision of the lesion and sending for histopath is natural. That is expected. But as a periodontist, you should also look about aftercare. That is, if there is any pocket remaining, or if there is any bone loss or gingival recession, you should be able to treat and take care of it. So that is what is expected. All right.
Thank you.
So that is all from my side. Questions?
Thank you, sir. Thank you, Dr. Aswati.
Thank you.
We can now proceed with the last presentation of the session by Dr. Abhinav Bhaskar and Dr. Manisha Rani.
Yes.
Good morning, everyone. I, Dr. Abhinav Bhaskar, is going to present a case report that is prepared by me and Dr. Manisha Rani. This case report depicts the management of partially edentulous maxilla in severe class 3 jaw relationship using implant-supported hybrid denture and psychiatric medications in a patient with panic disorder. Introduction. Restoration of function, aesthetic, and lip support in a severe case of class 3 malocclusion, especially in a patient with a panic disorder, can be a daunting task for a dentist. So, this case report explains the management of such a patient by prostatic and pharmacologic means. Objective of this case report: the implant supported prosthetic and pharmacological management of partially edentulous anxious patient having panic disorder. Now the methodology. A patient, 71 years old, controlled diabetic, visited the Department of Periodontology and Oral Implantology with a chief complaint of loose upper front fixed artificial denture. By evaluating the mental and psychological makeup of the patient, he could be placed in the category of apprehensive anxious patient. Clinical examination of the patient revealed the presence of a lewd porcelain fused to metal crown and bridge was extending from tooth number 13 to 24 as seen in the radiograph, and posteriorly in the maxilla and mandible, apart from the premolars, all the molars on both sides were missing, and the incisor relationship of patient exhibited a class 3 relation. After removal of the loose fixed maxillary prosthesis along with the supporting teeth, an implant supported fixed prosthesis extending from first premolar to first premolar was planned, and a total of 4 implants were placed in region 13, 11, 21 and 24. These are the radiographs depicting the implants placed with respect to 13, 11, 21 and 24 regions. However, immediate implant placed with respect to 21 suffered implant failure and was therefore removed after 2 months. This is the picture depicting implants with healing abutment secured with respect to 13, 11 and 24 regions, and the implant with respect to 21 was removed due to the implant failure. Considering the excess bulk and weight of the conventional fixed TFM prosthesis, an implant supported hybrid denture was planned and it was delivered to the patient. The denture was fabricated in such a way that it ensured a minimal amount of negative overjet as the patient exhibited a class 3 relationship. Bite registration of the patients were taken and the verification of implant abutment positions were done with the help of Zig trial. After the denture trial was done, finally the implant supported fixed hybrid prosthesis was delivered to the patient. After insertion of the implant supported prosthesis, the apprehensive and anxious patient reported back in a panic state, wherein patient could not tolerate the prosthesis in the mouth. So the prosthesis was removed within 24 hours of the placement. We tried our best to counsel the patient about the wearing of denture, but still the patient was not willing to get the prosthesis fixed, as the patient was very apprehensive. Therefore, as a last resort, psychiatric consultation was considered in this case. The implant supported denture was reinserted into the patient's mouth and was subsequently managed by using a short-term course of psychiatric medications, that is sertraline and etizolam. Sertraline is an antidepressant that belongs to the group called selective serotonin reuptake inhibitors. It affects the chemicals in the brain that are imbalanced in people suffering from depression, anxiety, and obsessive compulsive disorder. And this is one of the most commonly prescribed psychiatric medication. In this patient, we gave 50 milligram once daily after breakfast. Other group of drug was given was benzodiazepine analog, that is etizolam. It also possesses anxiolytic, amnesic, and muscle relaxant properties that are commonly given in the anxious patients. So the dose given to the patient was 0.5 milligram once a daily before going to the bed. At the end of the 1 week follow-up, there was a remarkable difference on the psychological behavior of the patient, and the patient happily accepted the prosthesis after the 1 week course of medication. Therefore, the psychiatric medications were then discontinued. Till the time of presentation of this case, approximately 3 months have passed and there has not been any complaint from patient side yet. Results of this case report are the case of partially edentulous anterior maxilla in class 3 jaw relationship could be managed by using lightweight hybrid denture along with psychiatric medications. One important thing is to keep in mind is that we cannot always give the psychiatric medication if the patient is not willing to wear the denture. In these cases, a proper counseling of the patient is a must while giving the denture. Even if all the counseling methods have been given to the patient, but still patient is not willing to put the denture or is not convinced, then we can opt in for the psychiatric medicines, but this should be the last resort. Concluding with my presentation, this case report reveals that large size implant prosthesis might pose psychological problems in some patients that can be managed by selective prosthesis design and psychiatric medicine. With this, I conclude my presentation. Thank you.
Thank you, Dr. Abhinav. Sir, you can start with the question answer session.
How did you manage the posterior occlusion in this patient?
Sir, actually, first of all, the patient was not financially sound, so and patient wanted aesthetics first, so that's why we first treated the anterior aspect of the patient.
Okay.
And apart, sir,
your answer is not complete.
Sir, apart from this also, several articles have depicted about the short dental arch concept, in which if the occlusion is still the premolars only and molars are not treated, then also it is a good treatment modality, as some cases have, some studies have shown that treating the molars also in these cases can be an over treatment for the patient. So we stick to the short dental arch concept.
Okay, fine.
Yes, Dr. Abhinav. There is one more presenter along with you. That is Dr. Manisha, right?
Yes, sir.
So is she there present today or she's not there?
Sure, she's there, sir. Yes,
All
sir.
right. Okay. Okay. So I want to ask why you didn't go for all-on-4 option in this case with a fixed prosthesis.
So for the fixed prosthesis, sir, it is also fixed prosthesis, but the conventional fixed prosthesis, sir, the bulk of the porcelain fused to metal would be large in this case, and the denture would be very heavy. So for this case, we go for the lightweight hybrid denture.
You can go for a hybrid option even in all-on-4 because that's the actually temporization is done with a hybrid. And how did you temporize this case? What temporary did you use?
Sir, as such, we don't give any temporary restoration to the patient.
Correct. So had you had you given a some form of temporary, either removable RPD or something that would have
No, sir, we didn't give any RPD, sir.
yes. So if you would have given that, that would have made the patient used to the processes, and then you would have not probably had the psychological complications of not using. So temporization and all-on-4 could have been a better option. You can also give a hybrid prosthesis and all-on-4.
Yes,
Okay, it is less bulky and it is with an immediate temporization which will habituate the patient for prosthesis.
Yes.
Okay. Just one more question is there from my side. Did you use any kind of stent while doing the patient surgery?
No, sir. No, sir.
Okay.
Okay, thank
Any
you, Dr. Abhinav.
one more second. Any reasons for not using the stent?
Not any specific reason.
All right. Take care.
Thank you, Dr. Abhinav. So with this, we end our second session now. Thank you so much, Dr. Nileshwar, Dr. Suryakant sir, for taking out your time and judging this session. It is
Thank you,
in
sir.
yes, sir. So now we will
Yeah,
begin with our third session.
it was our
Sir.
yes. Thank you so much.
Thank you so much, sir.
Thank you, sir. Now we will begin with the third session. It will be coordinated by Dr. Sun Prabha. So may I hand over the mic to her.
Very good, sir. I'm inviting Dr. Prakash V.S., Professor from the Department of Guru Nanak Institute of Dental Science and Research, Kolkata, and Dr. Ira Gupta, Professor, Dr. Rama Dental College, Kanpur. Ma'am and sir, before we start, we have to adhere to the strict timing as it is being held on virtual platform. After 8 minutes, the presenter has to be stopped, followed by 2 minutes of question answer session. So let's start our session 3. And the topic of presentation is post-COVID exertion in mucormycosis and multiple periodontal abscess, a case report by Dr. Binisa Bajaj.
Namaste. Be grateful for each breath. You are still surviving the COVID-19 era. A hearty good morning to respected members of the panel. Kindly allow me to present before you a case report entitled Post-COVID Mucormycosis with Classic Periodontal Manifestations. As we all know, at the end of 2019, a novel coronavirus, SARS-CoV-2, was identified as the cause of the cluster of pneumonia cases in Wuhan in China. It was rapidly spreading in China as an epidemic, which was followed by a global pandemic. Over 250 million cases were confirmed globally and were reported. Since April 2021, physicians, even in India, are documenting an alarming number of cases of mucormycosis, a deadly fungal infection, among patients with COVID-19 and those who have recovered recently from it. So what is mucormycosis? It is an opportunistic fulminating fungal infection caused by Rhizopus species of order of Mucorales, frequently seen in immunocompromised patients. It is the third most common angioinvasive fungal infection. These fungi are ubiquitous, meaning they are present everywhere. They are usually harmless, but they become pathogenic under certain conditions, like uncontrolled diabetes, immunocompromised states, hematological malignancies, marrow or organ transplants, corticosteroid therapy, and deferoxamine therapy, and in chemotherapies. Mucormycosis is clinically manifested as gastrointestinal, pulmonary, encephalic, rhinocerebral, cutaneous. Pathophysiology of it can be traced through spore inhalation, through the nasal mucosa, where massive spore formation takes place. It enters into the blood. After angioinvasion, there is arterial thrombosis and ischemic necrosis. It can either spread into the orbit, and from the orbit, it can spread to the cranium. That is the intracranial spread. Mucormycosis, which is also known as zygomycosis, has classic symptoms like continuous severe unilateral headache, nasal discharge, retro or periorbital pain, periorbital swelling. As there are not much cases that report intraoral findings of post-COVID mucormycosis, we aim to report post-COVID mucormycosis with classic periodontal manifestations. A 70-year-old male patient came to our OPD with chief complaint of pus discharge and multiple swellings in upper front region of jaw since 1 month. This patient was treated for COVID-19 infection 1 month back with CT score 8 by 25. He was hospitalized for 5 days for the same. At the time of admission to the hospital, investigations were made and they revealed that the patient was an unknown case of diabetes mellitus and the poor diabetic status was seen. The chief complaint of pus discharge and multiple swellings in upper front region of jaw began 7 to 8 days after the discharge from the hospital. On extraoral examination, paresthesia that is, somewhat similar kind of numbness was noted over right zygoma region, diffuse swelling on the right side of the face extending from lateral part of the nose to the tragus anterior-posteriorly, and from malar eminence to the commissural area on the right side of the face superior-inferiorly. There were some rare intraoral findings as this patient was referred to our department as a routine case. But look what all we found. Multiple swellings seen over the gingiva in maxillary region with respect to 17, 16, 15, 14, 13, 11, 21, 22, 23. Grade 1 mobility with 13, 12, 11, 21, 22. There were mild periodontal pockets with 4, 14 and 13. Halitosis was present and also poor oral hygiene was noted. So there was a very interesting finding in this patient of which we have recorded the video. There was mobility in the entire bony segment of right maxilla. This was helpful to us in determining the diagnosis. Also, a solitary soft midline swelling of 0.5 to 1 centimeter approximately was seen in the palate posterior to the Ruke area, although no visible perforation was seen. So we came to a provisional diagnosis of post-COVID fungal infection. When investigations were being made on intraorally on the radiograph, on radiovisiography, loss of lamina dura in the concerned area periapically was seen. On orthopentamograph, there were rarefactions in right maxillary bone area. On CT phase of paranasal sinuses, in coronal view, we noticed thickening of the mucosa of maxillary sinus on the right side, which was more than that on the left side. These findings were appreciated and confirmed on the axial view as well. Such cases can be managed by early diagnosis, underlying systemic condition reversal and risk factor reversal, intravenous administration of amphotericin B, which is also the first line treatment of mucormycosis as suggested by the ICMR in its recent guidelines, posaconazole as the second line treatment or the salvage treatment, also hyperbaric oxygen, which can be used as an adjunctive therapy. Coming to the discussion, rhinocerebral mucormycosis is the most common type in patients with diabetes mellitus. It initially resembles bacterial sinusitis and may mimic malignancy. Histologic staining can differentiate between the fungi. The prognosis of mucormycosis is usually fair to poor. Depending on the overall health of the patient, the speed of diagnosis and treatment, the ability of patient
the presentation is not audible,
and the complete debridement of the infected area, the prognosis.
Dr. Ravi, is it audible to you?
Yes, we know that corticosteroids cause immunosuppression. This is an interesting feature that rhizopus contains an enzyme called ketone reductase. So, in diabetic ketoacidosis, where this enzyme is required, rhizopus gets more scope of spreading and colonizing. Also, humidifiers for oxygen therapy and improper sepsis at the hospital premises predisposed to this condition. So much more attention should be given to the immunocompromised patients to prevent opportunistic infections. In this patient, conservative management with intravenous amphotericin B was done, to which the condition did not respond. So, further management, that is surgical debridement, was advised with follow-up. To conclude, we should make an early diagnosis for better prevention and management of opportunistic infection to reduce its incidence and morbidity. Also, protocols for prophylaxis should be established and followed for hospital admission, and rational use of corticosteroids should be done. This should not be forgotten. Times are hard, but we are in this together. Thank you.
Thank you, Dr. Vinisa Bajaj. Ma'am and sir, you can start with question and answer.
Dr. Ravi?
Was this a recorded presentation?
Pardon, sir?
this was a recorded presentation you presented, or it was live?
Yes, sir. It was a recorded presentation.
Is
He
it
was
allowed?
about. Yes, sir. It was a recorded one.
No, I mean, I don't know whether it is allowed or not. I mean, for the recorded presentation.
So
I don't
that
know.
was the protocol that was asked.
Okay,
They asked
maybe.
us.
Sorry, I might have missed. Okay. Well, indeed, it was a good presentation. Okay, you just mentioned it is the third most common angio-invasive fungal infection. Can you
Yes,
please
sir.
put some light on that?
Sir, because the first one is candidiasis and second being aspergillosis, mucormycosis is the third most common angio-invasive infection. And angio-invasive infection means it invades the blood. That is why it is called as angio-invasive.
And what about the palpatory findings of the swelling?
Sir, paresthesia was noted. Like there was numbness. Numbness on that part of the face on palpation. I have not mentioned exactly that on palpation we see the paresthesia, but I have mentioned that on extraoral examination we can.
No, palpatory findings, like what are the consistency, the onset, the progression associated with pain or not. That's what I'm asking.
So the consistency was soft. It was not tender. And onset, as I've mentioned, it after 5 to 7 days of the discharge.
Okay, ma'am. Yeah, ma'am.
I want to ask you, like, as you mentioned, there are 5 kinds of mucormycosis.
Yes,
can you hear me?
Yes, ma'am.
Okay. So can you tell me, normally we have been talking about it, like the kind of mucormycosis and the people it has been affecting are the ones which are with low immunity. So is there any among these which also affects the people with good immunity or good immune system?
Ma'am, it is not much likely that it will affect people with good immunity, but yes, that can be the case. Not, but it is very less likely that it will happen with good immunity. But patients who have recently started with certain drugs which suppresses the immunity, so it predisposes in that condition.
Okay, now Vinisha, I'm trying to ask you, out of the 5 kind of mucormycosis which you have mentioned, out of these 5 kinds, which is the kind which affects the people, which have chances of affecting even the people with good immune system?
Ma'am, it can be cutaneous because cutaneous is the one which will affect via skin inoculation if there is any cut or wound or in cases of burns. So in that case, immunity might be good for the patient.
See how it helps listening to the question properly. Huh?
Yes, ma'am. Yes,
so,
ma'am. Sure.
so any alternative therapies have been tried, like mucormycosis in itself has been a recent disease which has been highlighted post-COVID. So any alternative therapies have been tried for it?
Ma'am, only when first line therapy does not work, salvage therapy, which involves posaconazole, isavuconazole, and adjunctive therapy like hyperbaric oxygen therapy, which supports the neutrophils and helps them to fight against the fungi, can be done.
Okay. So like here you have shown a case of diabetic patient, unknown diabetic patient with lot of multiple periodontal abscesses, and along with it he was a COVID patient also. So what link are you trying to connect here? Are you trying to connect some link? Are you trying to have the effect of COVID on periodontal tissues or periodontal disease on COVID? Is it something like this you are trying to present with your presentation?
Ma'am, the most common predisposition with the cases that we are getting in these times is uncontrolled diabetes. So in this patient who was not a known case of diabetes and was investigated at the time of hospital admission, this is one link of diabetes. Also at the time.
No, I'm not asking you the link between diabetes and COVID. I'm asking you, what are you trying to settle some link between periodontal problem and COVID? One directional or two directional, is it?
No, ma'am, not periodontal and COVID.
Okay, okay. Thank you.
Thank you so much, ma'am.
Thank you, Dr. Binisa Bajaj. Our next presenter is Dr. Kistis Chavan.
Okay, so the title for the case report presentation is an innovative way of treating vertical root fracture with the socket precision and delayed implant. Presenting author Dr. Vijay Saman, myself, and Dr. Co-author is Dr. Vinayak Menvade sir. Paper ID 430-591 contains introduction, case report, result discussion, and
Excuse me,
conclusion.
back and team.
Yeah,
Introduction
can the
vertical root
organizers, can you
fracture
please
according to
pause?
the
Yeah,
Yeah.
this was not the
Yeah.
presentation mentioned actually.
Same. Yeah. Some pedicle buccal fat pad graph of for root coverage in severe gingival recession defect.
So what to do now? We have only this presentation from Dr. Chidit Chavan.
Ma'am, I had submitted the presentation on 22nd. They had downloaded the video.
Okay, fine, no problem. You continue with your presentation then. But what we have with us
Epidemic
in written, what we have with
the
us is pedicle buccal fat pad graph for root coverage in severe gingival recession.
fracture which is present. Ma'am, Located at the what root should I of the do right now? Directed buckling of the palliatory and treating the removal of the dental implant by the fixed the dental the tooth by the placement of a fixed or a removable prosthesis and a placement of implant osseointegrated. A vertical fracture can present can be complete or incomplete form and extending into the from the enamel to the long of the tooth. So the most frequent causes of the vertical root fracture are physical trauma, clinical prematurity, poor endodontic treatment, and dental treatment iatrogenic. So the patient mostly often the classical don't have any classical symptoms, but a definitive diagnosis can be done with the help of periodontal probing, radiographic and examination, surgical exposure, that is the inspection of the root surface. So frequently it occurs in the age of 40 to 69 years of age, the male patient, frequently occur in molar and premolar region, and it has a poor prognosis, so it leads to an extraction of the affected tooth. Bone defects are always accompanied the fracture line. In the cases of dubious and inconclusive diagnosis and exploratory surgery is indicated. The purpose of the study is to evaluate the alveolar ridge height, the preservation using bone graft and blood substitute after extraction of teeth with the vertical root fracture. So case report, a patient 42-year-old male patient was referred from the Department of Periodontology and Oral Implantology from the endodontic with a chief complaint of pain and deep periodontal pocket. No medical history and personal history was seen, and the patient had undergone a root canal therapy in lower right back region of jaws 5 years ago. So the clinical features are the patient complained of intermittent pain on chewing hard food. Uh, 4, 5, and 4, 6 were root canal treated, and there was no mobility with respect to 4, 5. In the distal aspect, we can see that there was a 12 mm pocket depth. Buccally also for 12 mm pocket depth and 13 in mesial. So intraoral periapical radiograph was recorded, and we can see that there was a presence of abscess even after the endodontic treatment. So preoperative computer tomography gave us more um, for a precise diagnosis, and then the radiographic line, radio lucent line was extending from the uh, in the till the apex of the root. Then and also loss of the buccal bone was seen, and there was abscess was present. So it made a diagnosis as a vertical groove or a vertical fracture. So surgical internal exploration was needed, is required. So the buckle height was around 12 from that. And the surgical technique is that we did a full mucosal periosteal flap reflection, and the vertical incisions were given at the mesial line angle of 4.3, and vertical root fracture was noticed, and we extracted the tooth. The extraction of the tooth was done, and the vertical root fracture was extending from the enamel to the apex of the tooth. Then the degranulation of the tissue was done with the help of curettes, And then the length of the dehiscence was 10 mm from the till the alveolar crest, and the width of the was 6 mm. And then the demineralized freeze-dried bone allograft was placed to have a new bone formation, and as a scaffold for osteoinduction and osteoconduction. And collagen membrane was used to avoid the loss of graft and stabilize the wound and promote blood clot formation. So double collagen layering was used to have a reduced buccal bone resorption and new bone formation. And PRF was placed to induce growth factors like PDGF and platelet-derived growth factor and insulin like growth factor. Horizontal matrix suture were used to have a precise position of the wound edges. 5 months postoperatively, there was 8 mm horizontal width and 9 mm for vertical height. So the results after 5 months, but we cannot measure it on CBCT due to the lockdown. And the problems faced preoperatively, it was seen as a vertical groove on CBCT, and during the surgical technique, ventral foramen was near the area of interest. No post-operative CBCT were taken due to the lockdown. So discussion, vertical root fracture is complete or incomplete along the tooth root portion, and most frequent causes as it was an endodontic treatment. So the lateral condensation endodontic fillings are the most common cause for the using finger spreader. So it was most common cause, and also due to the removal of the dentine from the root canals susceptible to fracture, and most of the author literature says that there in the such cases there is a localized deep pocket and fistulas in the vestibular area. So to achieve a predictable and aesthetic functional restoration and diamond to preserve it is important to preserve the dimension of the alveolar ridge height after the extraction. Alveolar ridge preservation is a surgical procedure which retains the maximum bone and soft tissue after the extraction is done. Then the DFDBA was used in this following case to in also formation of bone, new bone by osteoinduction, scaffold osteoinduction, and PRF was used as autologous source to increase the growth factors such as platelet-derived growth factor and insulin-like growth factors. To avoid the loss of the growth graft material, we used a collagen membrane. Double layering was used to stabilize the wound and promote blood clot. And platelet-rich fibrin aids at the bone graft, so it arrests the bleeding. Coming to the conclusion, bone graft, collagen membrane, and platelet-rich fibrin showed better results for the socket preservation in the vertical root fracture. And so the results so far we are satisfying, and we are after the CBCT, we are going to place the uh, uh, implant. Thank you.
Ma'am and sir, you may start with question and answer session.
Dr. Shitesh, as you said that it showed better results. So better in comparison to what? What are you comparing with?
Ma'am, comparing it the post pre-operative and post-operative, the according to the lockdowns, we could not take the CBCT, so there was no post-operative measurements, and we just took clinical measurements and showed better results with DFDB and double membrane collagen.
Dr. Shitesh, you're not. What I'm trying to ask you is, you said that you have seen better results by using this modality, combination of graft, PRF, and GTR membrane. So this was better as compared to what?
As there was a buccal dehiscence was present, so as we, according to the clinical measurements, it is showing better results. Results are satisfying.
Okay. So when exactly did you say, I just lost the track? PRF, first you place the DFDB and then?
Collagen, the double collagen membrane was placed.
And then you place the
then
PRF,
the
right?
PRF was placed over the membranes.
why PRF was not placed prior? Why was it placed over the collagen membrane? That's my question.
Ma'am, ma'am, we wanted to preserve the bone height. So to avoid the loss of bone graft, we used double collagen membrane and to stabilize
Agreed.
the wound. And then we placed PRF to preserve the soft tissues.
You are telling ulta. To preserve the membrane, you will put PRF.
That's what. Think about it, Kshitish. You want to change your answer in some way?
No, ma'am.
No. Okay, tell me, what is the role of PRF?
Ma'am, the role of PRF, PRF helps in uh, growth factors, several growth factors such as platelet-derived growth factors and insulin-like growth factors, and preserving the soft tissue height. And it also acts as a membrane.
Okay, so your conviction is that PRF is only for soft tissue healing. That's what I'm understanding by the way you are telling. That's what you think, right?
No, no, ma'am. Also for the bone regeneration, also several studies have been done for socket preservation with PRF.
That is what. So if that is the case, why was it not placed along with the bone graft or maybe over the bone graft, and over it the membrane should have been placed? That's what my question is.
Ma'am, yes, ma'am. Ma'am, we used DFDB and mixed it with the PRF.
Dr. Ravi?
Yeah, Dr. Kshitij, I don't have any question. Okay, but I have a suggestion for you. Kindly work on your presentation skill. Okay, and the photographs were not good. And even in one photograph, you kindly check the path of insertion of the probe, how you probe the pocket. Okay, it is angulated. Okay, those photographs you cannot. And for the sake of presentation, please don't do. Please work on your skills. Okay, thank you so much and all the very best.
Thank you, Dr. Kistis. Our next presentation by Dr. Pranesh Sundarshan and Dr. Asrita S.
Hello everybody, myself, Dr. S. Pranesh, third year postgraduate student, will be presenting a case report describing the lateral pedicle flap to enhance recession coverage with the adjunctive use of platelet-rich fibrin. Described gingival recession, it is the apical movement of the gingival margin which leads to the exposure of the root surface and causing a variety of problems such as dentinal hypersensitivity and root surface caries. The four most common etiological factors put forward are microbial-induced periodontal disease, incorrect brushing techniques, anatomical factors such as aberrant frenum and tooth malposition, and orthodontic treatment. Predisposing factors which increase the likelihood of occurrence of this condition include tooth bone angle, the tooth position and movement in the alveolar housing, the thin cortical plates if present, gingival biotype, which includes the gingival thickness and the extent of gingival tissue, and previous history of periodontal disease. Every procedure has certain indications. Some of the common indications for root coverage include anatomical factors prescribed previously, root hypersensitivity, aesthetic improvement, prior to prosthetic and orthodontic procedures, and shallow non-carious cervical lesions. And endpoints or goals to be achieved and verified are the complete coverage of the exposed root surface, no persistent root sensitivity, good marginal tissue contour to maintain self-cleansing areas, and adequate keratinized tissue width. Isolated recessions, as the name suggests, presence in a single tooth, and they can be present in the lower anteriors, which is the most common region, or in other areas such as the canines, where the thin alveolar housing could be the cause of recession. Treatment options include the pedicle soft tissue grafts, which include the rotational and the advanced flaps, and the free soft tissue grafts, which are the connective tissue grafts, which can be left submerged or non-submerged without the coverage of the flap. And additive treatments include the use of root biomodification agents and amyl matrix proteins and guided tissue regeneration membranes. Activated platelets, which are the key features of autologous platelet concentrates, have various positive properties, like they act as a scaffold to capture, support, and stimulate cytokines. They contain alpha granules, which release various chemokines and adhesive proteins by themselves. And the idea is to capture the final stage of the clotting process in a natural mechanism. These are the various platelet concentrates, which can be divided roughly into two generations. The first generation, platelet-rich plasma and PRGF, and the second generation, which includes platelet-rich fibrin developed by Chaukel and al. In the year 2001, and the other, platelet concentrates which followed are modifications of PRF in the form of advanced injectable titanium and concentrated growth factors. Moving on to the fibrin clot PRF per se, it contains platelets and leukocytes in the highest possible percentages. Apart from that, it also contains cytokines released by the various cells and mesenchymal stem cells, all trapped in a fibrin meshwork, which, as you can see, is a very highly polymerized and cross-linked structure, providing the ideal regenerative platform. Coming to the case presentation, male patient, 42 years, presented with a chief complaint of reducing gum level on his lower front teeth since 3 years. Clinical examination revealed proclined upper and lower incisors with Miller's class 3 gingival recession in relation to 4-1, and there was aberrant frenum present in relation to the same tooth. And the plaque levels were not sufficient to indicate microbial-induced periodontal disease, and therefore root coverage was indicated. And root coverage procedures were many, and lateral pedicle flap was chosen in this case because of adequate keratinized tissue apical to the defect and sufficient keratinized tissue present at the donor site, which is the adjacent tooth. It also showed thick biotype, and the patient presented with a high palatal vault, thus excluding connective tissue graft harvest. So preoperative measurements were taken in the form of recession depth and recession width. Then the incision was planned, the conventional incision, where the first incision was given in a reverse bevel manner around the recession defect to remove the epithelium to maintain connective tissue bed for optimal attachment. And the root surface was also curated so that there is no hindrance. The donor side incision was extended from the defect horizontally, leaving 2 to 3 mm away from the gingival margin to preserve the keratinized tissue. The second incision was extended apically in a vertical manner beyond the mucogingival junction. Elevation followed a full split approach, where full thickness flap was elevated up to the mucogingival junction, and a split thickness was done beyond that to ensure adequate mobility and tension-free repositioning of the flap. During the reflection, internal splenectomy was also done to receive further muscle tension. During the course of the surgery, blood was withdrawn in a 10 ml syringe with adequate aseptic precautions and centrifuged according to the required protocol. The post-centrifugation here shows 3 layers: the platelet poor plasma, the PRF clot, and the red blood cells at the bottom. The PRF clot is then slowly removed with the help of tweezers and placed onto the glass slab. And a second glass slab was placed on top of it to expel the residual fluid, which can be later withdrawn with the help of a syringe, and it can be applied onto the recipient side to maximize the effect of the growth factors. So the prepared PRF membrane is then placed onto the defect denuded root surface directly, and the flap was rotated onto the root surface of the recipient tooth to check for the adequate mobility. Once adequate mobility was established, the flap was rotated in a tension-free manner and placed over the denuded root surface containing the PRF membrane, thus completely covering the membrane as well. An interrupted sutures was placed to hold the flap in place. Pressure with moist gauze was applied in order to minimize the clot formation beneath the flap and also to ensure close adaptation, which will aid in the healing process. The 1 week follow-up picture shows a sufficient healing, satisfactory healing both in the donor side as well as the recipient side. Only 1 week follow-up could be obtained as the pandemic restricted the movement of the patient, thus preventing him from coming for further follow-ups. Thus, to conclude, under even a less than ideal indication of lateral pedicle flap, the outcome could be maximized substantially by the adjunctive use of platelet-rich fibrin. The ultimate success of any mucogingival procedure is assessed from the patient's perspective, and the patient revealed that he was satisfied with the approach, the outcome of the treatment, and there were no patient discomfort as well, which is most commonly seen with other procedures. On behalf of everyone, I would like to thank the Indian Society of Periodontology, my department, head of the department, Dr. Prabhuji, sir, and my guide, Dr. Rashmi ma'am, for providing me this opportunity to talk in this platform. Thank you and have a good day to all.
Ma'am and sir, let's start with question answer session. And please, ma'am and sir, kindly stick to the 2 minutes question and answer.
Dr. Pranesh, what care did you take for ensuring the tension-free repositioning of the flap?
Ma'am, good morning, ma'am. First, after the donor site incisions were given, cutback incision was given beyond the mucogingival junction to ensure adequate rotation. There was no tension in the flap, and further, since there was an aberrant frenum present, internal frenectomy was also done so that creeping muscle attachments will not be hindering or pulling the flap again once it has been repositioned.
Okay. Dr. Ravi?
Yeah, the root biomodification was done?
No, sir, we just curated the root surface and removed it from all the.
Was it what? It was not necessary?
There were contrasting reports or evidence that may or may not, and since we were placing the PRF membrane, we prepared the root surface and ensured that the growth factors will be reaching the root surface, and we do not want any layers of to prevent the growth factors from acting during the healing phase. The initial 7 to 10 days is the phase where the
Not
PRF
able
clot.
to give, we missed.
Am I audible, sir?
Yeah.
The initial phase of 7 to 10 days is the phase where the PRF clot has its maximum effect with the release of growth factors. So we wanted the maximum perfusion of growth factors into the healing area.
Okay. So you had given pack?
Yes, sir.
Yeah. Okay. Okay. Thank you.
Dr. Pranesh, Dr. Pranesh,
yes,
I think that if you would have done biomodification, that would have solved your purpose all the more.
Yes, ma'am. It could have been done.
Your purpose is that it should penetrate deeper into the root surface and collagen, everything. So that that could have been done better.
Yes, ma'am.
Okay, thank you.
Thank you.
Thank you, Dr. Pranesh. Our next presenter is Dr. Srushti Sukalkar.
The title for my case report is Management of Amlodipine Influenced Gingival Overgrowth Presenting as a Lymphoplasmacytic Lesion. Gingival overgrowths are characterized by enlargement of the gingival tissues, which can be attributed to various inflammatory, drug influence, and neoplastic etiologies. There are various drugs comprising of anticonvulsant, immunosuppressants, and calcium channel blockers, which are attributed to influence the clinical course of plaque-induced inflammatory gingival enlargement, of which amlodipine is known to cause gingival overgrowth. However, the prevalence is quite low. It has shown lymphoplasmacytic infiltrate, which is often been shown as mimicking like those of plasma cell gingivitis, leukemia, multiple myeloma, hepatitis C infections, and neoplasm. So the course, prognosis, and treatment of any gingival overgrowth will vary considerably based on the diagnosis. Hence, blood investigation and histopathology should follow clinical examination to rule out life-threatening disorders. So this case report is of a 49-year-old female patient who had reported to our department of periodontics with a chief complaint of swelling and bleeding from the gums in all regions of upper and lower jaw since 2 months. She was diagnosed with hypertensive 3 months ago and was on tablet amlodipine 2.5 mg and tablet Pertin 16 since 3 months. She also gave history of sporadic use of tobacco 2 years ago. On extraoral examination, there were no signs of ecchymosis, petechiae, bruise, hematoma, or hamarthrosis, and the lymph nodes were non-tender, non-palpable. On intraoral examination, there were no signs of petechiae, ecchymosis seen intraorally. We could see that these enlargements were frank with sessile, which was seen in the mandibular anterior region, and pedunculated like growth with respect to 4-5. They were nodular, diffuse, and were reducible but not tender on palpation. These enlargements were friable, soft, edematous, and would bleed spontaneously. And the poor oral hygiene status of the patient was assessed from the presence of local irritating factors, which could have contributed to the inflammatory component of the gingival enlargement. The provisional diagnosis was given as amlodipine-infused gingival overgrowth. Differential diagnoses were as those of conditioned gingival enlargement, globular capillary hemangioma or pyogenic granuloma with respect to 4-5, peripheral giant cell granuloma as that respect with 4-5, plasma cell lesion, vaginous granulomatosis, leukemia, multiple myeloma, non-Hodgkin's lymphoma. The investigations carried out were hemogram, HB, total leukocyte count, differential WBC count, platelets to rule out any leukemic or neoplasms, and followed by PTNR, which were all in the normal range.
Serological tests were also carried out as those like HIV, hepatitis B and C, which were non-reactive. Radiologically, we had done an OPG. Histopathological investigations, incisional biopsy was done with 3132 and excisional biopsy with 4546. The OPG shows that there was a horizontal bone loss pattern seen with the radiolucency seen at the apex with respect to 4-5 and giving it a hopeless prognosis. This was the excisional biopsy which was done with respect to 4-5, measuring 10 mm in height and 15 mm in length. And this is the immediate post-biopsy picture. The histopath report showed that there was increased cellularity and predominant plasma cells present, giving a histopathological impression as that of a lymphoplasmacytic lesion. Another second biopsy was done as that of a incisional biopsy with respect to 3132, which was measuring of 7 mm in height by 6 mm in length. This is immediate post-biopsy picture. And the histopathological report was similar to that of with respect to 4-5, where there was increased cellularity and predominant plasma cells seen, and a similar histopathological impression of that of lymphoplasmacytic lesion. These pictures are done at 2 weeks post biopsy with site A and site B. At 2 weeks post biopsy, we could see that because of the increased cellularity and predominant plasma cells which were present, further hematological investigation and immunohistochemical analysis of the biopsy was required. So she was referred to a tertiary cancer institute for the confirmation of the same and to rule out any neoplasm. So they also carried out certain blood investigation and they reached upon a diagnosis of the lesion being amlodipine-induced gingival enlargement masquerading a lymphoplasmacytic lesion. Further which the patient was referred to the physician for substitution of the drug and the drug was substituted to telmisartan 40 mg. She was educated for the stoppage of the habit, motivated for hygiene maintenance, scaling root cleaning was done, she was advised chlorhexidine gel application, gum paint application and use of ultra-soft toothbrush for brushing and mouth rinses. Re-evaluation of 3 months, we could see that there is considerable reduction in the size of the gingiva after the substitution of drug to telmisartan. She was educated and non-surgical periodontal therapy was carried out at all the intervals. At re-evaluation at 7 months, we could see that the gingival inflammatory component had also comparatively gone down. It had been more fibrotic, the spontaneous bleedings had reduced, and the apicocoronal extent of the lesion had also reduced. So a re-biopsy was done to evaluate whether there was any reduction in the lymphoplasmacytic infiltration post the substitution of the drug. The histopathological report said that there was considerable reduction in the infiltrate component in the slides. So this is the pre-biopsy, that was the initial presentation of the gingiva when the patient had come, and this is post after 1 year. We can appreciate that there is reduction in the cellularity and plasma cell infiltrate at 1 year as that compared to the initial histological slides. We know that the drug and the course of the amlodipine influenced gingival overgrowth will be influenced by various things like dosage, duration, blood level of amlodipine, as well as sex, genetic predisposition, the oral hygiene status, the gingival inflammation, and activation of growth factors. It is said that it is a multifactorial model. It could be involving both non-inflammatory and inflammatory mechanisms. The non-inflammatory mechanism include effective collagenase activity due to decreased levels of MMP1 and 3. The inflammatory, however, could be because of the upregulation of various cytokines as that of FGF2, TGF-beta1, interleukin-6, interleukin-1 beta, which cause a localized toxic effect and development of fibrotic gingival hyperplasia. They also are involved in mast cell migration, influencing the fibroblast proliferation, extracellular matrix synthesis, and degradation. So the present case did not present with the similar histopathological findings as that we would see in an amlodipine-influenced gingival overgrowth. So the final diagnosis was arrived upon as amlodipine-induced gingival enlargement, which is mimicking like a lymphoplasmacytic lesion. The tooth with the hopeless prognosis, that was with 4-5, was extracted, which healed eventfully. The patient was put on plaque maintenance protocol. There are certain studies in literature which have proved like that, those with Aldemer et al. In 2012 and Joshi and Bansal et al. In 2013 have said that the change of the drug has resulted in regression of the overgrowth within 3 to 1.5 to 3 months and without any need for surgical intervention. We have also seen literature in where we have seen that amlodipine has presented as a unusual findings as that of Schamberg's disease, which is caused by administration of amlodipine, or as that of induced linear immunoglobulin A disease and amlodipine induced plasma cell granuloma. So I would like to conclude by saying that physicians and dentists should be aware of the etiologic medications that can induce gingival hyperplasia and be able to identify changes in the oral cavity in such patients and to prevent, diagnose, and successfully manage them. In our case, we have done diligent lab investigations, non-surgical therapy, and drug substitution, and we have seen a clinical resolution of the lesion through the biopsy in the amlodipine-influenced gingival over. These are my references. Thank you.
Ma'am and sir, you can start with question and answer session.
Can you briefly tell me the line of treatment, just like other than non-surgical therapy?
Yes, sir. Good morning, sir. So other than non-surgical therapy, so we'll be putting after the non-surgical therapy, so we'll be checking for the patient for after reevaluation whether there is any decrease in the fibrotic component. Like for a periodontist, we would also be requiring to see for any other bone loss that has been associated and if the gingival component has reduced. If it's not reduced, then we would either go for a gingivoplasty to check to re-establish the contour for the patient, or if there is any underlying pocket which has been left behind to correct those. So line of treatment would be when the patient comes, we'll do a non-surgical therapy, refer the patient, if the biopsy is being done, the biopsy, then clinical examination, biopsy, then change in the drug substitution, followed by the contouring of the gingiva or any other periodontal therapy that is required in the patient.
What is a typical clinical feature of any drug-induced gingival enlargement?
Ma'am, it is enlarged, ma'am. Grade 3 enlargement is seen, ma'am. Also, ma'am, there is bleeding on probing and increase in the collagen activity in the gingiva.
I asked you a typical clinical feature. Bleeding on
Ma'am,
probing.
ma'am, mulberry pattern of enlargement, ma'am.
Can you think of something better? It is something different than the one seen in case of chronic gingival inflammatory gingival
Ma'am, it is
enlargement.
not associated with plaque always, ma'am. It is the drug which is the causative.
Okay, thank you.
Thank you, ma'am.
Thank you, Dr. Srushti. Our next presenter is Dr. Komala SR.
My greetings to one and all. Hope everyone is well and healthy. The topic of my paper presentation is plasma cell gingivitis with granulomatous cheilitis of lip, a different phase of IgG4 related disease, a case series. Plasma cell gingivitis is a rare condition characterized by diffuse and massive infiltration of plasma cells into the subepithelial connective tissue. Clinically, it appears as a diffuse reddening and edematous swelling of the gingiva with a sharp demarcation along the mucogingival border. Though considered as a hypersensitivity reaction to an allergen, the etiology of this braces condition is still not properly understood. Granulomatous cheilitis, like plasma cell gingivitis, is a rare disorder of unknown etiology. Plasma cell gingivitis and cheilitis are possibly granulomatous secondary to some contact allergy. The coexistence of both conditions together suggests that they have common etiopathogenesis. Immunoglobulin G4 related disease is a recently recognized immune mediated condition comprised of a collection of disorders that share specific pathological, serological, and clinical features. IgG4-RD is a fibro-inflammatory condition with a tendency to form tumors with inflammatory infiltrate with IgG4 rich plasma cells and elevation of serum IgG4, which may affect virtually every organ and tissue. Laco et al. Concluded that a subset of these lesions may represent mucosal manifestation of IgG4-RD in the oral cavity, And these patients may benefit from IgG4 testing as they may, at least according to the scarce literature, develop similar fibroinflammatory lesions in other locations. We are reporting 4 cases of plasma cell gingivitis, the granulomatous cheilitis of the lip, and we have evaluated it plasma cell gingivitis with cheilitis granulomatosis may represent a mucosal manifestation of IgG4-RD in the oral cavity as elevated by immunostaining for IgG and IgG4 antibodies. The case series presentation. These are the summary of the case series. A 25-year-old male presented to our department with a chief complaint of swelling and bleeding from gums and also swelling of upper and lower lips in 6 months. As swelling increased, redness of gums and bleeding while brushing and eating also increased. He noticed these changes when he changed his fluorinated dentifrice to the dentifrice containing the herbal ingredients. And another 35 years male presented to our department with the chief complaint of lip swelling since 20 days and also increased gum bleeding while brushing with the teeth. Patient reported previously medical history of being an anemic. From 20 years, he was using charcoal for cleaning his teeth, but 20 days before, he changed to toothbrushing and toothpaste containing cinnamon. The 25 years old female patient reported to our department with complaining of gum and lip swelling since 1 month and also increasing in gingival bleeding while brushing the teeth. She noticed this after the placement of porcelain fused metal crown in the maxillary anterior teeth. A 25-year female patient presented to our department with cracked and swollen lips since 1 month and also gum swelling and soreness along with bleeding while brushing and eating the food. She also noticed this one when she changed her the lipstick. This is the clinical pictures of the case one present. This is swelling of the lip, enlarged gingiva. This is the histopathology of the case one with the dense infiltration of the plasma cells. This is the immunohistochemistry of the case one of IgG and IgG4. The immunohistochemistry analysis of the case one is the immunoglobulin was immune reactive with a score of 3 to 5 involving 76.70 to 100%. IgG is of 60 to 70 plasma cells. IgG4 is a positive of 1 to 2 plasma cells. The ratio between the IgG4 and IgG is less than 40%. This is the clinical picture of the case 2 with the enlarged lip, bleeding of gums and swelling. This before and after the administration of the intralesional steroids. This is the treatment after the treatment of this picture. The histopathology of the case 2-1 with the infiltrate of the dense plasma cells. This is the clinical pictures of the case 3. This is histopathology of the case 3 case. The clinical picture of the case 4-1 with the fissured lip, enlarged lip and enlarged gums. The histopathology with the dense infiltration of the plasma cells. This is the immunohistochemistry of case 4 with IgG and IG4. The immunohistochemistry analysis, immunoglobulins was immune reactive with a score of +1 involving 1 to 25%. Ig more than 100 plasma cells. IG4 1 to 2 plasma cells with positive. The ratio is again less than 40%. These are the differential diagnosis. The case management and the outcome. All the cases that we have discussed here are the allergic plasma cell gingivitis cases managed by removing all the allergens like replacing the dentifrice which caused allergy and by replacing the porcelain fused metal crown with all ceramic. Granulomatous cheilitis of the lip was treated with the intralesional steroid injection which was managed by dermatologists. No post-operative complications were noted. As per the test classification, plasma cell gingivitis is classified as a type 1, type 2, type 3. The type 1 was caused by the allergens. Type 2 is the neoplastic one. The third one is the unknown. As per the above classification, our cases series study comes under the type 1 classification. Treatment was done by removing all the allergens which caused plasma cell gingivitis. Immunohistochemistry analysis for the IgG4 revealed that the lesion was immune reactive and stained approximately. IgG is 70 to 100 plasma cells. IgG4 is positive 1 to 2 plasma cells. The ratio is IgG4 and IgG is less than 40%. The diagnostic criteria, the clinical examination showing the characteristic diffuse or localized swelling or masses in a single or multiple organs. Hematological examination showing elevated serum IgG4 concentration and the histopathological examination showing marked lymphoplasma cellular infiltration. Fibrosis and presence of IgG4 positive plasma cells with a ratio of IgG4 with IgG positive cells that is more than 40% and with more than 10 IgG4 positive plasma cells per 1. that is HPF respectively. According to these criteria, individual cases are diagnosed as definite A plus B plus C, probably A plus C, or possibly A plus B. It's IgG4RD. Based on international criteria for the diagnosis of IgG4RD, the present cases cannot be classified as a mucosal manifestation of IgG4RD. Although to the date, there exists no consequence regarding to the cutoff values used to define a significant IgG4 positive plasma cell count. Several Japan medical associations, including gastroenterology, pancreas, biliary tract, rheumatology, have developed organic specific criteria for the diagnosis. There is no need to establish oral cavity specific guidelines for the diagnosis of this IgG4RD. Ogawa et al. Demonstrated that IgG4 expressing plasma cells are present in inflamed gingival tissue and documented a rise in IgG4 expression when comparing moderate periodontitis with advanced periodontitis. However, no detailed histopathological data are currently available regarding IgG4 positive plasma cells in gingival tissues. We concluded plasma cell gingivitis lesion with cheilitis granulomatous may represent a variant of IgG4 positive localized immune mediated type 4 hypersensitivity lesion unrelated to IgG4RD, and that the IgG4 counts must be cautiously interpreted. These are my references. Thank you.
Ma'am and sir, it's time for question answer session.
Should I?
Yeah, ma'am, please.
Okay.
Good afternoon.
Doctor, as you mentioned, it's plasma cell gingivitis cases, most of them. So why you did not diagnose it as plasma cell cheilitis, and what made you diagnose it as granulomatous cheilitis?
Plasma cell.
You mentioned somewhere in your presentation that
Yes,
the granulomatous cheilitis was treated using. You had mentioned something like this.
Yes, ma'am. Granuloma. Mine is
why did you diagnose it as granulomatous and not as plasma cell cheilitis?
Ma'am, according to clinical pictures and all those things, we diagnose it as a plasma cell gingivitis, ma'am. In a plasma cell gingivitis is generalized one, ma'am, where that is a localized one.
Pardon?
Ma'am, plasma cell gingivitis is the generalized one, ma'am.
Okay.
This is a localized one, ma'am.
Okay, let me put it very simple. What is the difference between plasma cell cheilitis and granulomatous cheilitis? Tell me the difference between two. Dr. Ravi?
No.
Dr. Ravi.
Okay. Can you name some synonyms of plasma cell gingivitis?
Sir, that is plasma cell cheilitis, actinic cheilitis, and dermatitis ventis. Other names we used that ones. Other atypical gingival stomatitis, idiopathic gingival stomatitis, allergenic gingival stomatitis, and plasma cell gingival stomatitis.
Thank you so much.
Thank you, Dr. Kumala Esar. Our next presentation by Dr. Ridhi Assathi.
Good morning, respected judges. Today, I'll be presenting a case report on capillary hemangioma of gingiva, which is a rare lesion, and also the associated diagnostic dilemma for periodontists. The term hemangioma incorporates heterogeneous group of clinical benign vascular lesions with similar histologic characters. Hemangiomas are characterized by rapid endothelial cell proliferation followed by involution over time, and they do not undergo ileomalignant transformations. Usually develops in children and occasionally in older age individuals. It has been found out by some of the clinicians that the capillary hemangioma have a higher incidence rate in female. It can also be classified on the basis of vascular spaces and histology into capillary and cavernous. Capillary hemangioma shows a characteristic feature of numerous proliferating small, thin-walled, blood-filled vessels, which composed of single layer of flattened or plump endothelial cells and are surrounded by a discontinuous layer of pericytes and reticular fibers. Now, cavernous hemangioma have a characteristic feature of deep irregular dermal tangles of large thin-walled vessels or sinusoids which are separated by scanty connective tissue and are surrounded by a discontinuous layer of endothelial cells. Capillary hemangioma can be clinically manifested as a soft tissue mass which can either be smooth or lobulated, sessile or pedunculated, and variable in size. Sometimes it appears as a pale halo surrounding an area of telangiectasis and are relatively rare and uncommon pathologic entity in the oral cavity. Most commonly, they are found on the face, fingers, and occasionally in the oral mucosa, and very rarely on the gingiva. Periodontally, these growths often appear to arise from the gingival papilla and spread laterally to involve adjacent tissues. Now, for the case report, a 32-year-old female patient reported to the Department of Periodontology with a chief complaint of swelling in the upper right front tooth region. On history of present illness, she mentioned the swelling was gradually increasing in nature and she experienced a difficulty in chewing and brushing along with the swelling. She didn't give any relevant past medical history which was related to the lesion. So next clinical examination was performed and on inspection, a 3 into 2 centimeter size solitary sessile reddish swelling with distinct pallor and smooth surface was seen on the labial surface extending from mesial aspect of 1-1 to the mesial aspect of 1-2, and on palpation the swelling was tender and soft in consistency. Radiographic investigation was carried out in which no pathological finding was detected with respect to the lesion. So the provisional diagnosis was given as a pyogenic granuloma, and for differential diagnosis, peripheral ossifying fibroma, peripheral giant cell granuloma, hemangioma, and fibroma was thought out. For treatment, scaling and root planing was performed and followed by the surgical excision or biopsy, then the histopathological investigation for final diagnosis, and finally the follow-up of the patient. After 1 week of scaling and root planing, the lesion was excised along with the surrounding gingival tissue of around 1 millimeter under local anesthesia, followed by thorough curettage and complete hemostasis. After that, periodontal dressing was done. Then the excised tissue was fixed in 10% neutral buffered formalin solution and was given for the histopathological investigation. In histopathological finding, under the 100x microscope, a hyperkeratinized stratified squamous epithelium was observed along with it proliferating capillaries in the connective tissue, which revealed numerous irregular and dilated endothelial line vascular spaces. Now further, it was zoomed in the 400x, and along with the hyperkeratinized stratified squamous epithelium, spongiosis was also observed, and in the connective tissue, the endothelial line vascular spaces were engorged with red blood cells. So the diagnosis came out to be capillary hemangioma. Post-operatively, the patient was recalled after a month and after 6 months. So after a month, as we can see, there is a mild inflammation along with some amount of the plaque accumulation. That was mainly because the patient was experiencing discomfort and she wasn't able to maintain her oral hygiene properly. And after proper healing, she maintained her oral hygiene. So in the 6 months, there was no plaque accumulation, neither the mild inflammation was there. Now, there was a study conducted by Matsumoto in year 2015 in which he studied 31 cases of intraoral capillary hemangioma and found that most lesions were occurred on buccal mucosa, that is 45.2%, and least percentage was found in the palate and gingiva. For palate, it was 3.2%, and for gingiva, it was 6.5%. So this study proves that the occurrence of capillary hemangioma on gingiva is a rare entity. Then Rashapa et al. Mentioned in one of his study that the management of hemangiomas of the oral mucosa varies according to various factors like the age of the patient, the size of the lesions, the site of the involvement, and the clinical nature of the hemangioma. Similarly, Chindesi et al. In one of his study mentioned that the treatment of choice for the capillary hemangioma is a surgical excision, but along with it, steroid therapy, electrocautery, laser, or cryosurgery can also be performed for treating the capillary hemangioma. Attempt to remove hemangiomas using surgical excision may lead to serious medical problems such as the heavy bleeding, and in addition, post-operative recurrence of this hemangioma have also encountered in some of the case reports, such as the case report given by Koser et al. In year 2004 and the case report given by Nestor et al. In year 1973. This is other one of the rare finding of the capillary hemangioma occurrence along with the pyogenic granuloma on the alveolar ridge associated with a dental implant. This case was uh, conducted by Kang et al. And they did the surgical excision of the pyogenic granuloma and the capillary hemangioma combined lesion, and no recurrence was found for an E. So, with this case report, I would like to conclude that the lesion was clinically diagnosed as a pyogenic granuloma, but histopathological investigation confirmed the lesion as the capillary hemangioma, which is a rare entity. So, diagnosing such lesion has to be based not only on the clinical evaluation, but also on the histopathological investigation. And for that, a close collaboration between the periodontist and oral pathologist is required for appropriate treatment, for appropriate diagnosis of such lesions, and to avoid the serious complications. Thank you. Please inform.
Ma'am and sir, you may start with question answer session.
Dr. Riddhi, can you please tell me what is the theory behind the occurrence of capillary hemangiomas in the gingiva?
Ma'am, capillary hemangioma is a very rare condition, and most commonly the gingival conditions which occur in the gingiva is the pyogenic granuloma, fibroma, then giant cell granuloma, and ma'am, when there is a presence of capillary hemangioma, there are chances that because of the accumulation of the plaque or the higher and more accumulation of the plaque or calculus may lead to the capillary hemangioma.
No. Dr. Ravi?
Yeah, I mean, can you just mention the various surgical approaches, okay, in treating the capillary hemangioma?
So the most common approach is the surgical excision, which can be done by the scalpel method, or along with its laser electrocautery can also be used for the surgical removal of the capillary hemangioma, as it has been discussed in the previous literatures.
You know what is cryosurgery?
Yes, sir, cryosurgery. Yes, sir. Nitrogen cannula is used, sir.
Can it be optional?
Sir?
Can it be used for the treatment?
Yes, sir. Cryosurgery. It has been mentioned in the literature that cryosurgery can also be used for the removal of the capillary hemangiomas.
Thank you so much.
Thank you, Doctor.
Dr. Riddhi, what is the difference between capillary and cavernous hemangioma?
Ma'am, in case of capillary hemangioma, the most commonly difference which we can find is the histopathological difference. In case of ma'am capillary hemangioma, there is a numerous blood vessels present in the connective tissue, whereas in cavernous hemangioma, ma'am, there are the deep and the in the connective tissue it's present, but there is a demarcation among the capillary blood vessels.
Okay, thank you.
Thank you, Dr. Riddhi. Ma'am and sir, with this we end our third session. Thank you for taking out your valuable time and being a part of this first virtual PG convention. So let's move on to our next, fourth session. Thank you,
Thanks
ma'am.
to all of you. Thank you so much.
Thank you, ma'am. Thank you, sir.
Now I would like to invite Dr. Vinita Gupta, Professor and Head, Department of Periodontology, Government Dental College, Raipur, Chhattisgarh, and Dr. Abhishek Verma, Professor, Department of Periodontology, Buddha Institute of Dental Science and Hospital, Patna. And please, ma'am and sir. Sir, Abhishek sir is not here. He has not joined yet. Yes, sir, very good noon, sir. Sir and ma'am, I have to invite to session 4. Here the presenter is Dr. Kiten Vijay Singh Rajput and Dr. Palak Agrawal and Dr. Sanika Kamble. Sir. Team, please play this video.
Warm greetings to all of you. Today, I, Dr. Ketan Vijay Singh Rajput, along with my colleagues, Dr. Palak Agrawal and Dr. Sanika Kamble, will be presenting a case report on successful restoration of Siebert's class 1 defect and chin block augmentation, followed by implant placement. Dental rehabilitation of partially or totally edentulous patients with oral implants has become a routine treatment modality in the last decades with reliable long-term results. However, unfavorable local conditions of the alveolar ridge due to atrophy, periodontal disease, or trauma sequelae may provide insufficient bone volume or unfavorable vertical, horizontal, and sagittal intermaxillary relationships, which may render the implant placement impossible or incorrect from a functional and aesthetic viewpoint. So this is a case report of a 24-year-old male patient who came to the Department of Periodontics with a desire to replace the upper front tooth with an implant. The patient gave a history of trauma to the upper front tooth by a road traffic accident 10 days ago. Detailed case history was recorded for the patient, which revealed no significant medical history. On the right side, we can see the preoperative clinical picture of the patient, which shows crown and mass fracture with the upper left central incisor. And also there was a slight bulbous region noted on the mucogingival junction with the lateral incisor. So the clinical examination was done, which revealed crown and mass fracture as stated with 2-1, which was non-restaurable, and grade 1 mobility with 2-2. So radiographic examination was done, and it stated vertical root fracture with 2-2. As the patient was willing to undergo implant placements, so the investigations were advised accordingly, which included RVG and CBCT with 2-1 and 2-2 region, and also CBC and random blood sugar levels. So after going through the CBCT and RVG reports, a treatment plan was formulated that included extraction followed by immediate implant placement with 2-1 and 2-2 region. A detailed written informed consent was taken from the patient and the treatment procedure was explained to the patient. On the day of surgery, a full thickness flap was reflected and the vertical root fracture with 2-2 was confirmed, and also there was buccal bone dehiscence which was seen. So the extraction of 2-1 and 2-2 was carried out, and after extraction, it was seen that there was a deficient buccopalatal bit, which was not in favor of the implant placement. So this defect was classified as Siebert's class 1 defect. Now what are Siebert's defect? So Siebert's classified the residual ridge deformities under 3 classes. Class 1 is the buccopalatal loss of tissue width with normal ridge height. Class 2 is the loss of ridge height with normal ridge width, and class 3 is a combination of class 1 and class 2. So in this case, it was the class 1 Siebert's defect, that is buccopalatal loss of tissue width with normal ridge height. So the previous treatment plan, that is extraction followed by immediate implant placement with 2-1 and 2-2 region, was discarded, and a new treatment protocol was made. The new treatment protocol was extraction followed by ridge augmentation for the Siebert's class 1 defect using chin block and autogenous bone graft, and then the delayed implant placement with 2-1 and 2-2. The new treatment protocol was made and it was explained to the patient, and also the patient was made aware about the previous treatment which could not be done and the reasons behind that. So the new treatment was started with the chin block augmentation. The extraction of 2-1 and 2-2 was carried out, and then the donor side was selected and the full thickness flap was reflected from the donor side. The chin block was marked and the chin block was harvested with a chisel mallet and microburrs. Then the DFDBA plus autogenous bone graft was placed at the defect area and was secured with the help of retention screws, and the suturing was carried out. Then we have the 6 months follow-up photograph where we can see adequate healing being achieved. Unfortunately, after 6 months, we could not have a follow-up with the patient due to some financial issues by the patient and also some personal problems. The patient reported back to us after 2 years, and after 2 years, the retention screws which were used for stabilization of the chin block were removed, and a CBCT scan was done. The CBCT reports stated that there was adequate width of the block being achieved, and the implant placement could be done. So the dentium NR-Line implants were selected with the dimension of 3.6 by 9 mm. And on the day of implant surgery, mid-crestal incision was given and the full thickness flap was reflected. After the full thickness flap reflection, the osteotomy sites were prepared and the parallel pin placement was done with 2.1 and 2.2 region to check for the angulation, and 2 endosseous implants were placed. After placement of 2 endosseous implants, we used DFDBA to cover the exposed implant threads, coronal threads of the implants with the 2.2 region. Suturing was carried out, and then we have the post-operative radiograph, which states that which shows that the implants were inserted in correct angulation, and there was also primary stability being achieved over here. So coming towards the discussion part, reconstruction of an aesthetic implant restoration requires greater clinical and technical skills. An aesthetic implant restoration should be harmonious with the patient's facial appearance and the rest of the dentition. The margin, color, and the contour of peri-implant mucosa should be symmetric with that of the contralateral teeth and or implants, and the papilla should fill the interproximal space. The shape, contour, shade, and proportion of the implant restoration should be optimal, and most importantly, the implant restoration must have a pleasing appearance that is acceptable to the patient. Deficient alveolar ridge often makes an implant placement difficult, so augmenting the ridge defects by placing various grafts and barrier membranes facilitates the implant placement. In this case, it was the Sievert's class 1 defect, that is the defect in facial width, that was successfully treated by grafting with chin block and DFDBA followed by delayed implant placement. So the chin block, it offers wide range of advantages and disadvantages. The advantages is that there is a horizontal bone volume increase documented up to 7.5 mm as compared to 4.5 mm documented by the particular GPR techniques. Also, the optimal bone density for implant stability due to the cortical nature of the graft. Then the rapid integration allows early re-entry for the implant placement, often in 3 to 4 months as compared to 6 to 9 months with the particular GBR techniques. And the locally available donor sites avoid the need for extraoral autogenous bone sources. So this case was simulated a case report which was published by Kalmish in 1992, in which the author made use of mandibular symphysis grafts to restore the partially edentulous patients with alveolar defects, which were contraindicating the implant placements. And the results of the study, they showed that compared to other bone regenerative methods for implant placement, a superior quality of bone was found and shorter healing period was required, and that the chin graft offers a viable alternative for reconstruction alveolar defects prior to implant placement. Another study which was taken into consideration was efficacy of guided bone regeneration using composite bone graft and resorbable collagen membrane in Sievert's class 1 ridge defects, which was a radiological evaluation being done by Pushkarajan et al. In 2013. So coming towards the conclusion, placing an implant in previously augmented zone that has undergone trauma has always been a challenge to the dentist because of wide variety of complications encountered during placement and also after the placement of implants. It is important to assess alveolar ridge deficiencies before implant placement for its long-term survival and no complications. The mandibular symphysis graft is composed of on average of 65% cortical bone and 35% cancellous bone. The cortico-cancellous nature of the graft facilitates faster vascularization, resulting in more rapid integration. This case report demonstrates that implant placement can be successful in Sievert's class 1 defect treated by chin block augmentation. These are the references that we have used for this case. Thank you.
Ma'am and sir, you may start with question and answer session.
What is the difference between the block graft taken from the ramus area and the symphysis area?
Good afternoon. Ma'am, if we consider the symphysis area,
The symphysis area, it offers the corticocancellous nature of the graft. As stated, the symphysis area, it offers 65 and 35%, at 65% of cortical
That
bone
you've
and
already
35%.
stated. What about the ramus area?
Ma'am, if we consider the symphysis graft, ma'am, there is better healing which is achieved, and
You told me the ramus. If you take a cortical bone graft, block bone from the ramus area, what is the difference? Is it of the same nature?
Ma'am, if we consider the healing which will be achieved, ma'am, with symphysis, ma'am, it will be.
If we are not going for a cortical block graft, what else? What other option you can do in this area?
Yes, ma'am. Ma'am, if we are not going for the bone block grafts, we can use a titanium mesh, and then the bone grafts can be used to stabilize the.
Sir, you can proceed. Do we have another chairperson here?
Ma'am, Dr. Abhishek Verma, sir.
Dr. Abhishek, you can take up the questions.
He's not online now. Question.
Okay. Can you say something about sausage technique? You know about sausage technique?
Yep.
It's all right. It's a nice presentation. Good case.
Thank you.
Thank you, Dr. Ketan Rajput. Our next presenter is Dr. Asuk Raj VM.
A very good morning to all and all. Today, I'm going to present a few cases about rich pattern as a promising periodontal regenerative materials. Periodontitis is an immunoinflammatory disease affecting the supporting tissue of the teeth, characterized by loss of connective tissue attachment and supporting annular growth. So the aims of the periodontal therapy is to eliminate this inflammatory process or prevent its progression of this inflammatory process and to facilitate the regeneration. The regeneration can be referred as the ultimate goal of the
Ma'am, it's not audible. I'm not able to hear anything.
inexpensive autologous growth factor delivery system is critical. The Chopon town in 2000 suggested this
Ma'am, this is the maximum sound of video.
Which is
Can you be hello?
Used as this autologous growth factor delivery system.
Hello.
Coming to this.
Hello. Can it be a little louder? There, I had some connection error. I wanted to ask question with the last session. Anyway, that ended up.
That's it.
Can it be a little louder?
Yeah, this is the maximum volume of video. So just wait for the end of this video. Then you can question.
Areas exposed by raising of glycopatous plaque, and then the thorough debridement is carried out. And after that, the PRF membrane is placed and this plaque is sutured back. These are the follow-up radiographs. In 4-year follow-up, you can see evidently see the bone fill in this angular defect, and this is the 6-year-old 6 years follow-up radiograph. Here also, although there is a slight angulation problem in this radiograph, but still we can appreciate this bone fill in that angular defect. This was another case, a 44-year-old male patient. After the phase 1 therapy, there was a residual pocket of around 10 millimeter in the distal aspect of maxillary molar. There was around 3 to 4 millimeter recession also there. In the radiograph, we can see the evident bone loss, extensive bone loss, extending beyond the apex of this distal buccal root, and the percussion involvement is also evident in the distal buccal root and palatal root. In this case, our treatment plan was to go with the root resection of this distal buccal root. The root canal treatment was completed before the procedure, and then the mucoperiostral plaque is raised. The area is thoroughly debrided, and here the distal buccal root is resected, and this defect is filled with PRF membrane. These are the follow-up radiographs. In 6 years, we can see the evidence of bone fill in this case. And this is another case, a 28-year-old female patient. There was a pocket depth of around 7 millimeter in the initial aspect of this central insert 1-1. And in between this lateral insert and canine also there was deep pocket around 8 millimeter. The radiographic picture correlate with the clinical findings. Here you can see this angular defect in between this central insert. Here also stitching bone loss is there in between this lateral and canine. This plaque here, mucoperiostral plaque is raised, and the defect, the area is debrided thoroughly. And here we used xenograft along with this PRF membrane. Xenograft is placed, and orange PRF membrane is placed, and the plaque is sutured back. These are the post-operative photographs, and these are the follow-up radiographs. We can see in Korea follow-up there is evident, bone fill is evident in both these sides, in between the central insert and in between lateral and canine. There is bone fill is evident. This was another interesting case. There was around 10 millimeter pocket in the distal aspect of both the mandibular molars. In maxillary molar also there is around 7 millimeter pocket depth in the it is on the buccal aspect actually. In this patient, all the 4 quadrants, the premolars, the roots were bifurcated. That anatomical defect may be one of the contributing factor for this extensive bone loss. Here you can see the bifurcated roots. The defect is exposed by raising the mucoperiostral plaque, and then the area is debrided thoroughly. Here also we placed a xenograft along with the PRF membrane. First the xenograft is placed, and over which the PRF membrane is placed, and the area is sutured. Now in this follow-up radiographs, we can see the even inside them in this long linear and maxillary radiographs. These are the clinical pictures in the follow-up radiograph, follow-up appointments. Coming to the discussion part, patients treated with PRF shows an improvement in the clinical parameters as measured by problem pocket depths and clinical attachment levels. Patient showed a significant level of bone fill in radiographs, and bone fill obtained in this case are indicative of regeneration of attachment apparatus. Sanchez et al. In 2003 suggested that the affinity of the osteoblast to the PRF membrane appears to be superior than the PRP, the affinity of osteoblast to PRP. Dohan et al. In 2006 suggested that we saw a slower release of growth factors from PRF when compared to PRP. It is responsible for the better healing properties of the PRF. And R. Joseph et al. In 2012 suggested that the increased regenerative effect in the platelet-rich fibrin in the treatment of human three-wall intrabony defects. And he also, in another study in 2014, suggested that clinical use of PRF in both gel and membrane form is more effective than open flap debridement alone in horizontal periodontal defects. In an article in this Journal of Clinical Periodontics in 2017, suggested that the favorable effects on hard and soft tissue healing and the post-operative discomfort reduction were often reported when LPRF was used. The standardization of protocol is needed to obtain an optimal effect of LPRF in regenerative procedures. Correct handling of LPRF as well as the use of enough cloth membrane cloths or membrane per surgical site might be crucial to obtain the benefits from this technique. PRF can be taken into consideration due to its reported good biological effect, low cost, and ease of preparation. To conclude, platelet-rich fibrin is an autologous complex fibrin matrix with strong fibrin architecture. It is a reservoir of growth factors and cytokines that can jumpstart the healing process to a more predictable preservative process. Be easy to use, safe, and cost-effective. Thank you.
And sir, start with question answer session.
No. No.
The audio was not very clear. Your presentation audio was not clear. The collection of cases is good, the results are good, but the thing was it was not audible at all. Why do you say PRF is better than PRP?
Yeah, in PRF, the release of growth factor is much slower, so it has much better healing properties, and the consistency also, it is a gel type or membrane type consistency. We can place it more comfortably.
Placement cannot determine the healing qualities, I guess.
Hello, ma'am?
Can you give more detailed explanation about it?
About what, ma'am?
PRF and PRP?
I have mentioned a study in the presentation itself that the PRF shown better healing properties when compared to PRP, and it is probably due to the slower release of the growth factors.
It is in both.
No, the rate of release of growth factor, in PRF it is long lasting effect is there compared to PRP.
Any other thing?
Hello.
It's all right. You can take over, Dr. Abhishek.
Yeah. Do you find any difference with the manipulation of this membrane? Difference with your traditional membranes?
This is somewhat a gel type in consistency, so it is initially it is difficult, but when we are used to it, it become easy.
Do you have any time limit for the viability of these membranes?
2 hours.
2 hours. Okay, fine.
Dr. Ashok, our next presentation by Dr. Sonayana Boro, Dr. Faria Asraf, Dr. Prasansa Sarma.
Good afternoon. The topic of our case series paper presentation is a novel coronally advanced flap technique with modified triangular incisions in the treatment of Miller's class 1 gingival recession, a case series. Coming to the introduction, gingival recession is defined as the exposure of the root surface as a result of apical migration of the gingival margin to the seal chain. It can be either localized or generalized. Clinically, it results in sensitivity, unesthetic appearance, and if left unchecked, may result in extrusion of the tooth, mobility, and finally, tooth loss. Coming to the treatment modalities, it can be either non-surgical or surgical. Non-surgical has desensitizing agents, varnishes, and dentin bonding agents, composite restoration, removable gum veneers, scaling, and root planing. Surgical has connective tissue graft, pre-gingival graft, guided tissue regeneration, coronally advanced flap, etc. Selection of appropriate surgical techniques depend on different factors, some of which are related to the patient, while others are related to the anatomical characteristics of the defect. The coronally advanced flap is the most suitable surgical procedure in cases where there is adequate keratinized tissue apical to the defect. It shows optimal root coverage, great color blending with adjacent soft tissues, and good re-establishment of former soft tissue, the morphology, and does not require a second surgical site as compared to subepithelial connective tissue graft. Recently, Zusheli et al. In 2016 compared the triangular design with the trapezoidal design in coronally advanced flap procedures and found similar results with regard to root coverage and contiguity. However, the triangular design was associated with less scar formation. Thus, keeping all this in mind, the aim and objective of the current case series is to evaluate the outcome of modified triangular coronally advanced flap in the treatment of Miller's class 1 recession. The methodology is as follows. 3 patients with gingival recession reporting to the Department of Periodontology and Oral Implantology in ITS Dental College were selected for this case series. The inclusion criteria are as follows. Age more than 18 years, periodontally and systemically healthy, isolated Miller's class 1 recession defect, presence of at least 1 mm high keratinized tissue apical to the root exposure, presence of identifiable cemento-enamel junction, presence of root abrasion but with an identifiable cemento-enamel junction, subjects who will be willing to sign the informed consent form. The exclusion criteria are as follows. Medically compromised, taking medications known to interfere with periodontal tissue health or healing, previous periodontal surgery on the involved site, pregnant and lactating females, recession defects associated with demineralized or caries, deep abrasion, restoration, as well as teeth with evidence of pulpal pathology, smokers and tobacco users, molar teeth. The clinical parameters were assessed with the help of a custom-made acrylic stent for standardization with the help of a UNC15 probe. The parameters assessed were gingival recession, probing depth, width of keratinized gingiva, attached clinical loss, clinical attachment loss. They were assessed at baseline and at 3 months post-op. The surgical procedure is as follows. The surgical area was anesthetized using local anesthesia, and the exposed root surface was scaled and planed using hand instruments. The length of a curved line parallel to the CEJ, which is the cemento-enamel junction, connecting the papilla tips and passing through a midpoint located 1 mm coronal to the cemento-enamel junction, was measured with an orthodontic wire, which represented the extension of the flap's marginal perimeter of the coronal advancement. The wire was then shifted to the most apical extension of the recession defect, and each half of it was bent along the gingival margin of the recession. 2 oblique vertical incisions of the triangular flap was given at the ends of the orthodontic wire and extended parallel to the soft tissue margin of the adjacent healthy teeth beyond the mucogingival line. The flap was then elevated following a full split thickness approach in the coronal apical direction, and finally it was secured using interrupted sutures. Coming to the results, an increase in clinical attachment level was seen at 3 months follow-up as compared to baseline. While comparing probing depth and recession height, better results were seen at follow-up visit than baseline values. Coming to the cases, this is the result of the first case. The first picture is at baseline and the second is after 3 months post-op. The second case, the first picture is at baseline, the second is at 3 months post-op. And the last case, first picture is at baseline and the second picture is at 3 months post-op. Coming to the discussion, the present case series indicated that the triangular coronally advanced flap design can be successfully used to treat gingival recession defects in patients with aesthetic demands. The rate of successful outcome for the treatment was similar to that previously reported in a case series study on coronally advanced flap for single gingival recessions in which a trapezoidal coronally advanced flap was used. While assessing the color matching and contiguity, the flap design demonstrated good results in follow-up visit. In the triangular coronally advanced flap, the shape of the surgical papilla is the same as the anatomical papillae. Thus, a precise soft tissue adaptation in the interdental area showed improvement in camouflaging of the treated site when comparing to a trapezoidal flap design. The risk of scarring is also considerably low in triangular flap design, as the releasing incisions are inside the de-epithelialized recipient bed and are covered by the flap, as compared to trapezoidal flap where the position of releasing incision sutures and hence more scar formation is seen. Aesthetically, the flap design showed good patient satisfaction at 3 months follow-up. Thus, It can be concluded from this case series that coronally advanced flap with triangular incisions can be used as a reliable root coverage procedure, resulting in good clinical outcomes and satisfying aesthetics. The following are the references we have used in our case series. Thank you.
And sir, it's time for question and answer session. Sir, you can proceed first.
Hello. Hello. Is it audible?
Yes, sir. It is audible, sir. Sir, it is audible.
Okay, fine. Have you heard about MIST? M-I-S-T.
Yes, sir.
What is that?
So it is a minimally invasive surgical technique where it's a technique for papilla preservation, where it was given by Cortellini and Tonetti. There are two types, which is simplified papilla preservation technique and modified papilla preservation technique. It is used when there is when the interdental papilla is less than 2 mm, then more than 2 mm. Sorry.
Is it a useful procedure?
Yes, so for preservation of the interdental papilla.
And can it be done or maybe used in your surgical procedures?
So, yes, sir. No, sir, because there is not.
Ma'am, you continue, please. Vinita, ma'am, you please continue.
Sure, sir. Why did you opt for this technique?
Ma'am, because it was because it was class 1 recession and
what other options you had?
Ma'am, I had Vista or normal coronally advanced flap with normal trapezoidal design, or Vista.
What size of sutures you have used here?
Ma'am, sling suture for coronal advancement and interrupted for a vertical
size.
Ma'am, 440 silk suture.
Can you improvise or you can do something better? You could have done better in this study while looking at your cases?
Yes, ma'am. We could have taken better pictures.
Under magnification, you could have done, no?
Yes, ma'am.
Okay.
Thank you, Dr. Sunayana Boro. Our next presenter are Dr. Sai Charan Dasari and Dr. Talasini Roja.
Hello, good morning, everyone. This is Dr. Sai Charan, and I, along with his colleagues, Dr. Chandrika and Dr. Roja. Hello. We are here to present a case report which is about alveolar ridge preservation using a novel synthetic grafting material, followed by implant placement with osteodensification and APRF.
Grafting material followed by implant placement with osteodensification and advanced PRF. Coming to the introduction, tooth loss is best treated with the help of implants. Now for the implant to be placed, the socket has to be preserved to reduce bone loss after tooth extraction. Implant placement becomes challenging when there is significant bone resorption. Without socket preservation, bone loss takes place at a faster pace, which is 30 to 60% in the first 6 months of extraction, which can be prevented by placement of advanced bone grafting material and techniques. And this is a case presentation. A 47-year-old female patient with non-contributory medical history presented with a non-conserved bubble maxillary lateral incisor, which got fractured due to trauma. And this is a clinical picture showing traumatized tooth. And after thorough clinical and radiographical examination, socket preservation was planned and followed by implant placement. And coming to a surgical procedure, atraumatic extraction of the fractured root has been done, and these are the clinical pictures showing fractured tooth and extraction socket. And these are the socket preservation materials, which is a bone grafting material and a PRF membrane. And for socket grafting material, dentogen is used, which is a medical grade bone graft. On absorption, it leaves a calcium phosphate based osteoconductive scaffold that enhances the bone regeneration. And after placement of bone graft, the socket was covered with the PRF membrane, which increases the neoangiogenesis and attracts the stem cells, favor the migration of osteopolyenter cells into the center of the graft. And after that, the flaps are approximated and sutured, and periodontal dressing is given, and patient is regarded after 9 months for implant placement. And this is a radiograph after 9 months. It's showing adequate bone fill in the socket preservation site. And this is a picture showing adequate bone after flap reflection in surgical re-entry. And for the implant placement, osteotomy site is prepared with osteodensification drills, which conserves and expands the residual alveolar ridge for the improved implant primary stability. And this is the osteodensification drill kit used for the osteotomy site preparation. And after implant placement, these are the clinical pictures showing implant placement with cover screws placed in position, and this is a radiograph showing implant in position. And after the placement of implant, the site was covered with PRF, which is advanced type of PRF, which is expected to contain greater number of white blood cells. And these are the clinical pictures showing PRF membrane, and this is a picture showing after membrane placement. And after that, the flaps are approximated and sutured. And this is the temporal provisionalization picture after 2 weeks. And in summary, these are the pictures showing radiographs. Preoperative CBCT showing traumatized root. And this is after 9 months of CBCT. 9 months CBCT showing adequate bone fill, which is favorable for placement of an implant. And these are the radiographs showing preoperative and post-operative implant placement, before and after implant placement. And in coming to the conclusion, it was concluded that the calcium sulfate hemihydrate used for socket preservation resulted in regeneration of high quality bone, which is able to support an implant. PRF paste resulted in the enhanced healing with adequate soft tissue coverage. The use of osteodensification discs resulted in the increased implant primary stability, and PRF used after the implant placement have enhanced the healing and osseointegration. And thank you, and maintain social distancing, stay home and stay safe.
Ma'am and sir, you can start with question and answer session.
So you can proceed.
Yeah. Hello.
Hello, sir.
Yeah, you mentioned about the socket preservation, right?
Yes, sir.
So regarding this prognosis or the success of implants, so whether this augmented site is more useful or non-augmented site, means fresh extraction site.
According to the studies, both are same after 6 months after placing implants, sir.
If you are augmenting a socket with a autogenous bone graft or maybe adding a synthetic bone graft, is there any relation with the success of the implant as compared to the deficient non-augmented socket?
Actually, no, sir. They are actually the preserved site and non-preserved sites are both can support the implant placement.
Okay, fine. If you're going a socket preservation, can we go for a routine two-stage implant surgical procedure?
Yes, sir. We can go for routine two-stage implant procedure, and
Maybe
the bone have to.
Yeah, please.
And the bone have to be healed for implant placement, no, sir. So we got to go for two-stage implant placement.
So what do you recommend? We should go for a two-stage or one-stage, single-stage implant placement?
Actually, it is better to go a two-stage implant placement.
Ma'am, please.
Why have you preferred using an APRO? Just that
Actually,
it has white blood cells?
Yes, sir. Yes, ma'am. It contains more white blood cells than
Apart
standardized
from
PRF. Apart from that, it has a more number of growth factors than standardized PRF.
As compared to?
Standardized growth PRF.
How does it affect using a denser burr or osteodensified and a normal burr? What difference does it make?
Actually, while doing the osteotomy, the conventional drills will extract the bone, ma'am. So while we are using osteodensification drills, the drill itself conserves the bone and it compacts the bone on the lateral walls of the osteotomy side. So
what difference does it make in osseointegration?
In osseointegration, while using. Sorry, ma'am.
Can you state some points?
Yeah, as we are using osteodensification drills, it increases the primary stability of the implant, ma'am. So itself will.
Can you quote the study?
No.
It's all right. Nice presentation.
Okay. Thank you.
Thank you, Dr. Sai Charan. Next presentation by Dr. Kriti Anil Sirgaonkar.
Greetings to all. As the quote goes, the comeback is always stronger than the setback. Today I'm going to talk about sinus elevation, a way to rebuild the sinus that would help to replace and restore the missing teeth. Let me start by introducing myself. I am Dr. Kirti Anil Sirgaonkar, and the topic for my case series is of maxillary sinus elevation and augmentation for dental implant placement. Today I'm going to talk about two case reports of sinus elevation, one with immediate implant placement and the second one with a delayed implant placement. There are various treatment modalities available for replacement of missing teeth. Under removable, we have the conventional removable partial denture, and under fixed, we have the fixed partial denture and implant supported prosthesis. As the modern dentistry suggests, with the prevailing implantology, the re-evaluation of posterior maxilla by the use of implants is a challenge due to its reduced vertical bone height and a normatized sinus. But there are various modalities in order to help this physiological limitations. But the treatment by short implants proves to be a challenge due to its literature that suggests its inability to bear the occlusal forces and the zygomatic implants with its difficult accessibility and technique sensitivity. Hence, the best treatment option available is the sinus elevation. The sinus elevation can be done by the direct approach, that is the lateral window approach, and by indirect sinus elevation, which is osteotome mediated, piezoelectric, hydrodynamic, or balloon mediated. Another point to be kept in mind for sinus elevation is the timing of implant placement, whether it is immediate implant placement or a delayed implant placement. So with this background, I would like to go ahead with my case report. The first case for today is Mr. Uday Dupal, 55-year-old male with no relevant medical history, with a chief complaint of replacement of missing 1/6. After the treatment plan was started as the patient chose implant, a CBCT was suggested. CBCT revealed that there was a reduced bone height. Hence, a maxillary lateral window elevation with the immediate implant placement was chosen for the patient. The process's delivery was to be done after 6 months. After administration of local anesthesia, incision was given and a full thickness mucoperiosteal flap was reflected. Excess window preparation was done using a slow spring handpiece with continuous irrigation to avoid any bone necrosis. Osteotomy site was prepared of 15 by 20 millimeters dimension, and the sinus membrane elevation was done with a blunt sinus elevation curate. Care was taken not to perforate the Schneiderian membrane. After adequate care was taken and no perforations, the osteotomy site was prepared for implant placement. The implant was placed using the implant driver. Bone grafting and membrane placement was done before the flap closure and primary closure was achieved. After 6 months, the prosthetic abutment was placed and final prosthesis was given to the patient. The second case for the day, Mrs. Vidya Bedike, 47-year-old female with no relevant medical history and with the chief complaint of missing teeth that needed replacement. The treatment plan for this patient, as according to the patient's choice, was implants. After an OPG that was taken, it was revealed that there was pneumatized sinus and reduced bone height. A maxillary lateral window sinus elevation with a delayed implant placement was done after 6 months and prosthesis delivery 6 months following the implant placement. After administration of adequate anesthesia, incision was given and a full thickness mucoperiosteal flap was raised. After a particular osteotomy site was prepared, the sinus membrane was elevated using a blunt instrument. It was made sure that there was no oral-ventral communication, after which the primary closure was achieved. After the 6 months, pre-operative view was as follows. Crestal and clavicular incision was done to expose the underlying bone. A full thickness mucoperiosteal flap was elevated. Sequential drilling was done, and implants were placed and bone grafting was done. Sutures were placed. This is the 15 days post-operative image. The prosthesis is placed after 6 months of implant placement. This is the pre-operative and post-operative OPG of the same patient. Post-operative instructions given to both the patients, application of ice within the first 24 hours of the surgery. Smoking was strictly contraindicated. Use of straw and blowing of nose was strictly contraindicated as it would create negative pressure. If the patient had to sneeze, he was advised to do so by keeping the mouth open, and post-operative medications were prescribed to the patient. Coming to the discussion. The lateral window technique was given by Tatum et al. In 1976 and further described by Boyne and James in 1980. It's indicated in case of inadequate residual bone height and a pneumatized sinus. It's contraindicated in case of active or recurrent sinusitis, in case of neoplasms related to the maxillary sinus, in case of previous sinus elevations, in case of radiation to the maxillary sinus, uncontrolled diabetes, and chronic smokers and chronic alcoholics. According to Zittman et al., the lateral entrostomy resulted in a greater amount of bone augmentation. However, a larger surgical access was needed. According to Wu et al. In 2004, the crestal approach was minimally invasive. However, it resulted in a limited amount of bone augmentation. This is the flowchart for decision making. Whenever there is a vertical residual alveolar height of greater than 5 millimeters, an indirect technique is opted for. If the remaining bone height is less than 5 millimeters, then maxillary sinus floor augmentation with a lateral window technique is done. If the implant stability is poor, then a delayed implant installation is done. If there is good implant stability, simultaneous implant installation is carried out. Immediate implant placement. If the primary stability is good, it will result in a long-term predictability. Since there will be one surgical site, there is reduced treatment time, reduced patient morbidity, and reduced cost. In case the implant stability is questionable, a delayed implant placement is opted for, which results in an increased treatment time, increased patient morbidity, and increased cost. Next, I would want to highlight a few complications. Under intraoperative, the following complications, of which osteomyelial complex obstruction, alveolar ridge fracture, and membrane perforation. For the early operative complications, incision line opening, implant failure, and infraorbital nerve paresthesia. For late operative complications, implant failure and implant migration. I would want to conclude my presentation by saying that a surgical intervention by direct sinus lift technique successfully enhances the vertical alveolar bone height of posterior part of maxilla before implant placement or in conjunction with installation of implants. These are my references. Thank you.
Ma'am and sir, you may start with question answer session.
I have a question. Why do we avoid smoking during a sinus lift procedure after sinus lift? Can you state 2 reasons for that?
Yes, ma'am. It might result in infection during that period of time. So that is one of the factors because of smoking. And also it will create a negative pressure after the surgical procedure that might.
And why do we say, how will you differentiate the healing in a sinus when you are grafting a sinus area and a normal area? How will you differentiate the healing that is? How will you compare it?
Ma'am, I don't know this answer.
Dr. Abhishek, you can continue.
Nice presentation, Dr. Kriti.
Thank you, sir.
I just have one question. If at all it happens to perforate the sinus area, so how come what will
So I'm getting a disturbance.
Post-management?
So if the sinus is perforated, the first intraoperative management will be performing a Valsalva maneuver to see if to confirm if the perforation is existing during the clinical procedure, followed by which the perforation first care is to be taken to close the perforation which has occurred. So suturing the particular area or placing of grafts for healing of the same region should be done. And the surgical procedure which is planned for can be postponed. First of all, the care of the perforation should be carried out. Post management.
Okay, fine. No questions.
Thanks.
Okay, thank you, Dr. Kirti. With this, we end our session. Thank you, Dr. Vinita ma'am and Dr. Abhishek sir, for taking out your valuable time and being a part of this virtual PG convention. So, thank you, sir. Thank you, ma'am, very much.
Thank you.
Thank you. Thank you.
Thank you,
Dr. Abhishek. Nice meeting
you, ma'am.
Now, I would like to invite Dr. Sachin K. Malagi, Professor and Head, Department of Periodontology, Maitri College of Dentistry and Research Center, Durg, Chhattisgarh, and Dr. Padmakant Manwa, Professor and Head, Department of Periodontology, Gitanjali Dental and Research Institute, Rajasthan, to start this session. And our presenter is here, Dr. Mansa Budhan.
Good morning, respected judges. My paper presentation is on the topic Maxillary Sinus Floor Augmentation Techniques for Compromised Alveolar Ridges case report. Coming on to my introduction, dental implants have become the standard care for rehabilitation of missing teeth, and in healthy patients, the success rate of dental implants range between 90 to 95% at 10 years, and the patient's health conditions and bone quality are two important determinants of dental implant survival. The maxillary posterior edentulous area presents difficult situation in implantology, and this is due to bone atrophy and pneumatization of the sinus, and this can be reconstructed by sinus elevation. Maxillary sinus. So this is the maxillary sinus, which is pyramidal in shape and the largest paranasal sinus, and it is also called antrum of Highmore. And the boundaries of maxillary sinus are the apex points towards the zygomatic bone. The roof is made by the floor of orbit, and the base and the floor is formed by the roots of molars, and the walls are formed by the lateral wall of nasal cavity. The anatomic considerations are sphenopalatine artery, infraorbital artery, and superior alveolar arteries. And the infraorbital nerve and superior alveolar nerves, and facial nerve, and pterygoid plexus. These should be considered while doing a sinus lift. The two surgical approaches that have been used are the lateral window or the direct approach and the indirect approach. The subantral classification of the posterior maxilla, which was given by Mish in 1984 and later revised in 1987, SA1, SA2, SA3 and SA4. SA1 where the residual bone height is more than 12 mm and does not require sinus lifting. SA2, SA3 and SA4 requires sinus lifting. SA2 where the residual bone height is 10 to 12 mm, SA3 5 to 10 mm and SA4 less than 5 mm. The indications of sinus elevation are no history of sinus liposis, insufficient residual bone height, severely atrophic maxilla, and poor bone quality and quantity in the posterior maxilla. The contraindications include recent radiation therapy in the maxilla, uncontrolled systemic diseases such as diabetes mellitus, and maxillary sinusitis, chronic infection of the maxillary sinus, heavy smoker, alcohol abuse, psychosis, severe allergic rhinitis, tumor cyst in the maxillary sinus, and oroantral fistula. The complications include intraoperative, early postoperative, and late postoperative. Intraoperative include bleeding, buccal flap tear, infraorbital nerve injury. Early postoperative complications include incision line opening, bleeding, barrier membrane exposure, and late postoperative complications include graft loss, implant failure, and implant migration into the sinus. And the postoperative infection rates are reported as 2% and 5.6%. These are some of the evidence-based reviews. The summary of success rate data from crestal sinus floor elevation studies, and the success rate ranges from 94 to 100%. And another study where the sinus lift up procedure in dental implants, systematic review and meta-analysis was performed, and the result shows that immediate implant placement has high rate with average bone height increase of 4.7 mm. These are the sinus elevation armamentarium. Moving on to my case report of direct sinus lift. Patient age 62 years old, male patient. Patient complains of loosening of teeth in the upper jaw for past 1 year, and the diagnosis was generalized periodontitis and partially adventurous mandible. And the prognosis for 1615, 25 and 26 were hopeless, and treatment plan there was we recommended extraction of 1615, 25 and 26, and direct sinus lift was planned as residual bone height was 2.63 and 3 mm on left and right and left side, and the implant placement in 1516, 25 and 26 was planned. So treatment plan was sinus lift in 16 and 26 region. So 16 region, incision and flap reflection was done. Lateral window was created using carbide bud, and sinus lifting was done, and osteograft and cybograph was placed, and single interrupted suture was given. And in 26 also the same way the procedure was carried out and sutures were placed. This was the pre-op residual alveolar bone height 2.63 and 3 mm in right and left respectively, and post-operative after 3 months of sinus lift it was 13.57 mm in the right and 11 mm in the left. Implant placement after 3 months was carried out, and incision and flap reflection was again done. Sequential drilling 2 mm short of the sinus floor, and implant placement in relation to 1516 2526 was done. And after implant placement, this is the OPG of the patient. Case report 2 of indirect sinus lift. A patient aged 37 years old, male patient. Patient complains of missing teeth in the upper left back region of jaw for past 2 years, and diagnosis was partially edentulous maxilla. And the treatment plan was indirect sinus lift and implant placement in relation to 15 and 16, as the residual bone height was 7.06 mm. The treatment done was incision and flap reflection, sequential drilling 2 mm in short of the sinus floor, osteotome placed, and floor of the sinus was fractured, and bios was placed as graft, and implant placement in relation to 25 and 26, and sutures were placed. P-repeatment placed. This was after 3 months of sinus elevation, and peak abutment was placed, and silicon impression was made, and screw retained PFM crowns were fabricated, and crown placement was done in relation to 2.5 and 2.6. This was the pre-op residual alveolar ridge height, that is 7.06 mm, and post-operative 14 mm. Conclusion: maxillary sinus is a safe, reliable, and successful surgical procedure provided the fundamental principles of the technique are strictly adhered to. And there are risks, but the risks are small, and possible post-operative complications amenable to the treatment through medication and surgical interventions. Different materials have been tried as graft, but the autogenous bone remains the gold standard. And recent studies have focused on the use of stem cells in the combination with various graft materials, and it shows promising results but require more evidences. These are my references. Thank you.
Dr. Sachin sir and Dr. Padmakant sir, you may start with question and suggestion.
Okay. Dr. Padmakant, start. Padmakant sir?
Yeah, your audio is not audible as such. It's very feeble. Yeah.
You can.
Okay. You have performed osteotomy-mediated sinus floor elevation. So there are some complications. Sometimes you might land up in a perforation. How did you find out whether there was no perforation or not? Or what are the methods where we can find out perforation has occurred or not?
So we can actually do a Valsalva maneuver, perform a Valsalva maneuver technique and find out, or else we can after if it is after grafting, we can actually take radiograph and find out if the dome is present, if the dome shape is well defined. If it is present, then we can find out if the sinus perforation is there.
Have you heard about Lama Linda pouch?
Sir,
Lama Linda pouch.
no, sir. I'll have to read about it.
It's okay. It's in the management of perforation. When there's a perforation, you treat it by the Lama Linda pouch. That is one of the technique. Okay. I think Dr. Sachin can pose some questions.
I just have one doubt that is what I saw in your slides. You said there is contraindication for diabetes mellitus. So we cannot perform any kind of sinus lift procedures in diabetes, according to you?
No, sir. It's not an absolute contraindication. It's just a relative contraindication. Only in case of uncontrolled diabetes mellitus cases, we'll have to wait for the diabetes mellitus to be controlled, to be brought into a controlled level to perform, as it can compromise with the healing.
And the same thing in smoking also. So
Yes,
what are the problems with smoking if you perform sinus lift procedures and implant placement in a smoker?
Sir, there again, the negative pressure will be present, sir. Also, the vascularity will be reduced in such case. So again, delayed healing will be a problem that will be faced.
But ideally, maxilla is highly vascularized, no? Does it really make any difference?
Yes, sir. Actually, it makes difference. That's what I read in articles too.
No more questions from myself.
Thank you, Dr. Mansa. Our next presentation by Dr. Aisa Khatri.
Hello, myself Dr. Aisha Khatri, presenting the paper on the gingival recession coverage with a bridge flap technique. Gingival recession is one of the most common aesthetic concerns associated with the periodontal tissue. It is defined as the exposure of the root surface due to the displacement of the gingival margin apical to the cemento-enamel junction. There are many techniques that have been developed for the treating the gingival recession. Isolated gingival recession has been a reasonable extent of a success, but when there is a multiple gingival recession, it has been remains an actual problem. Almost every gingival recession coverage procedure requires an adequate zone of attached gingiva, which is not always present. So the second surgery prior to that it has to be done to increase the width. Bridge flap, it is a single-step surgical procedure for the multiple recession with inadequate width of attached gingiva, which combines the vestibular extension procedure and coronally reposition flap. In present case series, two cases of multiple gingival recession has been treated with the bridge flap technique, which are first case was a female patient aged 38 years presented in Department of Periodontics with the chief complaint of a receding gum in the lower anterior teeth. Clinical examination revealed a grade 2 Miller's classification of the gingival recession in a 3-1 and 4-1 teeth, with the inadequate zone of the attached gingiva and shallow vestibule. Clinical parameters were recorded with the UNC 15 probe. They were a probing pocket depth, gingival recession, and width of attached gingiva. Probing pocket depth was a 1 mm, recession was about a 5 mm in 4-1, 3 mm in a 3-1, and width of attached gingiva was less than 2 mm. Surgical technique, after administering a local anesthesia of a 2% lignocaine and 1 by 80,000 epinephrine, and vestibular incision was made, which, including the one extra teeth from both mesial and distal side of the from the gingival recession site. The incision was given into the periosteum at approximately 2 into the gingival recession plus 2 mm from the distance of the gingival margin, as we can create an adequate width of a flap which was prepared later. The bone was exposed so that the scar formation could occur. A split thickness flap was elevated in apicocoronal direction by making a circular incision and connecting it with the first incision, and the whole bridge flap was elevated. The flap is then repositioned coronally, covering the denuded root surface, and then pressed for 3 minutes to avoid any dead space, and then independent sling sutures were placed. After that, periodontal pack was applied on the operative area covering the exposed bone. Amoxicillin 500 mg and ibuprofen 400 mg thrice daily was given post-operatively, and other instructions were also given. Suture was removed on the 7th day, and the patient was asked to maintain the oral hygiene meticulously and then recall after 1 month. On 1 month recall, we can evaluate the gingival recession was reduced from a 5 mm to 2 mm, and width of attached gingiva was increased from 1 mm to 4 mm. The second case I have done was gingival recession in lower anterior 3-1 and 4-1 with the inadequate width of attached gingiva and high frenal pull. As you can see here, the tension test was a positive. Gingival recession was of 6 mm in a 4-1 teeth, and width of attached gingiva was a 1 mm. Vestibular incision was given, bridge flap was prepared, and then coronally repositioned and sutured. Periodontal pack was given. At the 7th day, suture removal was done and patient was recalled after 1 month for evaluation. You can see here the reduction of the gingival recession from 6 mm to 3 mm and increase in the width of attached gingiva from 1 mm to 5 mm. Thus, various surgical procedures are used to treat the gingival recession, like a coronally advanced flap, semilunar flap, lateral pedicle flap. All of them are require adequate width of attached gingiva, which is not always present, as we have mentioned. Furthermore, minimum of a 2 mm of attached gingiva is required to maintain a periodontal health, as was given by the Langer law. If it is not present, then it will increase the risk of a gingival recession and facilitate the subgingival plaque formation because of the inadequate pocket closure. So, to maintain a periodontal health and to perform a proper gingival recession coverage technique, we have to increase the width of attached gingiva. It was done commonly by a free gingival graft or free connective tissue graft. But bridge flap or double lateral bridging flap, which was given by the Margaret in 1981, it is a single-step surgical procedure to resolve both the problems, gingival recession as well as the inadequate width of attached gingiva, by combining two surgical procedure. And this was modified by Ramanos in 1993, in that Edland measure technique to deepen the vestibular depth, and coronally reposition flap to cover the gingival recession. These two surgical procedures are used here. Here, the flap which covers the redundant root surface is supplied by a plasmatic circulation from the capillaries in the adjacent portion of the gingiva, which allows it to survive. In addition, because of the vestibular deepening, mucosal flap cannot be further influenced by the muscular tension from an apical direction as the periosteal fibers are released. Thus, it creates a healthy, functional, and aesthetic result that appear to be resistant to further recurrence. In my cases, two cases which were treated with this breech flap, the postoperative aesthetic result were satisfactory for the patient, and the secondary outcome variables like a recession reduction, clinical attachment gain, keratinized tissue gain, aesthetic satisfaction, and the reduced root sensitivity were achieved. The result of the present case series were inconsistent with the previous studies done by the Romanos and Margaret, who reported 70% root coverage even after a 5 to 8 years follow-up. Concluding my paper, there are numerous surgical techniques in literature to correct the mucogingival deformity, but the breech flap it can be a reliable solution for the attaining the root coverage, increasing the width of attached gingiva, and deepening of the vestibule simultaneously. But future research with a large sample size and long-term follow-up is needed to establish a breech flap as a steadfast treatment modality for the root coverage. These are my references. Thank you.
Sir, you can start with a question answer session.
Yeah. What could be the limitations of this technique? Audio is not clear. I think you need to unmute yourself.
Sir, when there is a gingival thickness is thin, then we cannot perform a breach properly, as there is a chance of tearing of a flap. So this
Okay,
can be a
fine.
limitation. And
What kind of healing does it take place? One in the cervical aspect, the other more apical to it. Is there any difference in the healing aspects?
yes, sir. Yes, sir. When where we are performing a vestibular incision, there will be a secondary healing will be there because of the wound is open, and at the coronal aspect, when we have sutured the flap, then will be a primary healing will occur.
Why did you prefer only this technique? What else other technique you could have prescribed?
Sir, as there is a width of attached gingiva is less, then we can perform a gingival free gingival graft technique or connective tissue graft technique. But as there is a requirement of a second surgical site, patient was not willing for that. That's why I have preferred this single step surgical technique.
One of your case, there was a diastema
Yes,
created,
sir.
okay? There's a considerable amount of diastema between the teeth.
Yes,
And
sir.
that could be the etiological factor for even the habit, any habits were involved.
Yes, sir.
What was the reason for the recession as well? Etiological factor.
Sir, because of one of my patient has a tongue thrusting habit, so it was a reason for the labially proclination and diastema in the lower central incisor, and another one has a traumatic occlusion. That's why the recession has been happened. So I have treated the both cause. I have reduced the traumatic occlusion, and a tongue thrusting habit was also treated.
So it was done in an interdisciplinary approach, right? Even the
Yes,
ortho
sir.
was done. So
Yes,
you could
sir.
have posted the post-operative image after that.
Yes, sir. That's
I
I'm
think Sachin
pleased.
can continue.
If ortho was planned for it, then why can't you do two-stage surgery? It would have been more appropriate rather than you have only achieved 70% of the root coverage. Plus, there was renal pull also. Plus, they had tongue thrusting habit also that sir has asked you.
Yes, sir.
If ortho was planned, then why you have stuck down to only this technique? There are other techniques which have given good results as well.
Yes,
There are
sir.
a lot of literature which says that other techniques.
Yes, sir. as a patient was aged, so she was not willing for complete orthodontic treatment. Only a tongue creep was given for the tongue thrusting habits, and she was also not willing for excessive surgical procedure. That's why I have chosen this. That's definitely more other technique can be performed, sir.
What was the age of the patient?
Sir, my first patient was 38 years old, and second patient was 42 years old. Sir.
Adult orthodontics is possible for that.
Yes, sir. It's possible.
No more questions from my side.
Okay, thank you, sir.
Thank you, Dr. Aisa Khatri. Our next presenter, Dr. Sunita PP.
Thank you, ma'am.
Good afternoon, everyone. This is a case report on fibrosarcoma, a rare presentation in gingiva. It is known that gingival enlargement is one of the frequent features of gingival diseases, but due to their varied presentation, the diagnosis of these entities becomes a challenge for the clinician. Fibrosarcoma is a malignant mesenchymal tumor that arises from the fibroblast, and there is an increased chance of recurrence and metastasis for this neoplasm. They are most commonly seen in the retroperitoneal, thigh, knee, and distal extremities, and uncommon in the head and neck region, and they comprises only about 1% of all the malignancies that affect the human race. The etiology of fibrosarcoma is obscure or unknown, but there are several associated risk factors with these neoplasms, like a prior radiation exposure, which is followed by trauma, underlying conditions such as Paget's disease of bone, fibrous dysplasia, and chronic osteomyelitis. Fibrosarcomas primarily occur in the soft tissues, but intraosseous lesions have also been reported. They also have an aggressive nature, and hence the overall survival rate is poor. The 10-year survival rate of fibrosarcoma is 83% for a low grade and 34% for high grade. Case description. A 44-year-old male patient who is an auto driver by profession came to our department with a chief complaint of enlarged gums in the lower left front region since 5 months. History of presenting illness. A patient noticed enlarged gums in the lower left front region since 5 months. He also noticed bleeding from gums in the same region while toothbrushing. Initially, the size of the enlargement was small, which gradually increased to the present size. Patient also complained of associated occasional pain in the same region. There was no post-discharge history of trauma and other systemic illness. The past medical history, dental history, and family history were non-contributing. There was no history of drug or food allergy, and the patient had no deleterious habits. On general examination, the patient was conscious and oriented, well built and nourished. On extraoral examination, these all structures were within normal limits, and there was bilaterally palpable submandibular and submental lymph nodes. On intraoral examination, the labial mucosa, buccal mucosa, tongue, hard and soft palate, floor of mouth, and tonsils were within normal limits. This is the clinical picture of the lesion, both on the labial and lingual aspect. On inspection, there was a discrete pedunculated lesion labially and a diffused or flat lesion lingually in relation to 3.1, 3.2, 3.3, and 3.4. The color was erythematous, and the size of the lesion was 1.5 into 0.7 into 0.4 centimeter labially, and 2 into 0.4 into 0.5 centimeter lingually. The anteroposterior extent was from the distal aspect of 3.1 to the distal aspect of 3.3 labially, and from the mesial aspect of 4.1 to the distal aspect of 3.4 lingually. And vertically, it extended from the cervical third of 3.1, 3.2, and 3.3 up to the mucogingival junction, both labially and lingually. The surface was irregular labially and flat lingually. Lesion was well demarcated, and the surrounding area appeared normal. The inspection findings were confirmed with palpation. It was soft, non-compressible, and non-tender on palpation, and there was bleeding on probing. This is the periodontal status. A probing pocket depth of 10 mm was found on the mesial aspect of 3.3. The gingival margins were coronal to the CEJ on all these associated teeth, and this is the clinical attachment level. On hard tissue examination, there was grade 1 mobility of 3.1, 3.2, 3.3, 3.4, 4.1, and 4.2, and attrition of 3.1, 3.2, 4.1, and 4.2, and pathological migration was related to 3.2 and 3.3. The trauma from occlusion was positive in relation to 3.2, 3.3, and 4.3. On radiographic evaluation, the intraoral periapical radiograph revealed horizontal bone loss extending up to the cervical third of root in relation to 3.1, 3.2, 4.1, and 4.2. There was periodontal ligament space widening and loss of lamina dura associated with these teeth, and also a mild periapical radiolucency associated with these four incisors. Based on these clinical and radiographic features, we came to a provisional diagnosis of chronic localized inflammatory gingival overgrowth in relation to 3.1, 3.2, and 3.3.
Our treatment plan was to initiate the standard periodontal therapy, that is phase 1 therapy followed by re-evaluation, then the surgical phase, re-evaluation, and to keep the patient in maintenance phase. So we started with the phase 1 therapy, which included scaling and root planing of occlusal correction, and then the surgical phase, where the excision of the gingival overgrowth was done by an undisplaced flap. Hemostasis was achieved, sutures were given, and patient recalled after 1 week. The biopsy specimen was sent for histopathological examination. These are some of the clinical pictures during surgery and 1 week after surgery. The healing was uneventful. On histopathological examination, the etch stained section showed a thin atrophic squamous epithelium and a highly cellular connective tissue. We can see in the connective tissue, the spindle cells are arranged in a herringbone or fishbone pattern. On high power, there was vesicles of spindle-shaped cells that were arranged in a herringbone or chevron pattern, nuclear and cellular pleomorphism, and increased and abnormal mitotic figures. This is a typical mitotic figure. The summary of the microscopical features. So based on these findings, we came to a primary diagnosis of malignant spindle cell neoplasm. For a definitive diagnosis, the immunohistochemical analysis was carried out. The ISP panel showed a high positivity for vimentin and cytokeratin was negative. So it was found that this neoplasm originated from the connective tissue. SMA, desmin, and actin are muscle markers. S100 is a neural marker, CD34 a vascular marker, and CD68 a histiocytic marker. As all of these markers were negative, we were able to exclude the muscular, neural, vascular, and histiocytic origin of the tumor. And by exclusion, we came to a final diagnosis that it is fibrosarcoma. Fibrosarcoma is always a diagnosis by exclusion. Coming to the discussion part, this paper reports the presence of a malignant tumor that mimics an inflammatory gingival overgrowth. This case is unique in the sense that the clinical and radiographic images were misleading. In most clinical cases of gingival overgrowth, the clinical appearance is complicated by inflammation, bleeding, and swelling, which creates a difficulty in identifying the cause and the pathogenesis. Oral fibrosarcomas primarily involve the maxillary sinus, maxillary or mandibular bone. The age group is in between 2nd and 6th decades, and they have an equal gender predisposition. The typical presentation has a swelling, associated pain, and paresthesia. And the grading of fibrosarcoma is from low to high based on the number of mitotic figures, tumor differentiation, and the presence of tumor necrosis. Absence of calcification or ossification helps to differentiate fibrosarcoma from other lesions such as chondrosarcomas and osteosarcomas. The low incidence of oral malignancy should not mislead the clinician. So all gingival tumors and tumor-like lesions must be biopsied and submitted for microscopic diagnosis. Fibrosarcoma's treatment of choice is wide surgical excision. Additional radiation therapy may be recommended, but it is considered only palliative. In our case, the patient was referred to a higher cancer center for further management. To conclude, some intraoral lesions may present in an unusual manner and make the diagnosis challenging. Even though intraoral fibrosarcomas are rare, we should always keep in mind that it is a differential diagnosis of gingival overgrowth. So, accurate diagnosis and prompt treatment is a prerequisite for prolonged disease-free survival, to avoid tumor recurrence, and to improve the quality of life. Thank you.
So you can start with your questions and answer session.
I think Dr. Sachin can start with his questions.
For diagnosis, PET CT was done, PET scan.
No, sir.
Why? When you are suspecting that it's a malignancy, before taking out that, you should have gone for a PET CT.
So we diagnosed this case as fibrosarcoma only after the microscopical examination.
Okay, at least after microscopic examination, when you got the confirmation that it is a malignancy, you could have gone for PET CT.
So the patient insisted for a referral to a higher cancer center, and we immediately referred him.
Okay. And you said there was a paresthesia in the lower lip and all.
No, sir.
Paresthesia was not in the lower lip?
No.
Okay, and pain?
No, sir. There was pain associated with the tooth, that is 3-2, but it is the lesion was non-tender on palpation.
Okay, it was not at all involving the bone itself.
Yes, sir.
Fine. For that also, you could have taken one occlusal radiograph and see whether it is involving the bone or no. And you could have gone, once you have got the diagnosis as malignant tumor, you could have gone for a PET CT so that you could have ruled out whether any kind of metastasis has happened or not. Okay. And what is the ideal chemotherapeutic drugs which are given for this kind of fibrosarcomas?
So fibrosarcomas had a low sensitivity to chemotherapy and radiotherapy. Wide surgical excision is the treatment of choice.
So
and chemotherapy and radiotherapy are considered only as a palliative care. In that case, cisplatin, doxorubicin can be given.
Okay, that means after the excision, you think the lesion will get controlled in that area only?
So fibrosarcomas are known for its higher incidence of recurrence.
Yes. So definitely chemotherapy is required for it.
Yes, sir. Currently, the patient is undergoing radiation treatment.
Radiation?
Yes. After the I had a telephonic conversation with the patient, and he had undergone a wide surgical excision of the mandible and reconstruction, and also neck dissection. And currently, he is undergoing radiation therapy.
That's what. R&D is also required, and chemo and radio is definitely required.
Yes, sir.
That's it from my side. Dr. Padmakant? Dr. Padmakant, you can start with the questions.
Sir Padmakant, sir, please kindly unmute yourself.
Now, is it audible?
Yes, sir.
Any skin or cutaneous lesions you found up the patient?
No, sir.
No, because usually it is frequently associated with skin and cutaneous lesions, right? Fibrosarcoma. Okay. How did you rule it out from the chondrosarcoma or osteosarcoma? How did you differentiate it?
So there was no calcification or ossification within the lesion. And from other spindle-shaped tumors, we differentiated by immunohistochemistry.
So you said you have sent it to the higher center for the further treatment. Is it undergoing the treatment? Is he undergoing the treatment or it's done?
Yes, sir. So this case was diagnosed in the first week of March 2021, and presently the patient is undergoing treatment.
So what exactly they are doing?
He had undergone a wide resection of the mandible and mandibular reconstruction, and also he had undergone a neck dissection and lymph node biopsy, and presently he is undergoing radiation treatment.
I think we can proceed.
Thank you, Dr. Sunita. Our next presentation by Captain Sumita Manandhar.
Good morning, sir. The topic for my paper presentation is management of gingival pigmentation using 4 different modalities, a case series. I'm going to cover this topic under the following headings. Normal color of the gingiva is coral pink. Along with the vascularity, pigment-containing cells such as melanin, which is a non-hemoglobin-derived pigment, is responsible for imparting dark color to the gingiva. In a patient with gummy smile or high smile line, while smiling, it can be aggravated, and that can be an aesthetic concern for the patient. As per Dummett et al. 1964, the prevalence of hyperpigmentation is seen more in attached gingiva, that is 27.5%, followed by papillary gingiva, marginal gingiva, and alveolar mucosa. Formation of the melanin include 3 phases: activation, synthesis, and expression phase, where formation of eumelanin, that is responsible for imparting dark color to the gingiva, is formed in the synthesis phase. Treatment modalities include scalpel technique, where we have surgical abrasion, split thickness, stripping. In lasers, we've got erbium-YAG lasers, dyed lasers. Other treatment modalities include pre-mucosal autograft, cryosurgery, electrosurgery, using burrs, chemicals which include 90% phenol. The aim of my study is to compare the treatment outcome of gingival depigmentation using 4 different modalities. The objective is to evaluate the intensity and extent of recurrence of pigmentation, level of discomfort, post-op wound healing in all 4 modalities. 10 patients were selected in a period of 6 months. After following phase 1 therapy, all the patients underwent depigmentation using the 4 different techniques in one setting under local anesthesia. Upper left quadrant was assigned to split thickness slicing technique, lower left quadrant for scalpel abrasion, upper right for RBM YAG, and lower right quadrant for diode laser. The parameters recorded were Dummett oral pigmentation index, head-in pigmentation index, pain score on VAS, epithelial wound healing based on peroxidase test. So quadrant-wise, in upper left quadrant, split thickness stripping with number 15 scalpel blade was performed, where surgical removal of 1 to 1.5 mm of gingival epithelium from mucogingival junction to marginal gingiva with a layer of connective tissue was removed, resulting in complete deepithelization. Second group, where lower left quadrant was assigned for abrasion of gingival epithelium with number 15 scalpel blade was done. Care was taken to see all the remnants of the pigmented layer was denuded, followed by periodontal dressing for 1 week in both the scalpel technique. Depigmentation in upper right quadrant was done using RBM YAG laser, which had a wavelength of 2940 nanometer in non-contact mode until entire area was depigmented. Now, group 4, in which lower right quadrant, the diode laser of wavelength 980 nm was used in a continuous contact mode with a flexible hollow fiber delivery system under standard protective measures. This is a baseline descriptive data showing 20% of the patients were male and 80% of the patient were female. And Dummett pigmentation index had a mean value of 3, whereas head-in pigmentation index had a mean value of 3.7. Intensity and rate of recurrences were evaluated in all the 4 groups, which resulted in faster rate of recurrences in the scalpel when compared to the laser. Moreover, RBM YAG laser had delayed recurrence rate. Analysis of pain and discomfort on the visual analog scale was plotted in all the 4 different groups at different time period, resulting in statistically significant difference between lasers and scalpel group. Wound healing was assessed using peroxidase test, where catalase enzyme responsible for liberating oxygen when hydrogen peroxide was performed, and positive is when effervescence is present and negative is when effervescence is absent. So results showed that there was no significant difference between the 2 scalpel groups and the 2 laser groups. However, scalpel had faster wound healing rate as compared to the lasers. While comparing the scalpel technique, split thickness stripping had the advantage of complete deepithelization, showing predictable results, which cannot be achieved by abrasion technique. Laser had the combined advantage of hemostasis, excellent coagulation, less post-operative swelling, and better result in terms of recurrence rate. Comparing wound healing, laser, due to its ablative nature on the cells, had slower rate of healing as compared to the scalpel, which can be confirmed by the study. Recurrence of pigmentation appears when melanin pigmentation occurs after a period of time, and exact mechanism is not known, but migration theory seems to be favored. It is hypothesized that active melanocytes from the adjacent tissues proliferate and migrate to the depigmented areas. Hung Lin et al. In 2014 did a systematic review of treatment modalities for gingival depigmentations, where they found out laser surgery to be promising result. To conclude, studies have reported that patients perceive pink color of gingiva as appealing and acceptable, whereas dark gingiva or hyperpigmentation cause aesthetic concern in the patient. Based on the available literature, gingival melanin pigmentation, it can vary depending on whether it is physiological or pathological. Scalpel stripping is gold standard for depigmentation because of complete deepithelization achieved. Though split thickness slicing has been considered as gold standard, but with the advent of lasers, laser is considered superior in clinical outcomes. RBM YAG lasers has shown better results with lesser intensity of the recurrence as compared to the diode lasers. Moreover, high cost of the laser apparatus has to be taken into consideration and should be performed cautiously to avoid damage to the periosteum and the bone. Thus, within the confine of the present case series, it is conducted that all the treatment modalities, laser therapy show better results. However, choice of technique should be dependent on individual preference, clinical expertise, and patient affordability. These are my references. Thank you.
Sir, you may start with the question answer session.
Okay. Majority of the
you have
clinical
started
picture.
with
Good afternoon, sir.
Yeah, you have done 4 different methods. What is your
Yes, sir.
preference and why is it so?
So my preference is in between, as I have also done comparative study, and in between lasers and scalpel, I prefer laser, and that is erbium YAG laser, sir. Because as per a study done by Gunn et al. In 2019, and also by Pavlik et al. In a literature review in 2017, they have mentioned that erbium YAG laser, when it comes to treatment for gingival depigmentation, it has got a promising results, and it has given significant results. And as per my study also, it has shown that the rate of recurrence is delayed in laser technique, and while comparing between the diode laser and the erbium YAG laser has a delayed rate of recurrence. So I prefer erbium YAG laser, sir.
Okay.
Majority of your clinical picture showed the pigmentation was remaining in the interdental areas. Did you actually have a follow-up after 3 months or 6 months? Which area was actually repigmented faster in your case?
Sir, I didn't do follow-up in 3 months, sir. I did follow-up after 6 months, sir, and majority it was more prevalent in papillary gingiva, sir. Followed by first, it was more prevalency in my study was seen in papillary gingiva, sir, interdental papillary.
Because majority of the time, that's what you said about the migratory phenomenon, where the
Yes, sir.
melanocytes migrate from the normal tissues to the deep pigmented areas,
Yes, sir.
right?
Yes, sir.
In your cases, majority of the areas in the interdental papillas were not depigmented properly.
Right, sir.
If you see your pictures,
yes, sir.
As scalpel or lasers, you have
So
not.
as per the migration theory, and also because it might be because all the pigmentation were not removed from the basal till the depth of the basal area, sir. So there might be repigmentation according to the migration theory given by Aoki et al. In 2015, sir.
Okay. And you also said about VS. Now, how did you measure the pain scores by VS?
Sir, this visual analog scale, sir, it is like patient perception of pain, sir. Looking at the person visual aspect of pain, there is a scale of 1 to 10, sir, where there is a inference like 0 is no pain, 1 to 3 is mild pain, 4 to 6 is moderate pain, and 7 to 10 is the extreme pain, sir.
So, are you going to write the scores of the patient?
Sir,
are you going to write the pain scores, or the patient is going to write the pain scores?
So I'm going to write the score, but all I have to see for the patient observatory. This is all observatory, sir.
Okay. So what about verbal rating scale, where patient himself is telling the amount of pain and the type of pain he is perceived? You could have gone for verbal rating scale.
Sir, yes, sir, but I went for visual analog scale, sir. Yes, sir. Got it, sir.
Okay, because sometimes the pain perception, what patient has perceived, might not be accurate with what you have seen or what you have visualized.
Yes, sir.
Okay, no issues.
Got
And
it, sir.
you said chemicals are also used for depigmentation. Why you didn't use those chemicals?
So because this study, my main aim of this study was to see for the gingival depigmentation procedure using this four modalities, that is comparing 2 scalpel technique with two laser techniques. So, sir, as this laser, because scalpel is the gold standard technique, sir, and I wanted to compare the gold standard technique with newer modalities such as laser, which is newer, which has a newer modalities and which is convincing. So I wanted to compare these two techniques. So I didn't use chemicals. So.
Okay. Have you ever seen people using chemicals for depigmentation?
Sir, I've learned, sir, but I've not seen people using chemicals for gingival depigmentation procedure, sir.
What could be the reason why people don't use it?
Sir, because chemical, it might it has got some corrosive and abrasive actions, sir, and it might abrade the soft tissues around the area, like where the gingival pigmentation is not there. Also, sir, it might abrade the alveolar mucosa, and it might spread. So there might be some problems, sir. So there is limitations in chemical use for the gingival depigmentation.
Depth of penetration, you cannot control the depth of penetration.
Yes,
That's
sir.
what
Yes, sir. Yes, sir.
No more questions.
Thank you, sir.
Thank you, Dr. Sumita. Our next presentation by Dr. Anima Sarma.
Thank you, sir.
Very good morning to all of you, respected teachers and dear colleagues. Myself, Anima Sharma from Maharishi Markandeshwar College of Dental Sciences and Research, Mulana, Ambala. I'm here to present a case which was performed by me, that is the management of suppurative periapical granuloma of the right maxillary central incisor. This case was performed in our department, that is the Department of Periodontology, under the supervision of my head of the department, Dr. Surendra Sachdeva. Introduction. Periapical lesion is a well-established infection in the dental pulp, which can spread only in one direction, that is, through the root canals into the periapical region. Periapical lesion can be in the form of a cyst, abscess, or granuloma. A number of different tissue reactions can be seen in the periapical region, depending on the variety of circumstances. There can be subtle transformation from one type of lesion into another type, and a certain degree of reversibility is also possible in some lesions. Interrelationship of a periapical infection. Periapical infection can also be called as the sequelae to dental caries. It is so because when the tooth is first affected, the enamel surface gets affected. Then the infection progresses towards the dentine. From the dentine, it progresses towards the pulp. So inflammation of the pulp is called pulpitis. In this case, in this condition, the tooth has to be treated endodontically. But if the tooth is not being treated, then the infection progresses towards the apex of the tooth, which is called apical periodontitis. Apical periodontitis is of two types, acute and chronic. The acute apical periodontitis forms periapical abscess, and a chronic apical periodontitis forms periapical granuloma. Now, this periapical abscess and periapical granuloma further progresses to form osteomyelitis. Osteomyelitis is the inflammation of the medullary bone area. Now, so from this state, we can say that the the infection has progressed from the soft tissue area to the bone area, that is the hard tissue area. Now, from the osteomyelitis, the infection further progresses towards the periosteum of the tooth, and it is called periostitis. Now, periostitis further forms cellulitis or abscess. Periapical granuloma. It is a localized mass of chronic granulation tissue formed in response to an infection. The involved tooth is usually non-vital and may be slightly tender to percussion, which produces a dull sound. The sensitivity at the site can be reported maybe due to hyperemia, edema, and inflammation of the apical periodontal ligament. The earliest periapical change in the PDL is the thickening of the ligaments at the root apex. The radiolucency is well circumscribed. A thin radiopaque line presenting a zone of sclerotic bone may sometimes be seen outlining the lesion. This indicates that the lesion is slowly progressive. Chopra et al. In the year 2001 developed a form of platelet concentrate labeled as platelet-rich fibrin, based on the strong fibrin gel polymerization found in this preparation. The main function of platelet concentrate is to contribute to hemostasis, the process of stopping bleeding at the site of interrupted endothelium. Platelet concentrate are a rich source of growth factors with added antimicrobial efficacy due to incorporation of leukocytes. Platelet concentrates were introduced to reinforce the natural wound healing process, hence PRF was termed as a second generation platelet concentrate. The advantage of PRF and PRP are its simplified preparations and lack of biochemical handling of blood. PRF is in the form of a platelet gel. It can be used in conjugation with a bone graft, which offers several advantages, including it promotes the wound healing, bone growth and stabilization, wound sealing and hemostasis. Case report. A 45-year-old patient reported to a department of periodontology with a chief complaint of pain in the right upper front tooth region. On clinical examination, it was revealed that the tooth was 1-1. There was a slight black discoloration of the tooth. The tooth was fractured at the cervical region, hence not in proper occlusion. The gingiva in the region was red, inflamed, and edematous. Swelling was fluctuant on palpation, not deeply adhered to the underlying bone. Tenderness on percussion was found to be positive in relation to the tooth. On radiographic examination, a white radiolucent area was depicted at the periapical region of 1-1 as shown in the figure 2. Methodology. Clavicular incision was given at the site as shown in the figure 3. 2 vertical releasing incisions were given in the form of a triangle with the apex towards the cervical portion of the tooth. Full thickness flap was raised with the help of a periosteal elevator with respect to 1-1 as shown in the figure 4. Episectomy was done, followed by the thorough debridement of the periapical region with the help of a greasy curette 1-2 as shown in the figure 5. The tissue sample was collected for the histopathological examination on a piece of a sterile wet gauze as shown in the figure 6. Preparation of PRF. PRF was processed from the autologous blood. 10 ml of venous blood was collected. Whole blood was drawn into the tube without anticoagulants and immediately centrifuged at 3000 rpm for 10 minutes. Within a few minutes, the absence of anticoagulant allowed the activation of the majority of platelets contained in the sample to trigger a coagulation cascade. It is also called as Buffy coat because of its white or buffy appearance as shown in the figure 8. It was immediately used at the surgical site to initiate the clotting as shown in the figure 8. After the advanced platelet-rich fibrin placed at the defect, suturing was done. Post-operative instructions. The most common consequence of a surgery is pain and swelling, hence it has to be managed properly. Swelling may be minimized by immediate use of ice packs at a surgical site, application of ice pack to the outside of the face for 20 minutes on and then 20 minutes off while patient is awake for the first 24 hours was advised. For pain, ibuprofen was recommended. If discomfort was tolerable, patient may alter ibuprofen with Tylenol, that is acetaminophen, for the first 24 hours. Adult dosage for ibuprofen is 400 mg tablet per 44 kg of body weight. Diet. Start with a liquid. It was advised. Patient was asked not to have hot liquids or foods. To help prevent discomfort, the patient was advised to avoid vigorous rinsing, sucking on the wound, spitting, using a straw, and exercising for 48 hours after procedure. Use of a soft bristle toothbrush and toothpaste after meal and at the bedtime was advised. Result. Follow-up was done at 1 week, 1 month, and 3 months. The sutures were removed after 7 days. At 3 months, the soft tissue healing was completely normal, as shown in the figure. The radiograph shows decrease in the size of the lesion. Histopathological examination confirmed educate bone fill at 6 months, and the lesion was periapical granuloma. Conclusion. The first surgical additive to be used as a fibrin sealant. It is also known as fibrin glue or fibrin tissue adhesive. Fibrin glue is composed of 2 separate solutions of fibrinogen and thrombin. When mixed together, these agents mimic the last stages of clotting cascade to form a fibrin clot. Fibrinogen can be obtained from pooled, single donor, and autologous blood donors and is usually isolated by the process of cryoprecipitation. The thrombin component is generally derived from commercial bovine sources. Some
Sir, you can start with question and answer session.
Okay. You said that PRF. What kind of PRF did you use it?
Sir, advanced platelet-rich fibrin, sir.
Okay. You in one of your slide you said that PRF induces bone regeneration. You have any reference for it?
Sir, in many of the articles, it has been mentioned that the PRF has many growth factors in it, like platelet-derived growth factor, vascular endothelial growth factors, tumor, like this, sir. So this growth factors helps in the regeneration of the bone at the site, sir, where it is used.
Actually, it doesn't help in bone regeneration. It is a very good source for wound healing because it has growth factors in it. There are scanty research has been done. There are no literatures giving 100% review that it is going to regenerate. First thing, right? And what kind of bone graft did you use with the PRF?
Sir, in this case, sir, we haven't used any bone graft, sir. We just placed the PRF at the site, sir.
You should have used a bone graft in this case.
Yes, sir.
Why? Because there is a root resorption if you see in that radiograph.
Yes, sir.
So you should have used a PRF, a PRF along with the bone, might be an alloplast, would have been a very good thing.
Yes, sir.
Endodontic procedure was done for it?
Sir, it was endodontically treated before. The patient reported to our department, and sir, maybe at that time they have not diagnosed it with. They have just diagnosed with a periapical lesion, but not means
secondary endodontic was required in this case.
Sir, secondary endodontic treatment, sir. We didn't refer to the endodontic department after that, sir.
Actually, you should have, because once it is treated endodontically, still there is periapical granuloma which is existing or periapical abscess which is existing.
Yes,
there
sir.
are chances that your first endodontic treatment would have been insufficient.
Okay, sir.
You should have retrieved the gutta percha. You should have created, you should have done the new BMP and you could have cleaned it. Then you should have done endo. Then you should have gone for surgery. It would have removed that bias where you are 100% sure that there is no infection which is persisting in the canal. So your healing would have been very nicely appreciated after it. A bone graft, this case would have been absolutely.
Okay, sir. Yes, sir.
No more questions from my side.
Okay, you said you have done a preparation for the PRF. Do you think what angulation was used? Angulation of the test tubes in the centrifuge, does it have a significance in obtaining the viable cells? I'm not able to hear.
The test tubes, when the test tubes are kept at 45-degree angulation.
So if there is a change in the angulation, is there any literature regarding the change in the angulation and the amount of viable cells that you can obtain? Did you go through that literature?
Change in the angulation can affect, sir, but I have not read it properly.
Okay. What are the contemporary growth factors that you can achieve from the systemic blood circulation?
Sir, platelet-derived growth factor, vascular endothelial growth factor, fibroblast growth factor, then insulin-like growth factors, like that.
As Sachin sir said, you should have taken an endodontic opinion prior to conducting the surgery. That would have been that could land up in a better prognosis for the case.
Yes, sir.
That's it.
Okay, sir.
Thank you, Dr. Anima Sarma. Our next presentation by Dr. Swati VS and Dr. Swati Judge and Dr. Aparna Suraj.
Hello, I'm Dr. Swati. The topic for my paper presentation is management of aberrant mandibular labial frenum by the rhomboidoplasty case report. Coming on to the introduction, so the frenum is defined as a band or a fold of mucosal membrane which encloses the muscle fibers and attaches the lips and cheeks to the alveolar mucosa or the gingiva and the underlying periosteum, and it limits the movement of the lips and the cheeks. So the foremost frena are the maxillary labial frenum, the mandibular labial frenum, and the lingual frenum. Their primary function being is to provide stability of the upper and the lower lip and the tongue. So according to Plasek et al. In 1974, he classified the frenum depending upon the extension of attachment of fibers. So it can be classified into mucosal, where the frenal fibers are attached up to mucogingival junction, and it is can be classified as gingival, where the fibers are inserted within the attached gingiva, and as papillary, where the frenum fibers extend into the interdental papilla, and as papilla penetrating, where the frenum fibers crosses the alveolar process extending up to the palatine papilla. So according to the Miller, the frenum is characterized as pathogenic when it is unusually wide, or when there is an abscess of an apparent zone of attached gingiva along the midline, or when there is a shift of the interdental papilla occurs when the frenum is extended. So the clinical indications for frenal removal can be when aberrant frenum when it is related to inflamed gingiva causing poor oral hygiene, or the aberrant frenum associated with gingival recession, or the maxillary frenum related to diastema after complete eruption of the permanent canines, or when there is an abnormal mandibular frenum with high insertion leading to onset of gingival recession. So this aberrant or abnormal frena, it can be visually detected by tension application onto the papilla tip, and thereby observing its movement or blanching due to the ischemia. So the management of the aberrant frenal attachment includes the two common procedures, that is the frenectomy and the frenotomy. So the frenectomy is the technique which involves excision of the frenum, including its attachment to the underlying alveolar bone, whereas the frenotomy comprises of removal and relocation of the frenum to a more apical position. There are other several possible approaches to frenectomy, which includes the classic frenectomy, bisepplasty, VY-plasty, electrosurgery, or carbon dioxide laser. So the vestibular incision method, which is also known as the mandibular frenectomy, is a surgical technique which involves the elimination of the abnormal frenum and simultaneously alters the vestibular depth. So this current case report, it describes the mandibular frenectomy treated conservatively by employing the rhomboidoplasty surgical technique for the treatment of an aberrant mandibular frenum. So coming on to the case report, a 29-year-old male patient reported with the chief complaint of irregularly placed lower front teeth as well as the growth on the lower lip. So on examination, the patient had an aberrant buccal frenum with a gingival attachment with respect to the left mandibular canine, and had a Miller's class 1 gingival recession with a depth of around 1 to 2 mm. And the frenectomy was of the apparent labial frenum in relation to mandibular canine. Left canine was planned to improve aesthetics and to prevent further gingival recession of the same tooth. So the area of interest was anesthetized with 2% of lignocaine with 1:80,000 adrenaline, and the labial frenectomy was performed. So the labial frenum was made taut and was clasped with the help of a tissue faucet. So the technique used was the rhomboidoplasty. Hemostat was placed to engage the frenum, where the incision was placed along the upper surface of the hemostat, and simultaneously an incision was also made under surface of the hemostat with a blade number 15. So a triangular portion of the frenum was resected along with the was resected along with the hemostat. Horizontal incision was placed to dissect and separate the fibers attached to bone. Later, the area was sutured It was sutured without tension to maintain its apical position and covered with a tinfoil to prevent reattachment of the tissues and allow granulation to occur at a greater depth. And then the parodontal dressing was applied, and the patient was prescribed analgesics for twice daily for 2 to 3 days, and the sutures and the dressing was removed after 1 week. Post-operatively, there was healing of the tissues at the site of frenectomy, which was uneventful, and the patient was able to maintain adequate play control. Coming on to the discussion, the traditional technique of um, frenal excision was introduced by Archer and Kruger in 1961 and 1964, which incorporated interdental tissues as well as the heart and papilla alongside the frenulum. So the classical technique which was introduced by Archer, it is an excision type which uses scarring and which may lead to parodontal problems and an aesthetic appearance. Thereby, it's necessary to modify the technique. So the necessary modifications were the Miller's technique, the V-rhomboroplasty and Z-plasty to treat the aberrant labial frenum. So in this present case, as said, the buccal frenum in reference to the mandibular left canine gave a positive tension test and was thought to cause a gingival recession of the consent root. So thus the frenectomy of the mandibular canine was planned to stop further recession and loss of supporting tissue, which might lead to dentinal hypersensitivity, or it can lead to root caries. So there was an uneventful healing with minimum post-operative pain, and there was no scarring was observed, and there was an adequate amount of vestibular depth maintained with concerned tooth. So even the alternative techniques such as lasers and electrocautery are the recent technique which can bear an advantages like minimal time consumption, mild bleeding, and minimal post-operative complications. However, they are expensive, and also in this case report, the patient was apprehensive to undergo this treatment. So coming on to the conclusion, an aberrant frenum may cause inadequate oral hygiene maintenance and aesthetics affecting the parodontal health and resulting in other mucogingival problems, while aberrant frena are often removed by any of the proposed modification techniques. A functional and an aesthetic outcome, functional and aesthetic outcome is achieved by the correct technique selection based on the type of frenal attachment. So thus the approaches like electro surgery and lasers have merits. However, further improvement can still be attempted.
It's time for question and answer session.
No questions from my side. Dr. Padmakant can continue.
No questions from my side as well. Good presentation.
Thank you, sir.
Okay, sir. With this, we end our session. And I thank you to Dr. Sachin K. Malagi, sir, and Dr. Padmakant Manva, sir, for taking out your valuable time and being a part of this first virtual PG convention. Thank you, sir. Thank you very much. And I would like to request the next coordinator to Dr. Asik Misra for the next session.
Good afternoon, one and all. Now we are going to start our sixth session. It should be started by 2 o'clock, but now we are going a little delayed in time. I would now like to introduce our chairperson for this session, Dr. Pedna Agarwal. She is reader from Institute of Dental Science, Bareilly. Along with her is Dr. Shailendra Singh Chauhan, professor and head KD Dental College, Mathura. Ma'am and sir, please kindly stick to the time frame of question answer session of 2 minutes. The first presentation of this session is by Dr. Nishana. Tech team, we can have the video now.
My topic for the paper presentation is neoteric approaches for the management of excessive gingival display case reports. Introduction. Beauty lies in the eyes of the beholder. The harmony of the smile is determined by the shape, the position, and the color of the teeth, and also by the gingival tissues. Elements of an aesthetic smile consist of gingival scapula, teeth, and lips. Amount of the visibility of the periodontium depend upon the position of the smile gland, which is defined as the relationship between the upper lip and the visibility of the gingival tissues and the teeth. Smile gland classified, different smile gland which is classified by T. Jan by high smile gland for 75%, median smile gland 69%, and low smile gland 20%. Ideal smile, which is the exposure of the entire length of the maxillary teeth, 1 millimeter, visibility of the mid-facial maxillary gingiva, and the gingival exposure within the permissible limit of 3 millimeter may be considered as aesthetically acceptable. Excessive gingival display, that is a gingival display exceeding 3 millimeters is unpleasant and is termed as excessive gingival display or a gummy smile. And there are certain causes of the gummy smile, that is dendo-alveolar, that's vertical maxillary excess, dendo-gingival, altered passive eruption, muscular, that is hyperactivity of upper lip muscles, and mixed nature, that is of the combination of all the above. Teeth-related factors contributing to excessive gingival display, that is amount of the upper incisor exposure, smile arc, altered or delayed passive eruption, width or length ratio of the maxillary incisors, occlusal plane. Classification of the excessive gingival display based on the etiology, that is type A, altered passive eruption, B, bony maxillary excess, and C, condition causing gingival enlargement, D, division maxillary lip length, and E, excessive mobility of maxillary lip. There are certain pre-surgical evaluation for the diagnosis of excessive gingival display, that is vertical and horizontal extent of the smile and the measurement of length, width of the anatomical crown, location of the mesogingival junction, and measurement of the maxillary lip, and measurement of the upper, middle, and lower third of the face. Management include type A, that is gingivectomy along with osseous reduction, that is or apically positional flap along with osseous reduction. B, lip repositioning surgery or crown lengthening, orthodontic intrusion, orthognathic surgery. Where C, gingivectomy procedure. D, lip training exercises. E, lip repositioning, lip stabilization, or botulinum type A toxin. Then lip repositioning or lip stabilization technique, which is introduced by Rubinstein and Kostianowski et al. In 1973. It is a cosmetic surgery for the correction of the gummy smile, which is caused by the hypermobile lip, and is the advantage of less aggressive fever post-operative complication with compared to orthognathic surgery. Contraindication, inadequate width of attached gingiva. This technique is not done. There are certain guidelines for the case selection of lip stabilization technique. That is, if 1 to 3 millimeter gingival display is present, that lip repositioning surgery is done to remove 2 to 5 millimeter of mucosa. If 4 to 6 millimeter gingival display is present, lip repositioning surgery is done to remove 8 to 12 millimeter of mucosa. If greater than 7 millimeter gingival display is present, lip repositioning surgery is done to remove 10 to 50 millimeter of mucosa. There is evidence shown that Ganesh B et al. In 2019, that is 7 millimeter gingival display reduced to 3 millimeter by laser assisted lip repositioning surgery along with the crown lengthening procedure. Khan et al. In 2017, that is gingival display 8 millimeter reduced to 4 millimeter by lip repositioning surgery. And Ribery Junior et al. In 2013, that is 6 to 7 millimeter gingival display reduced to 4 millimeter by lip repositioning surgery modified by Rosenbolt and Simon. This is the first case that 22-year-old female patient referred from the Department of Orthodontics to the periodontics with a chief complaint of gummy smile and incomitant lip, and she had undergone fixed orthodontic treatment. On clinical examination, has adequate width of attached gingiva and upper lip length, that is 70 millimeter. And the two treatment options were explained to the patient, and patient opted for the lip repositioning surgery because of less aggressive and less post-operative complication compared to orthognathic surgery. These are the photographs, gingival display on full smile, intraoral view, and upper lip length. After informed consent taken prior to the procedure, and after local anesthesia administration, that is outlined for the gingivectomy procedure done using a pocket marker and excised gingival tissue using a quick line knife. Then outline de-epithelialization is done and marked area de-epithelialized using diode laser without intervening frenum. That simple interrupted suture, that 30 black silk suture is given. This is a 2-week post-operative suture removal after suture removal, and lip poster at rest 2 weeks after the procedure. These are pre-operative photos and the 3-month post-operative. Then second case, 18-year-old male patient referred from the Department of Orthodontics to the periodontics with the chief complaint of gummy smile and concomitant lip. And patient, he had also undergone the fixed orthodontic treatment. On clinical examination, that's adequate width of attached gingiva and lip length, upper lip length measured, that is 18 millimeter. These are different smile photographs. The patient have adequate width of attached gingiva and upper lip, which is 18 millimeter, is the armamentarium used. After informed consent obtained prior to the patient, then prior to the procedure, the surgical borders are marked with a marker, and the partial incision carried out, and mucosa is removed and expose the connective tissue, and suturing using 5-0 proline, and is the pre-operative photographs, immediate post-operative and 3-month post-operative. Third case, that is 34-year-old female patient complains of gummy smile, and this is a photograph gingival display on a full smile. This is also crown lengthening done, carried out using external beaver gingivectomy using Kirkland knife. This is the pre-surgical photographs that with width of attached gingiva measured. Then procedure after taking informed consent, that is surgical borders are marked using marker and partial thickness decision to expose the underlying connective tissue. Sutures using 3-0 black silk, co-pack placed. It's a pre-operative, immediate post-operative, 2 weeks post-operative, and the 1 month post-operative. Conclusion, lip repositioning surgery is the effective method of reducing gingival display and improving the appearance of the smile. With the increasing awareness, aesthetic have become major concern for the people. Correct diagnosis is the key to success to solve cosmetic issues. In this report, multidisciplinary treatment approach have been undertaken for the correction of the excessive gingival display to achieve aesthetics. These are the reference. Thank you.
Prerna ma'am and Salendra sir, you can start over with the questions.
Okay, Rishana, am I audible?
Yes, ma'am. Yes, ma'am.
Can you tell me some modifications of lip repositioning for these procedures?
Ma'am, so that modifications include one of the case report that shows the laser repositioning along with muscle containment. That muscle containment, that is using the containment muscle using orbicularis oris, levator labii superioris, levator labii superioris aliquinaceae, zygomatic minor. In this technique, they have shows a longer long-term stability, that is greater than 1 year shows greater outcome.
Okay, most accepted modification was by Silva et al. In 2013. Any idea about that modification? Most accepted modification of lip repositioning was by Silva et al. In 2013. Any idea about that modification?
No, ma'am.
Okay, in all of the 3 cases, can you explain me the difference in their etiology and how the different etiology could affect treatment plan?
In altered passive eruption, they have done different options. That altered passive eruption that classified in type 1 and type 2. In type 1, there's excessive keratinized tissue and mucogingival junction apical to the alveolar crest. There are again subtype A and subtype B. Subtype A, they undergone gingivectomy, where subtype B, where the gingivectomy along with the osseous reduction. Whereas in type 2, that is keratinized tissue and mucogingival junction near the C, cemento enamel junction. They are again classified into that subtype A and subtype B. In subtype A, they undergone apically positional flap, whereas subtype B, osseous reduction with apically positional. This in the case of altered passive eruption. whereas the bony excess, bony maxillary excess, they are classified into subclass 1, subclass 2, subclass 3. That is in subclass 1, that is there is a 2 to 4 millimeter of gingival display that are done lip repositioning surgery, then hello mom. In subclass 2, that is 4 to 8 millimeter of gingival display. They remove 8 to 12 millimeter of mucosa by lip repositioning surgery. Whereas greater than 8 millimeters gingival display, they undergone orthodontic surgery. If it is a condition causing gingival enlargement, first due to any plaque retentive factors, first management of the plaque retentive factors, then if it is due to any medication causing gingival enlargement, that alternative drug should be given.
Done. Actually, I was not asking review part, I was asking pertaining to your cases only. I'm done with the questions, sir.
Shailendra sir. Okay, thank you, ma'am. Thank you, sir. We can now move on to the next presentation. The presenter are Dr. Priyanka Ghole and Dr. Akshay Sope.
Greeting to the judges and organizing committee. Today, my case presentation is on cutaneous lesion preceding to the gingival pemphigus vulgaris. The authors are me, myself, Dr. Priyanka Ghole and Dr. Akshay Sope. Coming on to the introduction part. Pemphigus is a chronic inflammatory autoimmune bullous disease. Lesion may occur anywhere on oral mucosa, but buccal mucosa is the commonly affected site, followed by involvement of the palatal, lingual, and labial mucosa. Gingiva is the least commonly affected site, and desquamative gingivitis is the commonest manifestation of the disease when gingiva is involved. In many patients, oral lesions are followed by development of a skin lesion. If oral pemphigus vulgaris can be recognized in early stages, treatment may be initiated to prevent the progression of the disease to the skin involvement. The chief complaint of the 34-year-old female patient is burning sensation on mastication and peeling of the gums since 3 months. The history of present illness is she had history of skin lesion 9 to 10 months back and reported to the dermatologist, where she was diagnosed with the pemphigus vulgaris and treated for the same. The past medical history 9 to 10 months back, the patient noticed small blisters on the right chest region, which gradually increase in size in 3 to 4 days and which leaves a black painful scar. There was no relevant intake of a drug history which can lead to pemphigus vulgaris of skin or gingiva. On cutaneous examination, we can see the multiple fluid-filled blisters were present 9 to 10 months back. Healed hyperpigmented cutaneous lesions were present. Such blisters were further noticed on the other parts of our body like neck, head, stomach, hand in few months. In these figures, we can see the healed lesion of the pemphigus on hand and healed lesion on the posterior trunk region. On intraoral examination, the upper and lower erythematous, red, attached and marginal gingiva we can see. In this video, we can see the red erythematous gingiva which can be peeled off easily. The provisional diagnosis of this case report is desquamative gingivitis due to pemphigus vulgaris. Differential diagnosis may be bullous pemphigoid, cicatracheal pemphigoid, erythema multiforme, erosive lichen planus, allergic stomatitis, dermatitis herpetiformis. On routine blood investigation, there was no significant finding in the blood. On laboratory investigation, we can see the paravasal acanthosis near the two tips of the retapeil. Some indices are taken to see the severity of the pemphigus vulgaris. The first indices we are taken is pemphigus oral lesion intensity score, that is POLIS. The it is a new scale and has adequate validity and reliability. It includes both quality of life and the clinical disease severity parameters. In this case, the POLIS score is suggestive of the severe case of the pemphigus vulgaris. The second score is autoimmune bullous skin disorder intensity score. The skin involvement, the total score is 81. The oral involvement score is 5. The severity of the food intake is 30.5. According to this, the APSIS score, it is a scoring system to measure and capture small changes in a disease severity for the pemphigus. In this case, the values are suggestive of the severe pemphigus vulgaris. The pemphigus disease area index PDAI of the skin, of the scalp, and of the mucous membrane are recorded. This is a scoring criteria of APSIS and PDI. Our score is greater than 19 in cutaneous region and more than 19 in mucosal region. So this is extensive or severe case according to the PDAI score, and according to the APSIS score, our score is more than or greater than 5.5 for the cutaneous region and more than 6 in mucosal region. So it is considered as an extensive or a severe kind. According to the pemphigus oral lesion intensity score, pemphigus disease area index, autoimmune bullous skin disorder intensity score criteria, this case is suggestive of severe case of a pemphigus vulgaris. The final diagnosis of this case report is severe pemphigus vulgaris with disquamative gingivitis. Treatment and management. In first 15 days, we give higher dose of prednisone, azithromycin, ciprofloxacin, ciproperol sachet, test ointment, and betadine gargles. There was 40 mg dosage of prednisone, and the antibiotics are given to reduce the action of steroids on the body. And the second, on next 15 days, we give the lesser dose of prednisone, that is 30 mg. After that, we can see our goal is achieved. There is less burning sensation, and peel of gingiva is less as compared to previous. Here we can see the before and after 3 months follow pictures, where there is reduction in erythematous gingiva and redness of attached and marginal gingiva. Discussion. Pemphigus is defined as the group of life-threatening blistering disorder of the skin and mucous membrane characterized by acanthosis. In most of the cases, the first sign of the disease appears on the oral mucosa, while the lesions can be located anywhere within the oral cavity and then proceed to the cutaneous lesion. Scoring systems are used to assess the severity of the disease and the response to the treatment. The main severity scoring indices are autoimmune skin disorder intensity score, that is APSIS, pemphigus oral lesion intensity score, and pemphigus disease area index. They have been validated and already used in the evolution of the pemphigus and in clinical trials. In this case report, cutaneous lesion precede to the gingival lesion. An important aspect of the patient management is the early diagnosis, when lower doses of a medication can be used for the shorter period of time to control the disease. In initial and most important aspect of the management is improving oral health and minimizing the irritation of the lesion. High dose of topical corticosteroid ointment may control limited oral diseases. In most of the cases, however, disease control or remission is achieved using systemic corticosteroid alone or in combination with the immunomodulating medications. The goal achieved after the successful treatment in this case is reduction of the burning sensation and peeling of the gums, which was a chief complaint of the patient. Conclusion of this case report is the present case was successfully treated. Hence, it was the paramount importance to ascertain The identity of the disease responsible for desquamative gingivitis is established. These are my references. Thank you.
Dr. Salendra sir and Dr. Pranama, you can proceed with the question answer session.
Okay, doctor. Dr. Priyanka, I want to ask two questions. Tell me the first types of pemphigus and which type of most commonly found in the oral cavity.
Sir, pemphigus are of different type. Pemphigus vulgaris, pemphigoid, then desquamative bullous pemphigoid, then and in oral cavity, pemphigus vulgaris. Sorry, sir.
Salendra sir, your audio is not clear.
What is the
So audio is not able to.
Hello.
Yes, sir.
Salendra sir, your audio is breaking, sir. Must be network issue on your side, sir.
Sorry for interruption. What is Nikolsky sign? Network issue. There is some problem.
Sir, actually the timing is over for the question answer.
Dr. Prerna, you can ask some problem in network. Hello?
Okay, sir. Yes, sir. Yes, sir. Okay, Priyanka, most common differential diagnosis of pemphigus vulgaris is bullous pemphigoid. How did you exclude the possibility of bullous pemphigoid in your case?
Ma'am, in this case, bullous lesion means in retipex are present and Nikolsky sign is positive and the cutaneous lesions are present 9 to 10 months back, which are diagnosed as pemphigus vulgaris. So we can see the differential diagnosis can be pemphigus vulgaris more commonly. Thank you, ma'am.
Thank you, Dr. Priyanka. We can now move to our next presentation by Dr. Neelam Mishra.
Good morning, respected judges. The topic for my presentation is maxillary sinus lift using hydraulic lift system and easier and quicker sinus lifting technique. Case report. As we know that after tooth loss in posterior maxilla, the maxillary sinus enlarges over time and makes implant placement more complex when combined with crestal resorption. Therefore, maxillary sinus augmentation becomes necessary to provide adequate bone height volume to place implant fixtures. This technique was introduced by Tatum and published as a clinical study by Boyd and James. This is suitable for the rehabilitation of both posterior tooth and a completely edentulous maxilla in the regions with loss of alveolar bone and sinus pneumatization. It has basically two approaches commonly used for this procedure. First is lateral window technique, also known as direct approach. Second is osteotome infusion technique, also known as Prestel approach or indirect technique. After introduction of Prestel approach, it had the limelight among the clinicians as it has many advantages compared with the lateral approach. Like it is less aggressive than the lateral approach. It is simpler and requires less time for wound healing. But it also comes with few drawbacks. Like it totally depends upon the skill of the clinician and causes ringing in the head while tapping the mallet inside the sinus. It can also give rise to complications like headache and vertigo after the sinus lift procedure. Therefore, there are various surgical procedures and devices which have been developed to overcome the shortcomings of the osteotome technique. Among this, a device which uses hydraulic pressure for sinus membrane elevation has been demonstrated. It presents with a low risk of sinus membrane perforation as well as ease of application. So the objective of my study is to evaluate the effect of hydraulic pressure lift system technique using gasket for easier sinus lift in a patient undergoing implant placement in maxillary posterior region. Coming to the clinical report, a patient, 42-year-old patient named Manish Kamble reported to the department with the extracted tooth with 1314, 1516, 2324 and 2526. After clinical examination, pre-operative radiographs revealed inadequate bone height with 1516 and 2526. Therefore, sinus lift was planned for 1516 and 2526 using hydraulic lift system followed by implant placement in all the edentulous area. So these are the pre-operative clinical pictures. This is the frontal view followed by occlusal view. This is the right lateral view and left lateral view, and these are the area of interest for both the quadrants. After that, patient was sent for oral prophylaxis before begin with the actual surgical procedure. A clinical stent was made for implant placement as a guide, and then patient was advised to get the CBCT done. In CBCT, we plan to place the implants in the region 1315 and 16, 2324, 25 and 26, and the sinus lift was performed in the region 2526 and 1516. As we can see that the alveolar bone height in the region 15 is 5 mm. The remaining alveolar bone height in the region 16 is 4.8 mm. In the region 25, it is 5.6 mm. And in the region 26, it is 2.6 mm. So, as the guidelines given by the manufacturer following strictly, the twist drill was selected in the subsequent number. Firstly, 2 mm was used to drill down as much as from the residual 2 mm from the residual bone. And for the safer drilling, the twist drill was connected with the stopper before drilling was begun. Then, before performing the final drilling, the drill was connected with a stopper of the same height as the pre-measured height of the residual bone, and the maxillary sinus membrane was elevated. After the last drill, a dip is felt and it showed that the sinus membrane is broken. After that, we can see the autograft incorporated in the drill as it has the conical shape. After that, after the final drill, a depth gauge was inserted to check the penetration through the maxillary sinus membrane. And then a hydraulic lifter was inserted into the drilled hole and saline solution was injected slowly by the 2 ml syringe to elevate the maxillary sinus membrane further. After lifting the maxillary sinus membrane by hydraulic lift system, the bone carrier and the bone condenser were used to fill the hole with bone graft material. The bone graft material used here is the autograft, which was extracted while drilling, plus xenograft, and material was spread to the lateral part, followed by implant placement in both the sinus augmented side as well as the edentulous side. Implant size used in the area which is augmented was 3.75 into 10 and 4.8. We can appreciate all the 3 implants placed and then the suturing was done. This is followed. These steps are followed exactly in the area, second quadrant. First, the pressure incision was given, full thickness flap was reflected. Subsequent drills with subsequent stopper was used. After that, a hydraulic lifter was used to lift the membrane further. Bone graft was placed which is pushed inside by mallet. Then implant size used in the augmented area was 5 into 10 mm and 3.75 into 11 mm and suture was placed. And this is a OPG taken after 1 week of the procedure. Patient came with no post-operative complication, uneventful healing took place, and the sinus lift was successfully done, which led to placement of implant of the desired size. So, Kyong Kim et al. In study done in 2013 concludes that the sinus membrane can be elevated safely through the crestal approach with the bone height averaging 3 mm. In this case, crestal approach sinus kit is used. It is a newly developed device for maxillary sinus membrane elevation by the crestal approach using a special drilling system and hydraulic pressure. It contains 2 different kinds of drill. One is twist drill, another one is cast drill, which has a conical hole in the bone in which the bone is formed after drilling. This cast drill allows the dentist to elevate sinus membrane safely. In addition, since the cast drill makes the lateral side round, it can be used safely for maxillary sinus in various forms. This cast drill provides additional function of collecting autogenous bone, and hydraulic lifter is connected with the syringe filled with saline solution, which elevates the membrane further. So to conclude, a survey performed by Kim et al. In 2013 shows that 92% of dentists were satisfied or very satisfied with using casket as compared with their preferred devices, and gave satisfactory easier lifting in sinus membrane. In my case as well, the hydraulic lift system was used, which provided an alternative lower risk method for sinus lift when compared to conventional technique. These are my references.
Dr. Salendra sir and Dr. Prerna ma'am, you can begin with the question answer session.
Okay, Dr. Neelam.
Yes.
Can you differentiate direct and indirect sinus lift procedure?
Yes, sir. Sir, basically, direct sinus lift is done by lateral approach, and indirect sinus lift is done by crestal approach. In direct sinus lift, when we need when the height is less than 5 to 7 mm, then the lateral approach is chosen. Otherwise, indirect sinus lift is the choice of treatment. Otherwise, sir, in lateral technique or the direct technique, the window is made on the buccal side, and in crestal approach, the alveolar bone is drilled down to the sinus membrane, and the sinus lifting is done.
And tell me the types of what are the instruments used for in the sinus lift?
Sorry, sir. Pardon.
What are the instruments used in the sinus lift procedure?
Yes, sir. Sir, particularly in my case, I used casket, that is crestal approach sinus lift system. In this system, it has drill and a stopper. Drill is of conical shape, which has a specific feature of incorporating autogenous graft inside it, which I have used later while grafting my sinus membrane. And also it has a hydraulic lift system in which the saline is filled, and further the sinus membrane is lifted. This is one of the safest method as it lesser the complication like sinus perforation and all. So the hydraulic lift system is used, and then the mallet is used to push the sinus further inside. Also, measuring gauge was used to measure the exact amount of the sinus lifting is done.
Okay. Prerna ma'am.
Okay, nice presentation, Neelam. I just have to ask, usually in crestal approaches, we use putty consistency graft or pasty consistency graft. So, was there any reason for you using day autograft?
Yes, ma'am. Ma'am, I used autograph while drilling, which I got while drilling the sinus membrane, and also xenograph. So autograft I used because it has both osteogenous as well as osteoconductive property, but it has higher resorption time. It resorbs early.
Therefore, I used xenograph as it has a longer duration of resorption time. So I mixed both of them in saline and kept it inside my sinus wall. And as it was mixed with autogenous graft, it has little bit of blood and saline mixed with it. So, ma'am, there was not much difficulty while putting the graft inside.
Okay, so basically the basic limit of using pasty consistency graft is that it will push up a sinus membrane a little. It will help in that also.
Okay.
So yeah, that was the basic point. But
Yes,
nice presentation.
yes, thank you, ma'am.
Okay. Thank you, Dr. Neelam. We can proceed with the next presentation. Presenter is Dr. Kanchan Agarwal.
Myself, Dr. Kanchan Agrawal. My paper presentation title is Clinical and Radiological Evaluation of DFDBA alone versus DFDBA with amnion membrane in the treatment of periodontal interbony defect. Periodontitis is a bacteria-induced inflammatory disease of the supporting tissue of the teeth, frequently resulting in the formation of interbony defect. The primary goal of periodontal treatment are elimination of the infection, resolution of the chronic inflammation in order to arrest the disease of progression and prevent the recurrence of the disease. The therapeutic goal of periodontal therapy is regeneration. Combination regeneration approach like open flap debridement with bone graft, GTR, growth factor have been used successful for treating a complex and large site interbony lesion. Now, case description: a 40-year-old male patient reported to the department with chief complaint of bleeding on gums since 2 to 3 months. This is a image showing the clinical measurement. This is a clinical picture which shows the clinical picture of right mandibular molar, and in which spontaneous bleeding on probing are present, and probing pocket depth was 5 mm. And the radiographic view of 3-6 radiographic view, mandibular molars are seen, and in which the intrabony using a RVG with grid line and interbony defect was seen. We can appreciate that the interbony defect are seen approx 5 mm. This is a clinical picture of 4-6, and bleeding on probing are present, and probing pocket depth was 5 mm. This is a radiographic picture. Interbony, we can appreciate that interbony defect are seen between the second and first molar, approx 5 mm, approx 4 mm. Surgical procedure. In this picture showing a clinical measurement including relative attachment and probing pocket depth measure using a UNC 15 probe. Then intercircular incision is given. Intercircular incision is given with the help of 12 number BP blade on the buccal and lingual aspect. The mucoparietal flap will be reflected. After that, the complete debridement of the defect was done, and with the help of curette, and the defect area was irrigated. And we can appreciate that osseous defects are seen clearly and visible between the right mandibular first and second molar. And after that, pre-suture were placed. After that, the bone graft DFDBA was placed over the defect area. After that, the flap was approximated and sutured, then periodontal dressing were placed. This is a clinical clinical measurement of amniotic. This is a this first and second image which shows the clinical measurement including relative attachment level and probing pocket depth was used for using a UNC 15 probe, and intercircular incision was given using a 12 number blade. After that, mucoparietal flap is elevated, and then complete debridement of the defect was done, and with the help of curette. Defect area was irrigated, defect area was irrigated then the osseous defect was clearly visible, and between the left mandibular first molar and second premolar. Then this is a bone graft and trimmed amniotic membrane with template. After that, the pre-suture were placed, and DFDBA was placed on the defect area. After that, the amniotic membrane are placed over the bone graft, and then the flap approximated and suture and periodontal dressing were placed. After 6 months follow-up, there was reduction in probing pocket depth and relative attachment level, and radiographically we can appreciate the bone frill about 2.5 mm. In this 6 month 6 month follow-up in side 2, there also reduction in the probing pocket depth and relative attachment level, and in radiographic view we can appreciate that bone fill was seen in 2 to 2 mm. Discussion: amniotic membrane, natural biodegradable membrane which consists of 4 layers, and these layers consist of growth factors, collagen fibers, and proteoglycans and non-collagen proteins, which promote the healing, and regeneration. This is a table which compile in brief about the various membrane and DFTB used for regeneration with their result. Both the sites shows significant improvement in clinical and radiographic parameters, and amniotic membrane in novel membrane barrier in conjunction with DFTBA, and gives predictable result, and long-term study required to get more conclusive findings.
Salendra sir and Prerna ma'am, the mic is all yours.
Okay, Dr. Kanchan, from where did you get this amnion membrane?
Tata Memorial Hospital in Mumbai.
Tata Memorial, Mumbai. Okay, tell me the limitations of amnion membrane.
Sir,
Limitations of
Sir, amnion membrane maybe it transfers the it transfer the infective disease like in a HIV patient, any they
Okay, tell me the properties of amnion membrane.
Sir, amniotic membrane contain growth factors like keratinocyte growth factor, basic fibroblast growth factor, transforming growth factor, and epidermal growth factor, and vascular endothelial growth factor, and they also contain proteoglycans, and they also contain laminin 5, and they have anti-inflammatory activity and anti-inflammatory activity. It reduces the it increases the vascularization, and they have reduce the pain of the surgical site, and
Okay, can you classify bone grafts? Can you classify bone graft? Classification of bone graft.
Yes, sir. Sir, like, allograft, xenograft, and allograft, xenograft, alloplast, and
Okay, okay. And then DF, DBA in comes which category?
sir, allograft.
Okay, fine. Fine. My question over.
Prerna ma'am, do you want to ask any questions or can we proceed?
Okay, just one question, Dr. Ranjan. What is the residual calcium content for DFDBA? What is residual calcium content for DFDBA? Optimal residual calcium content for DFDBA. Okay, how did you standardize your radiographs? What measures have you taken for standardization of your radiographs?
Ma'am, in radiography, we using a RVG and with a grid line.
That is radiographic technique, that is not methods of standardization. Okay, I'm done. Dr. Asad, I think we can proceed.
Thank you, Dr. Kanchan. We will proceed with the last presentation of this session by Dr. Ruchi Gaisote and Dr. Shukra Paralkar.
Good afternoon, everyone. I'm Dr. Ruchi Gyasota. My topic for presentation is effect of ribose cross-linked collagen membrane or 6+ on membrane exposure and soft tissue integrity during regeneration of intraosseous defects, the authors of which are myself and Dr. Shukra Paralkar. My abstract ID is 448320. Introduction. Regeneration is a desirable endpoint for intraosseous defects. The use of resorbable GTR membranes has been well documented. The ability of collagen to stimulate adhesion, chemostasis, physiological degradation of progenitor cells makes it an ideal material of choice. There are certain advantages of using a collagen membrane, that is, it has high biocompatibility, low antigenicity, low cytotoxicity, physiological degradation, and collagen matrices calcify or ossify when placed in the proximity of a bone. The certain disadvantages of using a collagen membrane are mucosal dehiscence, membrane exposure of collagen membranes. O6+ is a ribose cross-linked collagen membrane consisting of type 1 collagen of porcine origin and is cross-linked to a much higher degree, resulting in a longer barrier function of 4 to 6 months. This cross-linking increases structural stability, slows down degradation process, enables long-term osteogenic activity, and ultimately influences barrier longevity. The rationale of my study is, since cross-linked membranes are prone to premature membrane exposure than non-cross-linked membranes, the overlying mucosal dehiscence along with the membrane exposure may lead to less than adequate new bone formation. Ribose cross-linked porcine collagen membrane, that is O6+, appears to be more resistant to bacterial collagenollytic degradation. Methodology. A 30-year-old patient came with a complaint of bleeding gums in the upper right back tooth region of jaw since a month. Periodontal clinical examination revealed pocket of 6 mm in 1/6 on mesial and distal aspect. At the initial appointment, patient received oral prophylaxis and radiographic examination. Consent of the patient was taken. After 2 weeks of follow-up, there was no reduction in the probing pocket depth. Surgical steps. Perioral scrubbing with povidone iodine was done. Open flap debridement was carried out using administration of local anesthesia, 2% lignocaine with 1:80,000 epinephrine. Flap reflection was done. Sulcular incisions were given for the reflection of full thickness flap and a mucoperiosteal flap was raised. No vertical releasing incisions were given. After throughout debridement, site was grafted with synthetic nanocrystalline hydroxyapatite beta TCP bone graft. Membrane placement was done in 2 steps. First, the O6 plus membrane was trimmed to extend 2 to 3 mm beyond the defect margins. Secondly, it was placed over the grafted sites. Suture placement was done by primary closure using 3O interrupted sutures and periodontal pack was placed. Post-operative instructions to the patient were given as amoxicillin 500 mg thrice a day for 5 days, non-steroidal anti-inflammatory analgesics were given, 0.2% chlorhexidine gluconate antibacterial rinse for 15 days twice daily. Follow-up examinations were done at 7 days and 30 days, which revealed that this is the pre-operative radiograph, 7 days follow-up and 30 days follow-up period. Result. The membrane outcomes had 2 results. Firstly, ease of handling and stabilization. The membrane was placed easily and confirmed well. Exposure of the membrane showed that overlying mucosa covering the membrane remained intact throughout the follow-up period. Soft tissue outcomes were given as complete approximation of flap margin and wound approximation was observed throughout the follow-up period. Discussion. Ease of membrane handling and placement is a primary advantage of O6 Plus. Complete soft tissue closure was achieved at the end of 30 days. The membrane seems to have a potential benefit in soft tissue healing following membrane exposure. Concluding my study, on the basis of the case report, it can be concluded that O6 Plus membrane can withstand bacterial collagenollytic degradation and assist in complete gingival margin closure. Also, O6 plus collagen membrane allows soft tissue healing and dehiscence closure. These are my references. Thank you.
Dr. Shailendra sir and Dr. Prerna, you can begin with your question answer.
Dr. Ruchi, can you explain the repair, regeneration, and new attachment? What is repair, regeneration, and what is new attachment? What is repair, regeneration? Am I audible?
Yes, sir.
Am I audible? What is repair, regeneration, and new attachment?
So new attachment will be from a certain position. Regeneration, that means there is a loss of a tissue, and we are adding substances which would promote the site to induce.
Your answer is not. Your answer is not clear. Actually, tell me the second question. Factor affecting the clinical outcome of GTR. Which factor affecting the clinical outcome of GTR?
So, sir, in O6 plus, yes, sir, the scaffold helps us. So the scaffold leads to the formation of the. Hello, am I audible, sir?
Hi, you are audible. You are audible.
Yes, sir. So the scaffold leads to the formation of the new bone.
Dr. Prerna, madam, you can ask.
Okay, sir. Thank you, sir. Ruchi, what is critical defect angle?
Sorry, ma'am.
What do you understand by critical defect angle? Okay, can you tell me something about state of this O6 plus membrane, how it resolves, in how much time, whether it resolves from periphery to within or how?
Ma'am, so O6 plus, ma'am, the barrier effect is from 4 to 6 months, and the resorption is, ma'am, it occurs from the center to the periphery, as the collagen membrane, with the help of the collagen membrane.
Okay, done.
Okay, thank you, Dr. Ruchi. With this, I am ending this session, sixth session. I thank you, Dr. Prerna ma'am and Dr. Shailendra Singh Chauhan sir for taking out your valuable time and chairing this session and being a part of this first ever of its kind virtual PG convention.
Thank you, Dr. Rashid. I'm sorry for the net problem.
Yes, sir.
Net problem. Thank you.
Thank you, Dr. Rashid. Thank you, Shalini, sir.
Thank you, ma'am.
Thank you, madam. Thank you.
With this, now I begin the session 7. I may introduce the chairperson for this session, Dr. Rasmita Naik. She is professor of Institute of Dental Science, Bhubaneswar, and Dr. Nilima Katti, ma'am. She is reader from ICV Government Dental College and Hospital, Cuttack. Ma'am, you can kindly please adhere to the time limit of the judging for the time for the question answer session of 2 minutes. We may present the first presenter is Dr. Praruna Pradhan. Can we have the video, please?
Hello, everyone. Title of my paper presentation is the application of injectable platelet-rich fibrin and xenograft in the treatment of infra-bony defect. For over 3 decades, use of platelet concentrate represents a regenerative tool capable of releasing growth factors responsible for inducing tissue regeneration derived from autologous sources. Among them, the recent advanced liquid form of platelet concentrate, injectable platelet-rich fibrin, was developed, which shows a total increase in leukocytes prior to the formation of a fibrin clot and allows growth factors, including vascular endothelial growth factors, transforming growth factors beta 1, and platelet-derived growth factors to remain in the end product. IPRF, when used in combination with particulate bone graft, allows a more effective incorporation of graft material to the host tissues. This approach of incorporating bone graft without anticoagulants or other additives has revolutionized the grafting. The present case report focuses on the outcome of the use of IPRF with xenograft, utilizing clinical and radiographic evaluation criteria in intra-bony defect. And 44 years old female was referred to the Department of Periodontics, DAV, Dental College and Hospital, Yamunanagar, Haryana, with a complaint of pain and sensitivity in relation to physics. On examination, the patient was systematically healthy and had not taken any form of long-term anti-inflammatory medications or antibiotics. The periodontal charting and radiographs revealed a case of localized chronic periodontitis with a proving depth of 5 mm. Initial therapy consists of scaling and replaning of the teeth, followed by oral hygiene instructions. After 3 weeks of phase 1 therapy, a periodontal re-evaluation was performed to confirm the suitability of number 36 tooth for periodontal surgical procedure. Clinical measurements were made using periodontal probe with graduation to a precision of 1 mm. Blood sample was taken on the day of the surgery according to the IPRF protocol. 9 ml of blood was taken from the patient without an anticoagulant in 10 ml glass test tube and immediately centrifuged at 3300 rpm for 2 minutes, according to Morrow et al. Upon termination of this process, an orange-colored area is observed in the test tube and the remaining blood materials below. 2% lignocaine with 1:80,000 adrenaline local anesthesia was administered to the site. An intracircular incision was made on the buccal and lingual aspect of the tooth, and the full thickness flap was raised. The inner surface of the flap was curated to remove granulation tissues, and the root surface was thoroughly planed using hand instruments and ultrasonic scalers. IPRF was collected from the tube using 2 ml syringe with 24-gauge needle to prepare this mixture. A dependence dish was used. After 5 minutes, bone particles were gradually added. Within 15 minutes, polarization starts and the material being ready for use in 20 minutes. The material was applied and condensed to the defect walls and root surfaces. The
Flap were repositioned to their pre-surgical levels and sutured with self-utilizing an interrupted technique. After the operation, the patient was prescribed with systemic antibiotics, that is amoxicillin 500 mg TDS for three days, non-steroidal anti-inflammatory drugs, ketorolac, and 0.12% chlorhexidine twice a day for 14 days. Sutures were removed after 10 days, and the clinical healing was normal with neither infectious episodes nor unexpected clinical symptoms, and patient was kept on maintenance therapy. The patient was recalled after 3 months. Periapical intraoral radiographs were obtained from the periodontal defect site as at baseline and 3 months after the surgery. In this case report, the reduction in probing depth was found after 3 months of follow-up. Radiograph revealed improved bone fill in the intra-bony defects compared to measurements at baseline. Clinical parameters and radiographic assessment at the baseline and 3 months are the parameters taken were the probing pocket depth and the defect depth. Where the probing pocket depth was and baseline was 5 mm, and after the surgery, that is after 3 months, it was recorded as 3 mm. And the defect depth in baseline was 4 mm, and after 3 months it shows 3 mm. Discussion. The ideal goal of periodontal therapy is to regenerate the lost periodontal tissue caused by periodontitis. Many treatment modalities have been suggested, which includes the use of bone grafting materials, the use of platelet concentrates, including PRP and PRF, which both utilize supraphysiological doses of autologous growth factors. Concerns were made in PRP due to presence of anticoagulants. Due to recent findings by Ganati et al., who introduced low-speed concept for blood centrifugation, since low centrifugation speeds were shown to contain higher number of cells, including leukocytes, prior to the formation of fibrin clot. It recruits and directs various cells during wound healing process. Bone graft in combination with IPRF have shown to increase the regenerative outcomes. IPRF with the bone graft has its own body and can be easily molded into the required shape, thus aiding in its easy handling and also in preventing dispersion. Leukocytes are immune cells having vast property in tissue regeneration. So the result of this report shows that with the use of IPRF and bone graft material, it was possible to regenerate intra-bone defects. Conclusion, IPRF showed the potential for regeneration since it has number of growth factors which are responsible for tissue regeneration capable of inducing fibroblast behavior. Further studies are required to know the potential of IPRF as a regenerative material. Thank you.
Dr. Rashmita ma'am and Dr. Nilima ma'am, you can start with the question answer session.
Yes, why only IPRF has been taken? If anything else could have taken, why did you prefer IPRF?
Ma'am, actually it is a recent advancement. So we were trying to see the result of this advanced IPRF.
What is new in this study? What is new in this study?
Ma'am, it's a liquid form with the low speed concept. So basically in this, we won't be we won't be any manipulating anything with clot. In fact, we'll be taking an orange area which is in liquid form only. In an injectable form, we'll be manipulating in an appendage and put a bone graft and mix it and keep it for about 20 minutes so that polymerization starts and it forms a stick, gives a stick like for the product, so that we can enter it, we can condense it into the defect.
It's a sticky material, right?
Yes, ma'am.
Okay. Nilima,
Yeah, one small query. What do you think is the main drawback of your study, of your whatever case series or case report?
Ma'am, drawback. Ma'am,
Yeah.
actually, I have not found any major bone gain till 3 months. After 3 months also, it's like
See,
1 mm game only, ma'am. So
no, 3
soft
months
tissue.
is actually 3 months is not the ideal time where you.
Yes, ma'am. Ideal
seek
time is
for
not
some.
ma'am. So we
Yeah.
are waiting
And
for
second
6
thing,
months.
Second thing, you have used the word bone regeneration. Unless you use
Yes,
the
ma'am.
GTR membrane, okay.
Yes,
Unless
ma'am.
you use a GTR membrane, you cannot use the word because it is a bone-like tissue. You have used a bone filler.
Yes,
Okay, you can just call it as a bone. Whatever the radio opacity you have got, you cannot say it for sure. It is a bone or bone regeneration has taken place.
Yes,
okay, that you can only tell after histological observation. So it's always a bone-like tissue, and without using a GTR membrane, you cannot expect any kind of regeneration. Okay.
Yes, ma'am.
That's all, ma'am.
What is the time length it is expected for you to? I mean, if you would have wanted to wait it for some more time, like what would have been the time length? You said 3 months, right?
Yes, ma'am. Ma'am, it's 6 months. In some articles, they are written for 6 months, 3 months and 6 months baseline.
Actually, 6 to 9 months. And only
Yes, ma'am. 6 months we can. I think we can get more results, ma'am.
Okay. Nilima, anything else you want to ask?
No, ma'am. That's all, ma'am.
Okay.
That's all.
Okay.
Thank you, ma'am.
Okay. Thank you.
Right.
Okay, thank you, Dr. Prarona. We can now begin our second presentation. Presenter is Dr. Pooja Naik.
My topic for paper presentation is non-incised papilla surgical approach, that is NIPSA, a novel technique for papilla preservation, a case report. The contents include introduction, case presentation, surgical procedure, results, discussion, and conclusion. Coming to introduction, the ideal objective in treatment of periodontal defects is regeneration. The three optimal conditions that re-establish the periodontal complex is space provision, wound stability, and primary intention healing. The conventional flap surgeries where incision is placed on the marginal tissues cause lack of primary closure, flap dehiscence may occur, and biomaterial exposure can also occur. However, NIPSA is a novel technique which maintains the integrity of interdental soft tissues, increases the amount of space for hard and soft tissue regeneration, prevents gingival recession, and prevents biomaterial exposure. The indication for NIPSA is that the periodontal defects when buccal wall component is affected and adequate buccal access allowing an appropriate root and defect debridement. Advantages: it optimizes the wound closure by primary intention healing, ensures the integrity of papilla and marginal soft tissues, promotes the space provision for clot, there is better preservation of blood supply. Scientific rationale: NIPSA improved the clinical outcomes, reducing the risk of the soft tissue collapse, providing supraalveolar soft tissue stability. Basic principle is placement of one buccal horizontal incision as apically as possible from the periodontal defect and marginal tissues and raising the flap coronally by permitting the apical access to the defect while maintaining the marginal tissues intact. Coming to case presentation. A 50-year-old female, systemically healthy patient came to the Department of Periodontology with the chief complaint of bad breath and food lodgement in lower front and back region of the jaw. On oral examination, it was revealed a pocket depth of 6 to 7 mm in 4-2 region and 4 to 5 mm in 3-6 and 4-6 region. After phase 1 therapy, patient was re-evaluated and probing pocket depth of more than 5 mm was persistent with 4-2 region. In phase 2, that is surgical phase, NIPSA was planned out with 4-2 region. Coming to surgical procedure. In step 1, on buccal aspect, one horizontal incision was placed as apically to the interdental and marginal soft tissues coinciding with the alveolar crest of the defect. The incision was placed using microsurgical blade. Later, the extension of the incision was carried out mesodistally to expose the cortical bone around the defect, allowing correct debridement. In step 3, soft tissues were reflected coronally to expose the bony crest. Debridement was carried out using mini curettes and root planing was also done. In step 4, simple interrupted sutures were placed to achieve the primary closure. Coming to results. Soft tissue integrity was evaluated at 7-day and 1-month follow-up. Flap dehiscence was not observed throughout the follow-up. According to wound healing index proposed by Landry, Turnbull, and Hawley, a score of 5, that is excellent, was given at 1-month follow-up. Measurement of tip of papilla remained same at baseline and 1-month follow. Thus, complete wound approximation at 1-month follow. Coming to discussion. The disadvantages of conventional flap is that during elevation of flap, circular incision is placed and connection of gingiva periostal plexus, which provides vascularity to the tissues, is severed. Thus, vascular trauma is induced. There is soft tissue contraction which occurs, so the overall outcome is anesthetic. Soft tissue necrosis lead to increased contamination of the regenerated area. However, NIPSA, that is non-incised papilla surgical approach, causes unaltered integrity of supraalveolar soft tissues and act as a dome protecting the clot, enhances the wound healing and stability, and prevents mechanical trauma during early healing period. In this, the space can be maintained horizontally and the defect is protected from horizontal collapse. Coming to conclusion, in this case report, NIPSA showed a positive tendency in maintaining soft tissue integrity by preventing flap dehiscence and leading to complete wound approximation. Thus, it can serve as an alternative to the conventional flap techniques in which the incision is placed marginal tissues. Future considerations. Further RCTs are required comparing the two techniques involving evaluation of other clinical parameters like probing depth and CAL with a long-term follow-up period. These are the references. Thank you.
Neerya ma'am and Rashmita ma'am, you can begin the question answer session now.
Okay. Dr. Pooja?
Yes, ma'am.
Did I miss out something? How did you check the presence? Like, how did you check the position of crustal bone through bone sounding?
Yes, ma'am. The crustal bone was evaluated by using bone sounding.
You did mention that. You did mention
Yes.
that in your first. Okay,
Yes,
sorry, I
ma'am.
moved it out.
Sorry.
One more thing is, how did you ensure complete defect was debrided with root planing? Because it's a very conservative procedure.
Yes, ma'am. It was a conservative procedure. However, the bleeding which was induced after the debridement, so it was by the color of the blood which was initiated after the debridement. It was a bright red color, so we can justify that by.
So what if I have to use a membrane? There is a vertical defect. I'm not able to visualize the kind of bone defect in that area. So what if I have to use a membrane in that area? Don't you think it's a limitation of this technique?
Ma'am, actually, Rodriguez has used this technique for isolated buccal defects where there is a vertical defect. So he has used EMD and he has also done the root conditioning for that. So, however, in my case, the defect was non-containable. I haven't used a bone graft, and also the GTF procedure haven't been done in my case. However, the Rodriguez has proved the clinical significance and the results are significantly positive in intrabony defects.
Exactly, because complete visualization of the defect is not possible with such a conservative surgery. So that can be a limitation.
Yes, ma'am. Yes, ma'am.
Ma'am, Rashmita ma'am, over to you, ma'am.
Yeah. Just tell me one disadvantage of this procedure.
Ma'am, first is the access. So if there is a limited access to the buccal, I mean, in the posterior region, it is quite difficult to carry out this procedure in the posterior jaw. Also, in case of where there is multiple teeth or multiple defects which are involved, teeth involving the buccal defects or maybe lingual defects, so this cannot be accessed through this technique. So that can be a disadvantage. The accessibility as well as the lingual component of the defect which can be involved in some cases.
Are there any studies where it has been done lingually?
No, ma'am. Right now, there are no studies as such conducted. They have been conducted only in isolated defects and not in multiple defects.
Ma'am, one minute. Yes. In the original study, did they check for any shrinkage of the papilla post?
Sorry, ma'am.
Any shrinkage of papilla?
Yes, ma'am. They have checked the tip of the papilla also, and they have also evaluated the probing pocket depths, and the CAR has also been evaluated in those studies.
Okay, so there was no shrinkage?
No, ma'am. No shrinkage was found in NIPSA. However, in MIST and other conventional techniques, there was quite a shrinkage which was seen.
Okay. Okay. Thank you.
Thank you, ma'am. Thank you so much.
Thank you. Thank you, Pooja.
Thank you.
Okay. Thank you, Dr. Pooja. Now, can we have the next presentation by Dr. Samarpita Nanda?
I'm Dr. Samarpita Nanda, third year postgraduate student, Department of Periodontics from Rumta Dental College, Bhilai, Chhattisgarh. My topic for paper presentation is surgical reconstruction of vast periradicular lesion post-endodontic therapy failure. Untreated pulp tissue necrosis may lead to periapical periodontitis, which represents a response of the bone around the apex to restrain the local infective offense. The main cause of unsuccessful periapical healing after primary endodontic therapy is the persistence of bacteria and infected tissue in the endodontic space even after orthograde endodontic treatment and retreatment. In such cases, the last resort to maintain the tooth is represented by apical surgery. Case description. A 33-year-old female patient reported to the department with chief complaint of discoloration of upper front teeth and pus discharge from the same area since 4 years. The patient gave history of trauma in upper front region of jaw about 15 years back, followed by discoloration in her teeth. She also gave history of root canal treatment 1 month ago and persistent pus discharge even after her root canal treatment. So coming to the intraoral examination, discolored 1-1 and 2-1, sinus opening with respect to vestibular area of 2-1, pus discharge from the sinus, but there was no mobility found with respect to 1-1 and 2-1. Preoperative radiograph. We can see gutta percha point extruding beyond the apex of 1-1, suggestive of over-obturation. Also, we can see oval-shaped radio-opacity with respect to the apex of 2-1, suggestive of intracanal medicament. Well-defined radiolucency with well-defined radio-opaque margin with respect to periapical area of 1-1 and 2-1, suggestive of periapical cyst. Now coming to the surgical procedure. Incision design. Trapezoidal incision, or we can say rectangular incision, was given for the proper visualization of the defect area. Here in this incision design, circular incision along with 2 vertical incisions were given. The mucoperiosteal flap was reflected using periosteal elevator. Then complete enucleation of the cyst was done using Lucas curette. Root end resection was done using burrs almost perpendicular or at 90 degrees to the long axis of tooth. Root end preparation of 1-1 and 2-1 was done with burrs slightly greater than the canal diameter to about 2 mm. Tetracycline powder was placed in the defect for 2 minutes and then the defect was irrigated. Tetracycline was used to remove the smear layer and for antimicrobial action. Retrograde filling was done using mineral trioxide aggregate. Platelet-rich fibrin, in this case, LPRF, that is leukocyte PRF, was prepared according to Chokron et al. 2000, where 9 ml of patient blood was centrifuged to 3000 RPM for 10 minutes. Then the obtained PRF was mixed with perioglass, which is an alloplast containing calcium phosphate silicate bioactive glass. The obtained mix was placed into the defect and then the flap was reapproximated and sutured. Periodontal dressing was placed. Now histopathological view. Hematoxylin and eosin stain biopsy section showing cystic lumen surrounded by granulation tissue and thin fragments of epithelium. The 10 days post-operative clinical picture shows uneventful healing. Here we can see 3-month post-operative pictures. Picture A is the clinical picture showing uneventful healing and picture B is the periapical view taken after 3 months. Here we can appreciate the defect fill. Discussion. Reconstructive surgery along with PRF and bone graft successfully improved the treatment outcome in such vast periradicular lesion. Several studies reported PRF application to endodontic surgery, describing reduced morbidity and discomfort for the patient and accelerated healing. PRF is a strong natural fibrin matrix which concentrates platelet fibrin, growth factors like transforming growth factor, platelet-derived growth factor, vascular endothelial growth factor, insulin-like growth factor, and matrix glycoprotein like thrombospondin 1. Thus, it is preferred material to promote healing and achieve hemostasis in bone defect. Now, conclusion. Periapical reconstructive surgery is a predictable treatment option to save a tooth with apical pathology that cannot be managed by conventional non-surgical endodontic treatment. The use of various autologous material along with MTA, that is mineral trioxide aggregate, PRF, that is platelet-rich fibrin, and perioglast bone graft enhance healing. After treatment, keep the patient in maintenance phase, including timely clinical and radiographic evaluation, which will help in the eventful success of the treatment outcome. Thank you.
Okay, Dr. Rashmita ma'am and Dr. Nilima ma'am, you can begin the question answer session now.
Yes. What is the role of MTA in your study?
Ma'am, it was used as a retrograde filling material, ma'am. So that to restrict the exit of bacteria from the canal to the periapical area, ma'am. Ma'am, after doing the root resection, the root end was prepared a little greater to the diameter of the canal, and then it was sealed using a retrograde material. In this case, we have used MTA because it is a biocompatible material and it is not affected by moisture or blood, and thus it is used, ma'am, in this case.
What could have been the other option if MTA would not have been there?
Ma'am, biodentine can also be used, ma'am. And ma'am, biodentine is a combination of super EBA, that is ethoxybenzoic acid, and GIC. It can also be used, ma'am. Other materials are also there, but they are affected by moisture. Like we can also use amalgam, GIC, but these are affected by moisture. So preferred material is biodentine and MTA, ma'am, for retrograde filling.
And which PRF you have used here? What
Ma'am, LPRF I have used here according to Chokron et al., which was done in 2000 and published in the year 2001. Ma'am, and this PRF was mixed with perioglast, which is the alloplastic material, so that the bone graft is in its place for because of the consistency of fibrin. So, ma'am, the PRF was mixed with perioglast and placed in the defect area, ma'am.
Why did you choose perioglast?
Ma'am, because ma'am, we wanted to study
you could have gone for some other grafts. There are so many available, right? Why? Is there any specific reason behind it?
No, ma'am. Ma'am, because of the availability, and we wanted to see the results of because previous studies they have not used PRF and this particulate bone graft in apicectomy lesion.
One question. Yeah, one question. Thank you, ma'am. One question. We are progressing towards more conservative surgeries now. Yes, so don't you think your incision could have been modified to be more conservative? Your lesion was in the apical region.
Yes,
right. So you could have spared the middle and coronal 1/3 of the bone, yes, especially considering it is a aesthetic region.
Yes, ma'am.
So can you name any incision technique or any surgery you could have followed?
Yes, ma'am. Ma'am, semilunar incision technique is also, yes, ma'am. It was given by part, and ma'am, triangular incision technique, Lubbo's incision technique was done, ma'am.
Yeah. So why did you opt for those incision lines rather than going for a full-fledged trapezoidal flap?
Ma'am, actually, it was the first time we were doing, so it was.
You cannot say like that.
Yes, ma'am. Ma'am, semilunar incision would have been a better option, ma'am, in this case, when the defect was.
Because being a periodontist, this is a completely periapical lesion.
Yes,
It's an
ma'am.
endodontic lesion, so the periodontal implications are very few. So
Yes,
as a periodontal surgeon, you could have shown your skill by making it minimally invasive
ma'am.
surgery. Okay.
Yes.
So next cases, if you are going to do, try to be less invasive, especially if it is not involving a periodontal lesion. Okay.
Yes, ma'am.
If it is a
Yes, ma'am.
periapical lesion, go for some conservative incision line. Okay.
Yes, ma'am. Thank you, ma'am.
Yeah. Ma'am, that's all, ma'am.
Yeah. Okay.
Thank you, ma'am.
Thank you, Nanda.
Okay. Thank you, Dr. Samarpita. The next presentation, we can move on to the presenter is Dr. Milton Leichenbaum.
Good morning, everybody, respected judges and my fellow colleagues. Today, I am here to present a case report on topic lobular capillary hemangioma and inflammatory hyperplasia with heterogeneity in presentation. Starting with the introduction, a pyogenic granuloma or a lobular capillary hemangioma is an inflammatory hyperplasia of oral cavity commonly seen in females in response to local irritant, traumatic injury, sex hormones, or certain drugs whose exact cause is unknown. The term pyogenic granuloma is a misnomer because the lesion does not contain pus and strictly speaking is not a granuloma. The term pyogenic granuloma was coined by Hazel in 1904. It represents as a smooth or lobulated exophytic lesion manifested as a small red erythematous papules on painless, pedunculated, or sometimes sessile base, which is hemorrhagic. It may differ in size from few millimeters to several centimeters. Surgical excision is the treatment of choice, followed by the curettage of the underlying lesion. Here is a case patient with age of 40 years female presented in our department of periodontology with a chief complaint of swelling of gums in the upper front tooth region, which were gradually increasing in size. Since 3 to 4 months, the mass was not painful but often bleeds while brushing, eating, or sometimes spontaneously. The past medical history was non-significant. The personal history, patient reports of irregular menstruation for the past 6 months and is not under regular medication for the same, and neither has the history of using oral contraceptive. Extraoral examination was non-significant. On intraoral examination, localized gingival swelling in relation to 1-1 and 1-2 was seen as in the figure. The size was 18 mm to 12 mm. Shape was lobulated, the surface was smooth, and the type of lesion was exophytic, pedunculated base, hemorrhagic with spontaneous bleeding on probing. The oral hygiene was poor. On hard tissue examination, all teeth were present with the atraumatic occlusion, grade 1 mobility with respect to 1-1. Considering all the above features, the provisional diagnosis of pyogenic granuloma was made. Differential diagnosis such as fibroma, peripheral giant cell granuloma, pregnancy tumor, and conventional granulation tissue was made. Treatment plan: phase 1 therapy followed by an excision and biopsy was planned. Scaling and root planning was done in the first appointment, and the patient was advised to perform and maintain a good oral hygiene practice. After 1 week recall, gradual reduction in the growth was seen, as in the picture. Thereafter, it was decided to treat the lesion with a surgical approach after 1 week. The surgical procedure: LA was given with LA with adrenaline of 1:2 lakhs was administered, and the lesion was excised with the help of an electrocautery up to the base of the lesion, and no remnants of the soft tissue adjacent to the tooth are left to prevent the recurrence of the lesion. Antibiotics and analgesic were prescribed for 1 week. The excised tissue was sent for histopathological examination to the Department of Oral Pathology, MMCDSR, Mulana. From the histopathologically, the presence of blood vessels, dense collagen fibers bundles with mild chronic inflammatory cell infiltrate reveals the presence of pyogenic granuloma. As in the image. And final diagnosis: after careful clinical evaluation and histopathological correlation, the final diagnosis was confirmed as the lobular capillary hemangioma, which is a type of pyogenic granuloma. Follow-up was made after 1 week and 6 months for the checkup, and there was no growth visible clinically, as it is after 1 week, and as in the second picture is after 6 months. Discussion. Pyogenic granuloma is an inflammatory hyperplasia formed as a result of exaggeration, reaction of connective tissue to some localized minor lesion or any underlying irritation or hormonal changes. Gingiva is the most common site followed is a common site affected, followed by the buccal mucosa, tongue, and lips. Pyogenic granuloma in general does not reoccur, but when excised along with its base and all the causative factors are removed. From a histological point of view, there are two kinds of pyogenic granuloma. The first one is called as the lobular capillary hemangioma, characterized by the proliferating capillaries which organize in lobes, and the second type as non-lobular capillary hemangioma consists of vascular proliferation resembling the granulation tissue. So differential diagnosis such as fibroma, peripheral giant cell granuloma, pregnancy tumor, and conventional granulation tissue is done on the clinical and histological features, which help in providing adequate clinical treatment and a good prognosis. Histologically, the surface epithelium may be intact or may show foci of ulceration or even exhibit hyperkeratosis. It overlies a mass of dense connective tissue composed of significant amount of mature collagen. In order to determine the pyogenic granuloma diagnosis, some factors such as hormonal changes during puberty or pregnancy, administration of certain drugs, and some kind of trauma should be considered. In the present case report, presence of pyogenic granuloma can be related to the possible female sex hormonal disturbances and the local factors such as the absence of interproximal contact, presence of calculus, and poor oral hygiene indices. Although pyogenic granuloma, on conclusion, although pyogenic granuloma is a non-neoplastic growth in the oral cavity, proper diagnosis, prevention, management, and the treatment of the lesion are very important. So, removal of causative irritants such as plaque, calculus, foreign materials, and the source of trauma is the major line of treatment. Excisional surgery is the treatment of choice for pyogenic granuloma. Thank you.
Ilya ma'am and Rashida ma'am, you can proceed with the question answer session now.
Yeah, under the etiology of pyogenic granuloma, what are the major factors, most common factors associated with capillary hemangioma, lobular capillary hemangioma?
Yes, ma'am. Actually, these are local irritant, mostly like calculus or plaque deposition.
Exactly. So, don't you think your history was incomplete because nothing related to oral hygiene habits of the patient was mentioned, considering it as a major factor in the etiology? In the history, you missed out. Yeah.
Yes, ma'am. Actually, she have a history of irregular menses, so I was little concerned about the hormonal.
Yeah, okay, but even the oral hygiene history, you have not mentioned anything about the patient oral hygiene practices. And second thing, was there any bone loss in that region around the lesion? Or
yes, there was a mild. Yes, there was a mild bone loss was there.
Yeah, because the teeth look like they have pathologically migrated.
Yes, ma'am. There was bone loss.
So just excising the lesion would have solved the issue in that region, considering there was bone loss and pockets.
Yes,
you just went for excision of the lesion.
Excision of the lesion.
So if the patient had pockets in that region, he would have again undergone a surgery for flap, for pocket reduction. So both of them could have been done in a single sitting.
Yes,
ma'am, over to you, ma'am.
Yeah, thank you, Nilima. Dr. Milton, if I'm not wrong, you've written the patient didn't have any hormonal history, but now you are saying there's a positive history of irregular menses.
But yes, she has irregular menses, but she have not taken any medication for that one.
No, you have written there is no history as such. Anyways, you would have shown the IOP at least, okay? You would have seen the bone loss. There was no IOP, like I couldn't see anywhere. Did you show any IOP?
No, ma'am. IOP was not available. I would check it with this one with the probing.
Yeah, that is clinically okay, but as it a huge reason, you could have showed an IOP, right? That would have given a better picture of bone loss.
Yes.
Yeah, that's the one big lacking point I could see.
Yes, sir.
That's it.
Thank you.
Okay, thank you, Dr. Milton.
Thank you, sir.
I may request the tech team to go for the next presentation by Dr. Visaj Maru.
Good morning, everyone. I, Dr. Visaj Maru, will be presenting a paper on the topic Preserving Natural Tissue Contour of Extraction Socket using Modified Interpositional Vascularized Augmentation Neogenesis MEI Technique, a case report. Introduction. According to Johnson K. et al. In 1969, the post-extraction alveolar ridge resorption and alteration in the soft tissue contour is an inevitable consequence with maximum tissue changes observed during the first month. So the soft tissue management of the edentulous socket is an important to maintain the optimal contour and to increase the keratinized mucosa, thus improving the aesthetic and functional outcome in implant dentistry. So, when the natural tooth fails related to endodontic origin, a thin facial plate at the root apex may be partially or completely absent, preventing the placement of an implant at the time of extraction. This was given by Kosinski T. et al. In 2015. Thus, a delayed approach may be necessary by grafting of the socket for development of the site to accommodate eventual implant placement. Rationally, rebuilding the soft tissue with hard tissue augmentation of the extraction socket frequently becomes difficult due to poor blood supply in the overlying soft tissue graft. This was mentioned in the article by Fagan MC et al. In 2008. Objective was to evaluate the soft tissue and hard tissue contour of the extraction socket. Case presentation, the study design, it is a case report. Ethical approval and informed consent was obtained from the patient before commencing the surgical procedure. Clinical case, a 25-year-old male patient presented to the Department of Odontology with a root piece in the upper right back region of the jaw. His medical and dental history was non-contributory. Treatment plan. After extensive clinical and radiographic examination, it was determined that the tooth was indicated for extraction. Routine blood investigations were carried out and the results were known. So as we can see in the image, it's a root piece with respect to 1.5. So the technique termed E1 consists of hard tissue grafts, various barrier membranes, and with a pedunculated connective tissue graft. So with the surgical procedure, in the first image, we can see a pre-op with root piece 1.5. 2% lignocaine with 1:80,000 adrenaline was administered. Extraction was done using the luxator. Atraumatically, tooth was extracted and the socket was thoroughly curated to remove any residual tissue. So in the next picture, we can see a collagen membrane which was cut into an ice cone shape. So the membrane was then curled into an ice cone and inserted into the socket on the facial aspect and was filled with osseous bone graft material. Then a single incision technique was carried out in the palatal area, not disturbing the lingual sulcus, starting from the mesial of the canine, extending till 1/6 of the molar to the mesial of 1/6. Pedicle graft was then harvested, contoured, folded over the graft and was covered on the socket. Porous silk sutures were then placed. Results: the facial ridge contour was maintained in continuity with the natural curvature of the adjacent sides. Discussion: graft products demonstrate better results when combined with a resorbable membrane. Higher hard tissue graft yields have better reported with membrane usage. The MEI technique allows preparation of site for subsequent implant placement following soft tissue healing and hard tissue graft incorporation with the host bone, resulting in quality of bone to house the implant circumferentially. The technique may be utilized for hard and soft tissue augmentation in the extraction socket with missing labial bone, for hard and soft tissue augmentation with simultaneous implant placement, for ridge demonstrating horizontal atrophy in the aesthetic zone. Conclusion: the soft tissue deficiencies are often present due to previous recession, inadequate available keratinized gingiva, or combination of both. So the various techniques have been suggested to treat this situation with mixed results. Thus, the ME1 technique allows for simultaneous augmentation of hard and soft tissues, saving the need of costly, time-consuming second surgical procedure by maintaining the vascularity of the facial soft tissues and improving the overall graft. These are my references. Thank you.
Okay. Dr. Rashmita ma'am and Dr. Nilima ma'am, over to you.
Dr. Visas, only one question I'll ask. Is this a first kind of study? Yeah, unmute yourself. Is it a first kind of a study?
Ma'am, I'm not sure.
Am I audible to you?
Yes, ma'am.
Yeah. I just want to know, is it a first kind of study or anything new in your study?
Ma'am, this is basically the only one case report and case series have been carried out. So this was done usually in the anterior area. So we have taken the posterior premolar region. So, and a single incision technique was made so as to eliminate the any discomfort for the patient, and primary closure would be better.
Okay. 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 One thing what I liked is the shape you have given the collagen is very nice, and
Yes,
I really liked it.
Thank you, ma'am.
Okay. Over to Nilima.
Okay. Why is it called as Mivan technique?
Ma'am?
Why is it called as Mivan technique?
Ma'am, I thought it is.
Hello. Yeah. Am I audible now?
Ma'am, I can't hear. Hello?
Yeah. Am I audible now?
I am not, ma'am, you're not audible.
I can hear you. You can't hear me?
Ma'am, I'm just... Yes, ma'am.
Yeah. Can you hear me now?
Yes, ma'am. That's
okay. So why are you calling it as Mivan technique?
Ma'am, it's a modified interpositional vascularized autogenous neogenesis vascularized. So, ma'am, in this technique, we are augmenting the hard tissue and the soft tissue as well, and taking a pedicle connective tissue graft over the socket so as to maintain the width and contour of the socket.
Okay. Since this was a premolar region, it was easy to mobilize a connective tissue graft. What if it was in other region or in the mandibular area? How will you mobilize a graft? Or will you use
the literature says it's only done in the maxillary region and not in the mandibular region. And we have taken the incision from the anteriors, from the anterior section, so as to avoid injury to the greater palatine as it is towards the posterior. So we have taken the incision from that.
Okay, and you don't have a post-op picture?
Ma'am, actually, no, ma'am. Actually, this was the objective was only at the baseline only to check the contour of if we have maintained it well or no. But post-operatively, yes, ma'am, I have evaluated the patient, and the healing was also uneventful. And
yeah,
there was,
even we would have appreciated if you
yes,
had
ma'am. Yes, yes, ma'am. Yes, ma'am. It was like just recently I had carried out the procedure, so
okay, we understand. Yeah.
Okay.
Thank you.
Thank you, ma'am.
When did you do the follow-up, Vishas?
Ma'am, I'm going to carry out the follow-up at 1 week, 3 weeks, then 1 month, 3 months, and 6 months.
Okay.
So I'll have a follow-up of all the records.
Okay. Thank you.
Thank you.
Thank you.
Okay, thank you, Dr. Visaj, for the wonderful presentation.
Thank you,
We can now move to the last presentation of this session by Dr. Ranjan and Akanksha Dubey.
Hi everyone, I'm Dr. Regina Rajan. Today I'm going to present my paper presentation topic on conservative retrieval of implant abutment screw fracture, a case report. To introduce, dental implants have become widely recognized and highly effective for the treatment of missing teeth. The success rate of osteo-integrated dental implant is high, that is above 90% of treatment modality, which is not free of complication, and dental implants sometimes fail. Implant-related complications are divided into mechanical, biologic, aesthetic, or phonetic complications. Coming to mechanical complication, which comprises mainly of problems of retention, framework of fractures, crown fractures, screw loosening, and screw fractures. A 5-year period study has shown that incidence of fracture of abutment screw is 3.9% and loosening of abutment screw is 6.7%. One of the most frequent mechanical complication is abutment screw loosening, which is followed by a screw fracture and which have a common causes like ill-fitting superstructure, bruxism, or overloading. For management of fractured screw, several techniques have been described for screw retrieval. In some cases, the only solution for the abutment screw fracture is removing the implant itself, and in majority of these cases, additional surgical procedures might be needed. Fractured end can be retrieved and replaced by a new abutment screw, but sometimes it cannot be conservatively removed using rotary instruments wherever internal threads of the screw may be damaged. Coming to the aim of this case report is to the present and alternative simple method for retrieval of fractured implant abutment screw. Materials and method: a 56-year-old female patient presented to Department of Periodontics, Krishnadevaraya Dental College, Bangalore, with a dislodged healing abutment in mandibular right first molar implant crown. The patient stated that implant was placed 1 year back and was restored using cement retained metal ceramic crown. On clinical examination, revealed that implant head was completely covered over the soft tissue and there is a suppression present. Radiographic examination further confirmed the presence of a fractured abutment screw with no indication of any damage to implant body, and there is evidence of marginal bone loss. After anesthetizing the area, a horizontal incision was given on the most fluctuant area and pus was drained by using curette. Implant exposure, which was done using the diode laser of 810 nanometer wavelength, which is inserted at the center of the site and worked in a spiral pattern outward until the entire cover screw is exposed. Then curette is used to loosen the tissue over the cover screw. So this is the picture which shows the implant has been exposed during the by using the laser. After locating the site of screw fracture, the implant body was meticulously cleaned using an air water spray from the 3-way syringe and dried with air. The piezoelectric ultrasonic scaler tip was placed on the relative on the top surface of the abutment fractured screw. The scaler tip was held firm on the top surface of the fractured fragment, and the oscillations were started with minimal power and copious irrigation. When the vibrating scaler tip contacted the top surface of the screw, a moderate reverse torque was applied alternatively, so that the fractured abutment fragment, which will spin out from the implant body. As the fractured abutment screw fragment started loosening, the tips contacting the screw fragment was gradually decreased, and the loosened abutment screw was then picked up by the tweezer. So this is the fractured abutment screw which has been taken. Using the air water spray, the internal surface of the implant was again cleaned. The new abutment was then fried and was tightened to the implant body with a screw, and the previous existing prosthesis was placed. So this is after the same existing prosthesis was placed. The patient was instructed on the use of 0.12% chlorhexidine mouthwash, and systemic antibiotics such as amoxicillin and metronidazole was also given, and was seen periodically for provisional oral hygiene maintenance during the follow-up period. Coming to result, the final results were aesthetically satisfying with corresponding gingival margin. The tissue surrounding the implant was thick, healthy, and there is reduction of bone loss also evident. This picture shows the periapical radiography of the implant on the third tape. There is a little reduction of bone loss is seen, and this is after a 1-month follow-up where the tissue it is healthy and the tissue has been covered up properly. Coming to discussion, reasons of screw fracture have been known as inadequate tightening, adverse occlusal forces, and fatigue character and yielding strength of the screw material. According to the MISH, fracture of screw can be prevented by confirming adequate fit of the prosthesis, avoiding excessive angulation of implant to occlusal load, using the correct fixation screw, Avoiding occlusal overload of the process is applying recommended screw tightening torque with a torque range and reinforcing periodic maintenance. Bandari et al. Has used piezoelectric scaler on low combined with the reverse torque speed. So he concluded that screw being an inclined plane will unthread when subjected to continuous vibration. Satwalkar et al. Has studied instrument modification in which modified spoon excavator and he made a slot in screw fragment to back out a broken screw. He concluded that the management of such complications has given rise to several techniques to address failing. Barbosa et al. Has given instrument modification, which is used explorer to rotate fragment counterclockwise and then press the cotton swab into the implant head and rotate counterclockwise. This procedure allows the screw fragment to be retrieved without the risk of damaging or altering the surface characteristics of the component. This technique is cost effective, simple and applicable to all implant systems and can be effectively incorporated into those clinical situations in which broken screws are not retrievable by conventional techniques. To conclude, the new implant replacing it should be as wide as possible with a due examination and modification of the occlusal forces in order to avoid overload. This clinical report described the management of an implant abutment screw fracture using an unconventional technique, simple armamentarium, and non-invasive method of the procedure to the patient. These are my references. Thank you.
Dr. Nirima ma'am, I'm Dr. Ashwita Naik ma'am. The mic is all yours.
Yeah. Rezana, right? Your name? Okay, Rezana, just tell me one point, like one takeaway point in your presentation. One takeaway point we need to remember forever. Just tell me one point.
Just one point, the limitation of this study is like, ma'am, I have not followed up with the X-ray after 1 month, ma'am. So that is one of the limitation of this study, ma'am.
So tell me one strength.
It's like the implant exposure, it was done by using the laser, ma'am, and just we have to see the laser healing also, ma'am. So because of that, it has been done the implant exposure, ma'am, by using the laser.
Okay. Okay, Nilima.
Yes, sir. Why do you call it as a conservative retrieval? Is it because of laser or because of the piezo scaler you are using?
Because of the piezoelectric and the laser, ma'am. Because piezoelectric, I mean the ultrasonic scaler, it is used because it will conserve. It is a conservative method, ma'am, and it is used mainly for easy retrieval, as well as it completely eliminate the need to create the slot, ma'am.
Okay, does it have any effect on implant stability?
Implant stability, the result, the report of my study, it just shows the implant stability is stable only, ma'am.
But that was after 1 year. What if the osseointegration has not taken place and there was a screw fracture? So does your piezo have any effect because of the vibration?
It has effect, right?
How much time does it take for with your method? How much time did it take?
It took 30 minutes, ma'am.
For 30
because
minutes
it was
the vibration.
No, ma'am. It was like not continuously. We were not using a vibration. Like at a 5 minute, we were using the vibration.
So within 5 minutes, you could retrieve the screw.
Yes, ma'am. Then we were using the explorers and all to take it out, ma'am.
Okay. Oh, thank you. That's all.
Okay. Thank you, Asit. Thank you, team. Thank you, Nilima. Nice to see you
Thank you,
after a long
ma'am.
time.
Same here, ma'am.
Yes.
Thank you so much, ma'am.
Okay. Thank you. Thank you.
Thank you, Nilima ma'am. Thank you, Rashmita ma'am.
Thank you, Asit. Thanks a lot for this opportunity.
Yeah. Thank you. Thank you, Asit.
With this, now we have come to the end of the 7th session. Now we will begin the 8th session, the last session of today. Let's see. I may introduce the chairperson of this session, Dr. Manoj Kumar. He is a reader from Department of Periodontics, Institute of Dental Science, Bhubaneswar, Odisha. Along with him is Dr. S. Shyamsundar. He is reader from Chhattisgarh Dental College and Research Institute, Chhattisgarh. To all the chairperson, I may remind them there should be a strict panel of the judging session, and the time limit should be included to 2 minutes only. The first paper of this session is by Dr. Ridhima Uppal.
Greetings to all the respected judges present in the room. Myself, Dr. Ridhima, and I am going to present a case of mine on this prestigious platform of ISP on a case of root coverage for multiple gingival recessions using Zucchelli's technique. So we all know that gingival recession, it is defined as the apical displacement of the gingival margin in relation to the cemento-enamel junction. And the occurrence in the interior regions of the oral cavity, it leads to compromised aesthetics. This being a concern of the patients, they demand cosmetic correction, and meeting their aesthetic and functional demands remains a major therapeutic challenge. Coronally advanced flap is the first choice of surgical technique because it provides us with optimum root coverage, a good color blending, and a good recovery of the original soft tissue morphology. It was in 2000 that a Zucchelli's technique, a modification of the coronally advanced flap procedure, was introduced by Zucchelli and Santis so as to treat multiple recession defects of the affecting the adjacent teeth in a one single stage surgery. And the involvement of the incorporation of the microsurgical approach by the use of the microsurgical instruments, the magnification loops, it helps us in refining the basic surgical techniques by improvement in visual acuity, passive wound closure, and minimal tissue trauma, thus increasing the clinician as well as the patient acceptance. It was Cortellini and Tonetti who introduced the concept of minimally invasive surgical technique, which stresses upon the primary wound closure for the protection of the blood clot. So this is the armamentarium which I used. I own a magnification loop from Carl Zeiss. I use the microsurgical blades, micropapilla elevators, microsurgical tissue holding forceps, microsurgical needle holder, microsurgical Castroviejo scissors, and 50 Vicryl sutures. So a patient 45 years of age, he reported at the outpatient department with a chief complaint of unpleasing appearance of the teeth in the upper front region. And before surgery, a proper case history was recorded, a complete hemogram was done, plaque index and bleeding index were recorded, and we recorded the recession depth, the width of the recession defect, the probing depth, and the width of the keratinized tissue with the help of the UNC 15 periodontal probe. So these are the preoperative photographs which we took, and the first two photographs they depict the width of the gingival recession. The bottom two photographs they depict the depth of the gingival recession. In this slide, the first two photographs they depict the width of the keratinized gingiva, and the bottom two photographs they depict the measurement of the probing depth. And after the initial examination, the patient was given proper oral prophylaxis and oral hygiene instructions. A coronally directed roll brushing technique was advised so as to minimize brushing trauma to the gingival margins. And once the adequate supragingival plaque control was achieved, surgical treatment was scheduled. So to start with the surgical procedure, the first was the incision. The incision design is such that it consists of the horizontal incision, including the oblique submarginal incisions in the interdental areas, continuing with the intrasulcular incision at the recession defects, thus providing us with an envelope-shaped flap. The flap was elevated and de-epithelialization of the anatomic interdental papillae was done. Now the interdental papillae, it is not because of this incision, the interdental papillae, they are divided into two parts. One is the anatomical papillae, which are present in the interdental area, and the portion of the interdental papillae which goes with the flap is the surgical papillae. After the reflection of the flap, so as to increase the mobilization of the flap, a vestibular releasing incision was given. Root biomodification was done using tetracycline liquid, and
Suturing was done after the flap approximation with the help of the 5-0 Vicryl sutures. Post-operatively, infection control was achieved by instructing the patient to use chlorhexidine mouthwash 0.12% twice daily for 1 week. Sutures were removed after 14 days, and plaque control was instructed to be maintained with the help of the chlorhexidine mouthwash only for another 2 weeks. After 2 weeks, the patient was instructed to start with the mechanical cleaning of the area with a soft toothbrush using the roll technique. So this is the picture which we took after 14 days, and this is the post-operative photograph after 3 months. So if we had compared the pre-operative photograph with the post-operative photograph after 3 months, we can clearly see that there is an increase in the width of the keratinized gingiva, as well as a good coverage of the recession defects has been achieved. On an average, a 2 mm of root coverage was achieved in this case. So to conclude, I need to emphasize on the incorporation of the magnification in the dental practice because it helps us in improving the visual acuity. It provides with ergonomic benefits, decreases the patient morbidity, provides us with rapid healing and an enhanced patient acceptance. Also, the Zuchelli's technique, it has an advantage that it does not allow the damage to the blood supply of the flap because the vertical releasing incisions are not there. It helps in providing stabilization of the gingival margins, which is critical for the success of the surgery. This technique also helps in maintaining the blood supply to the surgical papilla in the interproximal areas, and it provides coverage to all the gingival defects to be corrected simultaneously in one single go, thereby placing the soft tissue close to the defect themselves. Thank you, sir.
Okay, Dr. Manoj sir and Dr. Shamsundar sir, you can proceed with the question answer session now.
Yeah, Dr. Ridhima, nice presentation.
Thank you, sir. Good afternoon, sir.
Good afternoon. Just two questions. First of all, what was your aim in this case? Was it gain of attached gingiva or root coverage or both?
Sir, no, attached gingiva was sufficient, but the patient had because of the faulty toothbrushing technique, he had a lot of gingival recessions in the interior region. So the complaint of the patient was that it was unaesthetic for him. So the idea was for the coverage of the recession defect, so as to
but as I could see in the post-operative photograph in 1.2 and 1.3, I think you have not achieved complete root coverage, if I'm not wrong.
Yes, sir. In 1.1, I could not. Much of the root coverage has not been achieved, and I studied about it. And the reason behind it that the enamel defect, there is presence of the enamel defect there, with a step of more than 0.5 mm. So for that case, there was a study done by Pini Prato in 2010, I think. And he said that because of the presence of the enamel defects, complete root coverage cannot be achieved. So I have to do the restorative part over there, sir.
Okay, fine. Thank you.
Welcome, sir.
Ridhima, good presentation.
Good afternoon, sir. Thank you.
Good afternoon. What is this submarginal incision? You placed one submarginal incision.
Sir, for the Zuchelli's technique, this is a particular incision design where the submarginal incision is that we are not involving, the margin, the gingival margin, but I am placing an oblique incision in the interdental papillae starting.
So submarginal incision will help you to prevent what exactly?
Sir, it will help me prevent maintain the anatomy of the interdental papillae.
Okay, very good. Okay, nice presentation. Done, sir.
Thank you, sir.
Okay, thank you, Ridhima. We can now move on to our next presentation by Dr. Tapasvi Kamble and Dr. Shivani Nandekar.
Good morning, dignitaries. My topic for paper presentation is Management of Miller's Class 1 Gingival Recession Defect using Coronally Advanced Flap with Human chorion membrane and platelet-rich fibrin membrane. Gingival recession is the apical migration of gingival margin to the cemento-enamel junction. This can appear as localized or generalized. The main goal of this periodontal surgical procedure is to obtain complete root coverage and optimal aesthetic appearance. In 1985, Miller gave the classification of gingival recession based upon anatomic features, prognosis, and treatment. Class 1 is recession that does not extend the mucogingival junction with no periodontal bone loss in the interdental areas. Class 2, recession that extends to or beyond the mucogingival junction with no interdental bone loss. Class 3 is recession that extends to or beyond the mucogingival junction with some periodontal attachment loss in the interdental area or malpositioning of the teeth. Class 4 is recession that extends beyond the mucogingival junction with severe bone loss and soft tissue loss in the interdental area and severe malpositioning of teeth. Coronally advanced flap is commonly used approach for root coverage, and it has been demonstrated very good results in treating localized gingival recession both in terms of root coverage and aesthetic outcomes. Platelet-rich fibrin is second-generation platelet concentrate. It has natural healing properties and has following effects such as providing mechanical support and protection to graft material. It provides fibrin network which helps in cellular migration of endothelial cells and release of various growth factors such as prostaglandin growth factors, transforming growth factors, insulin growth factors, and endothelium-derived growth factors. And it thus facilitates healing. Placental allografts possesses antimicrobial and antibacterial properties and have shown to reduce inflammation and provides a protein-rich matrix. Chorion membrane has shown to reduce scarring and inflammation, enhancing wound healing. It acts as a scaffold for proliferation and differentiation of cells due to its antimicrobial properties. This is a case in which a 38-year male patient reported with hypersensitivity since 2 months. The oral examination showed class 1 gingival recession in respect to 1-3. The diagnosis was made according to the new classification published in 2017. It is generalized gingivitis with localized periodontitis in relation to 1-3 stage 1 grade A. The treatment plan was phase 1 scaling and root planing, 0.2% fluorhexidine mouthwash, and oral hygiene instructions. Phase 2 is root coverage procedures, and phase 4 is recall for follow-up. These are the clinical pictures which shows the incision for coronally advanced flap, in which a horizontal incision was made, then 2 vertical incision was made at the nasal and the distal extremities, and the full thickness mucoperiosteal flap was raised till mucogingival junction. After the flap reflection, 2 into 2 cm of human chorion membrane was placed, and then suture was placed and non-eugenol periodontal plaque was given. These are the postoperative picture after 1 week and postoperative picture after 6 months. The treatment outcome shows significant results in the terms of clinical attachment level, recession height, recession width, gingival tissue thickness, and width of ketonized gingiva at 6 months from baseline. In case 2, 42-year male patient reported with hypersensitivity since 3 to 4 months with no relevant dental and medical history. Oral examination showed class 1 gingival recession in respect to 1-3. Diagnosis was made generalized gingivitis with localized periodontitis stage 1 grade A. The treatment plan was scaling and root planing, 0.2% chlorhexidine mouthwash, oral hygiene instruction in phase 1, root coverage procedure in phase 2, recall and follow-up in phase 4. These are the clinical pictures which shows incision of the coronally advanced flap. The surgical procedure was same that was carried out in chorion membrane case. After the flap reflection, platelet-rich fibrin membrane was placed and suture was given, after which a periodontal pack was given. Postoperative after 1 week picture, and this is a postoperative after 6-month pictures. The treatment outcome showed good results in terms of clinical attachment level, recession height, recession width, width of ketonized gingiva, gingival tissue thickness at 6 months from baseline. These are the preoperative and postoperative pictures which shows the measurements in regards to clinical attachment level, recession height, recession width, gingival tissue thickness, and width of catenized gingiva. Discussion. Janice et al. Does a case series which indicate a stable result at 6 months with the use of chorion membrane and showed a reduction in probing depth along with a gain in clinical attachment level, which could be attributed to the regenerative potential of the membrane. Pundir Ajan et al. In 2015 used chorion membrane and showed improvement in the recession height at the end of 6 months. Padma et al. In 2013 stated that coronally advanced flap is a predictable treatment for isolated Miller class 1 and 2 recession defect. The addition of platelet-rich fibrin membrane with coronally advanced flap provides superior results in aspects of root coverage with addition benefits of gain in clinical attachment level and width of catenized gingiva at 6 months postoperatively. Conclusion. Both the chorion membrane and platelet-rich fibrin membrane have provided successful result in terms of root coverage, increased width of catenized tissue, and cal gain. This indicates that both the material are effective in root coverage. References. Thank you.
Dr. Shamsundar sir and Dr. Manoj sir, over to you.
Dr. Tapaswi, good presentation.
Yes, good afternoon, sir.
Good afternoon. So my question is, so you have used chorion membrane and PRF. So what is your opinion of these two materials in comparison with connective tissue graft, which is the gold standard?
Yes, sir. Actually, sir, connective tissue graft is a gold standard, as you have said. But connected in that, we require a second surgical site. Correct. And the patient nowadays does not undergo for, or they don't want the second surgical site. So it is beneficial to use an allograft nowadays.
Okay. And from where did you procure the chorion membrane?
So chorion membrane, it has been, the study has been done by my senior batch, and I have been assisted to her, Dr. Shivani. So she has taken this chorion membrane from Tata Memorial, Mumbai.
Okay. So it is easily available?
Yes, sir.
Okay, thank you. Dr. Shyam, you can ask.
Okay. Tapaswi, good presentation. Can you tell me different techniques? Now you used PRF and chorion membrane.
Yes.
Simple. Which one is easy to use? Means technically, practically, which one is easy to use?
So practically, I think PRF is more easy to use, as the chorion membrane, it is technique sensitive, and the thickness of chorion membrane is very less. So the membrane, it is very fragile. So it requires
handling. It is difficult to handle. Okay. Thank you.
Yes, sir.
Thank you. Okay. Thank you. Very good.
Thank you, sir.
Okay, thank you, Dr. Tapaswi.
Thank you, sir.
Tech team, can we move to the next presentation by Dr. Pankti Shah and Dr. Kevin Saraya?
Good morning to all the dignitaries and everyone present here. My name is Dr. Pankti Shah, and today I'm going to be presenting my paper on the topic Evaluation of Clinical Outcomes of Local Drug Delivery of Coenzyme Q10 Gel Adjunctive to Scaling and Root Planing in Patients with Localized Periodontitis, which is a case report. Now coming to introduction, periodontitis is an immunoinflammatory disease process resulting from the interaction of bacterial attack and host inflammatory response causing inflammation of the supporting tissues of the teeth, leading to tissue destruction and tooth loss. Free radicals and reactive oxygen species like superoxide anion radicals, hydrogen peroxide, hydroxyl radicals, and hypochlorous acid are capable of damaging either cell membranes or associated biomolecules. Periodontal pathogens can induce ROS overproduction and thus may cause collagen and periodontal cell breakdown. Coenzyme Q10 was discovered by Fred Crane and his colleagues in 1957 in beef heart mitochondria. It was first isolated from the mitochondria of bovine hearts in 1957 at the University of Wisconsin. It exists in two molecular forms, which is ubiquinone, the oxidized form, and ubiquinol, the reduced form, which are the basis for its antioxidant properties. Hence, coenzyme Q10 also functions as an intercellular antioxidant. Other than that, it has also been shown in literature that coenzyme Q10 acts as an immune enhancer and also accelerates tissue healing and plays a crucial role in the generation of adenosine triphosphate and cellular respiration. It also regenerates other antioxidants, stimulates cell growth, and inhibits cell death. Now, coming to the advantages of LDD, the major advantage that local drug delivery may potentially provide is the ability to achieve high and sustained local concentrations of drugs without large systemic doses, thus minimizing systemic toxicity, adverse reactions, resistant strains, and superimposed infections. Local delivery may employ antimicrobial agents which are not normally suitable for systemic administration. Now, coming to the mechanism of action of periocuzel, the ubiquinol serves as an endogenous antioxidant which increases the concentration of coenzyme Q10 in the diseased gingiva and effectively suppresses advanced periodontal inflammation. Due to its redox property, coenzyme Q10 functions as an intercellular antioxidant by acting as a primary scavenger of free radicals and reactive oxygen species. Coenzyme Q10 is the only endogenously synthesized liposoluble antioxidant that can participate in redox reactions, acting on the prevention of damage to DNA and proteins and on lipid peroxidation, and indirectly stabilizing the calcium channels by preventing calcium overload. The enzyme acts on lipid peroxidation by either sequestering free radicals or reducing the alpha tocopherol radical to alpha tocopherol. Now, coming to the case, a 45-year-old male patient from Madhya Pradesh visited the Department of Periodontology at KM Shah Dental College and Hospital. The chief complaint of the patient was bleeding gums and no relevant past medical history and dental history was present. On examination, the debris score was 2, the calculus score was 2 according to the oral hygiene index simplified. Bleeding on probing was present at all sites and a pocket probing depth of 5 mm was present in relation to 1.5. Also, partially edentulous upper arch was seen. Hence, we came to the diagnosis of generalized gingivitis with localized periodontitis in relation to 1.5, stage 1, grade A. Hence, the treatment plan which was formulated for the patient was, in phase 1, scaling and root planing was carried out, oral hygiene instructions were given, the patient was advised to use 0.2% chlorhexidine mouthwash, and local drug delivery with periocuzel was done in relation to 1.5. In phase 4, maintenance and follow-up was carried out. Now, the treatment given to the patient was as follows: that at the first visit, clinical parameters such as plaque index, bleeding index, pocket probing depth, and gingival index were measured, after which phase 1 therapy was carried out. After the phase 1 therapy, the patient was recalled after a week for the treatment, at which the drug was delivered in the localized pocket by using a 24-gauge syringe until some of the drug overflows from the pocket. The site was then covered with a periodontal pack for 7 days, after which pack removal was carried out. The patient was then recalled at 6 weeks for follow-up, and again clinical parameters such as plaque index, bleeding index, pocket probing depth, and gingival index were measured and compared with baseline parameters and evaluated. As we can see in the picture, the application of periocuzel was carried out in this way, after which periodontal pack was given, which was removed after 7 days. Hence, the treatment outcome for local drug delivery with coenzyme Q10 gel showed preoperatively there was a pocket probing depth of 5 mm present, as we can appreciate in the picture, which was reduced to 3 mm postoperatively after 6 weeks. Also, significant difference was seen in plaque index, bleeding index, and gingival index after 6 weeks post-operatively as compared to baseline on the treatment with local drug delivery with coenzyme Q10 gel. Hence, in this case, there was significant improvement in plaque index, bleeding index, pocket probing depth, and gingival index seen post-op after 6 weeks. A study was done by Hansen et al. In 2012 in which the clinical parameters like PI, GBI, PD, and CA were improved with the use of periocuzel as an adjunct to SRP. Another study done by Pitale et al. In 2012 showed that there was significant improvement in the clinical parameters like PI, BI, PD, and CAL when coenzyme Q10 gel was used as an adjunct to SRP as compared to SRP alone. Another study done by Chaudhary et al. In 2014 showed that application of coenzyme Q10 gel in patients with chronic periodontitis showed significant reduction in PI, GI, PPD, and RAL as compared to SRP alone. Another study was carried out by Sali TM et al. In 2016 to evaluate the effect of intra-pocket application of perio-Q gel alone as an adjunct to scaling and SRP on periodontal clinical parameters. And it was seen that the better improvement was seen in clinical periodontal parameters by using Q10 gel in combination with SRP as compared to SRP alone. Hence, we can conclude that a significant improvement was seen in plaque index, bleeding index, pocket probing depth, and gingival index in post-op after 6 weeks. Also, no side effect was noted in the patients after receiving perio-Q gel as local drug delivery, and it is also a cost-effective treatment for patients who are suffering from localized periodontitis. Hence, local drug delivery with Q10 gel can be used in the treatment of isolated periodontal pockets as an adjunct to SRP. These were my references. Thank you.
Dr. Shamsundar sir and Dr. Manoj sir, you can proceed with the question answer session now.
Yeah, Dr. Pankti, good presentation.
Good afternoon, sir. Thank you so much.
Good afternoon. My question is, since you have done only for a localized site, how do you justify that the pocket reduction was because of the gel? It can be because of scaling and root canning as well.
Sir, I have found various studies online which showed that whenever they were using scaling and root planing, perio-Q gel as an adjunct to scaling and root planing, better results were seen as compared to SRP alone. Also, when after doing SRP, the patient was called after 1 week so that in order so that the proper healing could be seen. And after that, only perio-Q gel was delivered locally to the patient. And based on the different results which are found on the studies, and based on that, we decided to give it as a locally perio-Q gel locally.
That is fine. What I'm telling you, see, even if you do a scaling and root planing in a 5 mm pocket, it will definitely reduce to 3 mm. So what I'm telling is, what you could have done, you could have done a split mouth study. You could have done only SRP in one side of the mouth and SRP with that gel on the other side. Then probably you could have got a better reference. That is my question, right?
Yes, yes, sir. Correct, sir.
Okay, okay. All the best. Thank you.
Thank you, sir.
What is your name? Pankti Shah. Pankti Shah,
Yes,
nice.
Dr.
Present,
Pankti.
nice.
Thank you, sir.
Okay, can you tell me the standard regimen? How many times you should use this perio-Q gel? There is no standardization, I feel.
No, sir, there is no standard any variation given for using perio-Q gel. It is still undergoing different studies are still being done on that. In our study, what we did was the perio-Q gel was locally delivered only once after 1 week after SRP, and after 6 weeks we checked the parameters and the results were.
Okay, only once, then your pocket depth reduced from 5 mm to 3 mm.
Yes, sir.
Okay, thank you. Very good.
Thank you, sir.
Okay, thank you, Pankti.
Thank you, sir.
We can move to our next presentation by Dr. Richa Peshave and Dr. Nikki Upadhyay.
Good morning to all the dignitaries present over here. I'm Ranjan and the topic for my paper presentation, which is a case report, is degeneration of periodontal osseous defect using an allograft, that is a demineralized freeze-dried bone allograft. Periodontal disease resolves not only because of primary etiological factors, but some secondary factors like trauma from occlusion, which plays an important role in its pathogenesis. It alters the morphological features of the bone in addition to reducing bone height. McCartan and Beanman in 1954 and Glickman and Wimby in 1962 and 1965 stated that occlusal forces may alter the path of spread of gingival inflammation and thereby facilitate penetration into the periodontal ligament, enhancing the angular bone resorption and intrabony pocket formation. Degeneration of periodontium to its pre-disease state is the optimal goal for clinician. In overall evolution of periodontal therapy, initial attention is focused upon the arrest of disease and long-term maintenance of the dentition. Osseous grafting techniques may present one mode of therapy to combination of pocket and osseous defect. They have their greatest applicability in the intrabony defect. Demineralized piece-wide bone allograft provides an osteoconductive as well as the osteoinductive factors, which induces the host undifferentiated mesenchymal cells to differentiate into osteoblasts, the subsequent formation of a new bone. It contains bone morphogenetic proteins 2, 4, and 7, which induces the new bone formation during the healing process. A 35-year-old female patient reported to the Department of Periodontology with a chief complaint of foot lodgement in the lower left back roof region since 8 to 9 months. There is a clinical photograph of the patient which depicts the occlusal wear facet and on clinical examination, it also showed a pocket probing depth of 7 mm, which was recorded with the help of the UNC 15 code. This is a radiograph of the patient which showed a vertical bone defect in the mesial aspect of 3-6. So the diagnosis, according to the World Workshop classification of 2017, was made as localized periodontitis stage 3 grade with respect to 3-6 and a traumatic occlusion with respect to 3-6, and otherwise there was a healthy, normal healthy periodontitis. So the treatment plan that was formulated for the patient was therapeutic scaling and the root planing was given, and curettage was performed. Oral hygiene instruction was given. Coronoplasty was done by reducing the medioclusive and lactoclusive prematurity and occlusal disharmony. All the contact relationship was rechecked with the help of the articulating paper, and all the surfaces, deep surfaces were polished. Then, followed by the phase 2 therapy, in which token flap realignment with the regenerative procedure was done, and the patient was then kept on the maintenance therapy. Technique. So, moving on to the technique, internal level incision followed by the circular internal incision was given. Then the full thickness flap was raised, which revealed the two-wall osseous defect, keeping the buccal and distal bottom intact. Then open flap debridement was done. After that, the buccal plate was filed with the help of the Schumann file, and then demineralized piece-wide bone allograft was placed. Here, the bone graft that was used was from Tata Tissue Bank. Then the simple loops sutures were given, and the periodontal pack was given for 14 days. This is the follow-up photograph that is after 6 months of the patient, which showed the pocket depth of 2 mm, which has been reduced. This is a picture showing the preoperative as well as the 6-month follow-up photograph, which showed the pocket depth has been reduced from 7 mm to 2 mm. This is a picture showing the difference between the IOTA, preoperative IOTA, and the 6-month follow-up IOTA, which showed that the vertical defect has been obliterated in the 6-month follow-up. Paulus GM et al. In 1989 conducted a study on histological evaluation of new attachment apparatus formation, stated that the formation of new attachment apparatus is significantly more in intrabony defects grafted by DF-EBA than the non-grafted defects. Reynolds et al. In 2003 also conducted a study on efficacy of bone replacement graft in the treatment of periodontal osseous defect, stated that DF-BBA supports the formation of new attachment apparatus in intrabony defect. Shah and et al. In 2015 conducted a study on comparative evaluation of paper bridge chitin with demineralized piece-type bone allograft in periodontal intrabony defects, stated that DF-BBA as the most extensively evaluated graft material for the treatment of intrabony defects. Mehta DB et al. In 2018 has done a study on comparative evaluation of paper-rich pipeline, membrane, and collagen membrane, along with demineralized freeze-dried bone allograft and grade 2 furcation defects. He also stated that it showed a significant and consistently better gain in bone fill with the use of DFTBA as compared to the open flap development alone. So, at last, I would like to conclude that trauma from occlusion plays a crucial role in the progression of periodontal disease. Hence, etiologic therapy should be performed first, followed by the defect management using a bone graft like DFDBO, which demonstrated substantial clinical and radiographic improvement. Allografts can function as both osteoconductive and osteoinductive scaffold, making them a useful treatment modality for the periodontal regenerative cases. These are my references. Thank you.
Okay, Dr. Manoj Kumar sir and Dr. Shyam Sundar sir, you can have the mic now.
Dr. Shyam, you want to add something?
Yes, sir. How did you diagnose traumatic occlusion in relation to 3-6?
Sir, with the help of the occlusion facet was present, with the help of the wear facet that is seen in the occlusal surface, and also with the help of the radiograph, which showed at the alveolar crest, the funnel-shaped appearance was seen.
Okay, where facets clinically and radiographically?
Radiography funnel-shaped.
Okay. Why did you choose DFDBA?
Sir,
Any reason?
yes, sir. As demineralized freeze-dried bone graft has shown both osteoconductive as well as osteoinductive properties, which because of which it has the capability of producing the bone morphogenic protein, which is known to cause in initiating the bone formation during the healing phase.
Okay. Oh, very good. Nice presentation.
Over
to you, sir.
Yeah, Dr. Richa, good presentation.
Yes, thank you, sir.
I want to ask you, what are the drawbacks of using an allograft?
Sir, the main contraindication of using the allograft are first, if the suppose the host site, if he or she is suffering from any diseases, that is contaminated diseases, so it can be transferred through it, and also it has known to cause some allergic reactions.
So what will it lead to if there is any allergic reaction? Graft rejection, right?
Yes, sir, graft rejection.
And one more thing, why didn't you use it, since it was an isolated site, why didn't you use a GTR membrane on top of the graft? Did you use or you didn't?
No, sir, we didn't use a GTR membrane.
Ideally, you should, right? Because it's an isolated defect anyhow, but you got a good result clinically as well as radiographically.
Yes, sir.
Okay, thank you.
Thank you, sir.
Thank you, Dr. Richa.
Thank you, sir.
We can now move on to the last presentation of the last session of today. The presenter is Dr. Salil Joshi.
Jai Hind and a very good morning to everyone. I, Dr. Salil Joshi from the Department of Odontology and Implantology, Subhadhi Dental College and Hospital, Meerut, is here to present my paper on the effect of selected fibrin in enhancement of soft tissue healing around dental implants, a case report. To begin with the introduction, the objective of dental implantology is to restore missing or extracted teeth by placing implants in anatomically, aesthetically, and long-term functional position. Edel et al. In the year 1981 stated that 0.9 to 1.6 millimeter of marginal bone loss occurs around implants by the end of first year, and 0.5 to 0.13 millimeter occur during each subsequent year. Albrechtsen et al. In the year 1986 stated that a vertical bone loss of less than 2 millimeters is acceptable in the first year after implant placement, followed by a maximum of 0.2 millimeter annually thereafter. Lindvik et al. In 2009 and Bhatt et al. In 2014 demonstrated the importance of soft tissue biotype on crestal bone changes and maintenance of implants. And they concluded that more bone loss is seen in cases of thin soft tissue biotype as compared to thick soft tissue biotype. Thus, over time, various modalities have been used to reduce bone loss around implants, which influence both soft and hard tissue. Few of these are macro and microscopic design in implant modification, surface alteration, platform switching, use of growth factors and biomaterials around implants. So when we talk about platelet concentrates, they are basically an autologous source of growth factors like the vascular endothelial growth factor, the endothelial growth factor, the platelet-derived growth factor, and the transforming growth factor beta that are released in large amount upon activation of platelet granules. Platelet concentrates can be broadly classified into the three generations. The first generation is the platelet plasma, the second is the platelet fibrin, and the third generation is the titanium prepared platelet fibrin. In this case report, we have used the second generation, that is the platelet fibrin, the PRF. It was developed by Chokran et al. In 2001 in France. It is an autologous reservoir of growth factors which accumulates platelets and cytokines in a physiological fibrin clot. Coming to the method of preparation, 10 ml of venous blood is collected into a test tube and is centrifuged at 3000 rpm for 10 minutes, thereby separating the blood into the three components. The top layer consists of the acellular plasma, the middle layer consists of the fibrin clot, and the bottom layer consists of the RBC base. The acellular plasma is then discarded and the fibrin clot is separated from the RBC base to obtain the PRF. Thus, the aim of this case report was to evaluate the response of PRF as a barrier membrane in soft tissue healing around dental implants. Moving on to the case report, a 47-year-old male patient reported to the Department of Odontology and Implantology, Subhati Dental College and Hospital, Meerut, with the chief complaint of missing tooth in lower right back region of the mouth. Upon examination, the patient was found to be physically fit with no apparent medical condition. Intraoral examination revealed a missing mandible of first right molar with adjacent tooth intact. There was sufficient bone width, height, and inter-arch space present at the missing site. Implant placement was advised to the patient after careful evaluation. The patient was explained about the procedure and informed consent was obtained. Preoperative medication was started 1 day prior to the surgery in the form of antibiotic, probiotic, and antacid. Moving to the surgical procedure, this is the preoperative view of the patient. And after anesthesia, a subclavicular incision was given on the buccal side using a 12-number plate. Then a full thickness mucoperiosteal flap was reflected. Then with the help of a lance drill, initial punch hole was made at the center of the operating site, which was then gradually enlarged using drills of various diameters in a sequential manner to prepare the osteotomy site. Here is a clinical photograph of the prepared osteotomy site. After preparation, an Alpha Bio SPI implant was placed at the osteotomy site. Coming to the method of preparation of PRF, 10 ml of patient's venous blood was collected and injected into a plain test tube without any anticoagulant and was sent for centrifugation using the above protocol. Upon centrifugation, the blood was separated into 3 layers, then the acellular plasma was discarded, and the PRF clot was held with the help of forceps and separated from the RBC base with the help of a pair of scissors. The PRF clot thus obtained was then compressed between the 2 glass slabs to obtain the PRF membrane. The PRF membrane obtained was then shaped and trimmed according to the surgical site, and was gently placed onto the surgical site and stabilized so as to cover the implant and the surgical site completely, thus forming the barrier membrane around it. The flap was then approximated and sutured with the help of 30 PGLA sutures. This is the post-operative view of the patient at 2 months, and we can see the amount of healing that has taken place. After the 3 months, the patient's final prosthesis delivery was done, and this is the RVG of the patient at the time of crown delivery. Now moving on to the discussion, HEL et al. In 2009 stated that PRF has the capability to gradually release autologous growth factors with a stronger and durable effect on cell differentiation and proliferation. Onko et al. In 2015 concluded that PRF application results in improved implant stability in the early healing period after implant placement. Tomar et al. In the year 2016 concluded in a case report that PRF membrane, when used as a palatal bandage, reduces the post-op complications associated with the pregingival graft donor site and accelerates the healing process. Fabrice et al. In a case study concluded that PRF may enhance the post-insertion stability of dental implants placed in the posterior maxilla within the healing period. Thus, To conclude, PRF membrane releases a cascade of growth factors at the surgical site that reduces the post-operative pain and complication associated with the implant, thereby accelerating the healing process. Thank you.
Okay, Shamsundar sir and Manoj sir, you can have the question answer session.
Dr. Salil?
Sir.
Yeah, good evening. My question is, in the initial part of your presentation, you told about methods to prevent bone loss around implants. And your topic is soft tissue healing. So I'm getting confused. Why was that introduction given?
Actually, sir, was not the, actually the reason was that bone, the rationale for using PRFs, the rationale has been accepted that PRF can be used around implants. And the modalities that have been used to reduce the main actually the main reason is to determine the success of an implant is osseointegration.
Right.
So most of the studies that have been done till date are done to evaluate or increase the amount of state to reduce the marginal bone loss. So just to introduce the topic to pediatric the why we use the growth factors, that part was explained.
Okay, so what was the purpose of using PRF in this case? Because you, as you told, there was sufficient width, height, everything of bone. So
actually, this the patient had a thin periodontal biotype in the beginning that we had evaluated, and it was a standalone case. This is the only case that was done in our department that we have used PRF in the implant, as to cover the implant after placement. Earlier, the studies that we have done in our department, in that we have coated the implants with the PRF membrane and they were inserted. And in one case, we have used the PRF release aid. So all those studies were done to enhance the bone level. And because this case was done recently, so the only result that we were able to obtain within a short period of 3 months was of the soft tissue. We couldn't, because to comment anything about the bone loss, we have to evaluate the case for a maximum period of minimum like 12 months is necessary before we can comment anything regarding the bone loss, whether the use of this modality had a good effect on bone loss or not.
Okay, fine. Thank you. Thank you.
Salil Joshi, did you place that implant? So I was assisting in that case. Okay, no dimensions. I didn't hear any dimensions of the implant. The implant was of 3.75 into 11.5 millimeters. The purpose of placing, same question, the purpose of placing PRF is to increase soft tissue or retain soft bulk of the tissue or better osseointegration. Yes, sir. What was it? Both, one, anything? I didn't get it. So actually, the main purpose was, it was actually both. The primary reason why we use the PRF membrane was to increase the bulk of the soft tissue. Okay. Thank you. Thank you.
Okay, thank you, Dr. Salil. With this, we now come to the end of our marathon of the paper presentation for today. I cordially thank Dr. Manoj Kumar sir and Dr. Shamsundar sir for taking out their valuable time and being a part in this first ever kind of PG convention in the virtual platform and being as the chairperson. Thank you, sir.
Thank you very much. Yeah, and I also take this opportunity. I also want to take this opportunity to thank the ISP organizing team for putting up a wonderful show and giving us an opportunity to be the chairperson. Thank you.
Okay, sir. I thank ISP PG convention for giving me this opportunity to participate. Thank you, sir, for considering me. Thank you, sir. Manoj, sir, I disturbed you a lot.
No, it's fine. Thank you, Dr. Sham. And congrats to the organizing team as well as the tech team. They have done a wonderful job.
Wonderful. Okay, sir. Thank you. Bye-bye. Good day.
Bye.
Yes, sir. Goodbye, sir.
Can we leave or we can leave?
Yes, sir. Yes, sir. I also thank the backend team and tech team of Vama Dental College. Thank you so much for your support. We can continue tomorrow at 9 a.m. Thank you so much.
So now can we end the meeting?
Yes. Thank you.
Okay. Thank you so much.